Natarajan sir, please start.
Yes. So good afternoon and good evening to all, and good morning to rest of the world. And on behalf of Asia Pacific Ophthalmic Trauma Society, I have the great privilege to welcome you for our fifth virtual conference. So I'll share my screen. So this is our fifth APOTS virtual conference to be held today and tomorrow, September 5th and 6th, 2020. It's an international ophthalmic trauma scientific feast on integrated care of APOTS, by APOTS, for APOTS, and all the entire global community. And as I was a child, I was assisting my dad when I was in the government ophthalmic eye hospital quarters, where I put torch for him to remove corneal foreign bodies. I got the passion for managing ocular trauma later. I joined the Shankarnath, and then it is the history. So coming to our Asia Pacific Ophthalmic Trauma Society, we present you the fifth APOTS virtual conference, a meet focused on all aspects of ocular and adnexal trauma. That's why we call it ophthalmic trauma, and a comprehensive curriculum ranging from basic to advanced topics in ocular trauma, covering diagnosis, medical management, strategies, surgical concepts and techniques, and rehabilitation presented by global experts. So I just want to take you through the history, and I always call this history as high story, and I see everything, and even Isaac Newton and Charters have mentioned that only because of history, where the tall stalwarts, we have our founding member of Ocular Trauma Society, Dr. B. Shukla, in our panel today, and also the president of Asia Pacific, the Ocular Trauma Society of India, Dr. Shukla, and Dr. Ferram Spoon is also part of this, and Dr. Azad and many others from trauma, where they are tall stalwarts and who's on the tall structure, the figures, we as a dwarf stand on them so that we can look beyond. So that's how the Asia Pacific Ophthalmic Trauma Society was planned by myself and Dr. Professor Azad, joined by Dr. Carolyn Chi, Dr. Gangadhar Sundar, and Rupesh Agrawal. And it happened, and when we started the thinking in 2009 onwards and 2011, the APOTS was born. And thanks to Dr. Gangadhar Sundar, we insisted from ocular we should have it ophthalmic, because ophthalmic includes the globe as well as the orbit and adnexa. The objective was to advance the knowledge in the field of ocular trauma, it's ophthalmic trauma, to set the tone for subspecialty care in the field of ophthalmic trauma, to formulate general guidelines through evidence-based medicine. And the mission, build a network and team of eye care professionals with special interest in ocular trauma. So ophthalmic trauma will comprise of ophthalmologists, optometrists, the ocularists, and many others involved in this, and to advance the clinical care, science, and research in ophthalmic trauma. So the founding president was Dr. Professor Rajwardhan Azad, and myself as Secretary General. Dr. Hua Yan was the Vice President, Dr. Rupesh was Joint Secretary, and Dr. Gangadhar Sundar was the Chair Scientific Committee, and Carolyn Chi was Treasurer. And now, for a few years later, Dr. Azad has become President Emeritus, myself as President, Dr. Hua Yan from China as the Vice President, and we're happy. He's also the Director of the Tianjin University, apart from heading the ophthalmology. And Rupesh Agarwal is in Singapore, and we have Dr. Lingam Gopal, Councillor Raj, Dr. Gangadhar Sundar from NUH is the Chairman Scientific Committee, and Carolyn Chi is the Treasurer, who helped us to register our society in IROSIS in Singapore. And we have the council members, Dr. A.K. Grover, Dr. Andreas, Dr. Annette Hazen, who's doing her PhD from Australia, Mehul Shah, Mohan Rajan, Kakhan, Dr. Manish Bapai, Kendrick, who's now will be running the show, Dr. Rekha Kandelwal, Dr. Vivek Dave, Dr. Unia, Dr. Ilya, Dr. Veeramani, Dr. Syed Kadir Mehboob, and Dr. Shanti Visare. And we have activities where we have CMEs, collaborative studies, meetings, research, and I wanted to take you through the taking from the current to the towards 2011. And this is the fourth Asia Pacific Ophthalmic Trauma webinar, which was happened along with the Jakarta Eye Center. We have Dr. Unia and my good friend Didi, who's a very old friend, including his earlier boss, Dr. Istiantaro, and we have my fellow Dr. Rafrano here, which was done with the Jakarta Eye Center on 15th August. And we had APOTS Giridhar Eye Institute Ophthalmic Trauma, which was held a few days back, and we had the interesting videos and the also the quiz program. And we had the APOTS ISOT Advanced Ophthalmic Trauma Symposium, and again by Gangadhar Sundar, myself, and we had almost 6 sessions, and thankful to the International Council of Ophthalmology that ophthalmic trauma was recognized as an important subject as an ICO program in WOCN, and myself, Dr. Gangadhar, Rupesh, Dr. Ferenc Kuhn, Dr. Wolfgang Ganger, and many others were involved in 6 major symposiums. Apart from free papers, videos, we took part on our own also. And we had the first annual virtual resident ophthalmic trauma competition, thanks to Fasika and also the Dr. Gary Legault and Grant Justin, where we had Ferenc Kuhn, Robert Mazzilli, James Sauron, Amy, thanks to, for asking the Wilmer Institute to join the APOTS there. And we also had an International Ophthalmic Trauma webinar on 30th May, along with the Ocular Trauma Society. We have the Dr. Grover, Dr. Giridhar, Dr. Mukherjee, Dr. Shukla, and you can see the many names in Dr. Rajiv Raman, Dr. Carolyn Chi. And we had this program thanks to Gangadhar, Rupesh, and we also have Professor Graham Holder, which was there in June 2019 in Nice, in France, as a part of the Society Ophthalmologica Europa. And then we had APOTS at the All India Ophthalmic Conference, where me as a President of APOTS and also took over as the President of All India Ophthalmic Society. We have Professor Azad, Dr. Rajiv Raman, Dr. Grover, and you can see Dr. Namrata, Dr. Mehul Shah in one of them. And then we had the AO 2019. We have, you can see the entire team here, Dr. Rupesh Agarwal, Dr. Gangadhar Sundar, Annette, Ferenc Kuhn, Fasika, Dr. Rekha Kandelwal, Andreas, and even Kendrick. And I think this is we also had a meeting with the American Academy of Ophthalmology Trauma Group, and now I'm happy because of a part of the influence from APOTS, the ASOT has started American Society of Ophthalmic Trauma. And we had the session in APO 2019 in Bangkok. You can see with the president of WOC at that time, Dr. Hugh Taylor, and this is our APOTS meeting, which is happening. And then we had the 47th annual conference of the Ophthalmic Society of Bangladesh, tackling ophthalmic trauma. We had a APOTS session, and you can see along with the Bangladesh Society. And then we had this in the TraumaCon 2018, along with the Ocular Trauma Society, Asia Pacific, and the SASU, which happened in Chennai. We can see Dr. Rajiv Raman, Dr. Pyson, and everybody from our APOTS were there. And this is with our Vice President, Dr. Huayan, in Chennai, with Carolyn Chi, Annette, Gangadhar Sundar, and Mohan Rajan, who was also part of the session today. We had this was a great APOTS program held by NUHI International Congress in 2016. And you can see Dr. Gangadhar Sundar, Carolyn Chi looking very young there, Rupesh looking same, Azad, and myself. And this is the few photographs again with the Ferenc Kuhn and the entire team there. And this is in Busan in 2016 with Carolyn Chi. And I think we took this opportunity of, thanks to Professor Azad, who's like my elder brother, we are boiling the idea. Actually, we wanted to start Asia-Pacific Vitreoretinal Society, and from there we came to Asia-Pacific Ophthalmic in the late 2000, and then 2011 it was born. And this is in 2012 in Busan with Professor Stefan Serigad and Professor Kumar Manikwal, Dr. Awa Hussain, who's the president-elect, and we have Professor Ferenc Kuhn and Dr. Dennis Lam, APOTS at AO Chicago in 2016 in McMahon Place. And this is the Nepal Ophthalmic Society in 2015 with the Tilganga Institute of Ophthalmology. And then you can see this with the Dr. Rupesh, Carolyn Chi, and Azad and Gangadhar in a committee meeting. Thanks to both Gangadhar Sundar, Rupesh, Carolyn, making us feel at home. And this is in Gangadhar Sundar's house with the Quresh Muscati, his family, Carolyn Chi with her husband Paul Chiu, Gangadhar Sundar with his wife, Professor Kumar Manikwal, myself. And this is a meeting thanks to Professor Huan we had in Shenzhen in Dalian, China. And we also had the APOTS postgraduate education module and APOTS at Hyderabad in 2013. Thank you very much, and I giving out to Dr. Rupesh Agarwal.
Thank you, Professor Natarajan. And it was very illustrating the history of APOTS. So with that, I welcome you all to the two-day symposium, or rather I should call two-evening symposium of APOTS. And today we should have been in Bali, celebrating and getting all of us together. But unfortunately, because of the COVID-19 pandemic, we are all here. So how the two sessions, the plan on the 2 days are, we have 4 sessions on the day 1 and 4 other exciting sessions on day 2, which is tomorrow evening. For today, we have the session 1 of cornea and anterior segment, and then followed by lens, glaucoma, the session 2, followed by 3rd and 4th session, and which will be neuro-ophthalm and oculoplasty session. We have session in charge for each and every session, and the session in charge will introduce the chair and subsequently the speakers. One of the things which we will try to follow in all the sessions is to restrict our timings to the very limited time, because we have a really packed schedule and we really want all of you to go through each and every presentation in detail, and we don't want to compromise on any of the presentation. So to get a full breadth of whatever we are talking, we need everyone to restrict themselves to the timing. So that's what I will probably request session in charge to kind of work with the chairs and the co-chair. Unless otherwise me as a moderator for the day, I will have to probably kind of interject between and then probably go ahead with it. So that's one of the housekeeping rule. The housekeeping rule number 2, which is very, very important, and I'm sure all of you probably would have appreciated by this time, you would have all become PhD and experience holder in webinar. So probably we'll try and keep ourselves mute and our video off so that the spotlight can be on the speaker and there is no distraction for him. And even for the speakers, if I can request them to keep their video, and you can see the president leading from the exam, leading the way by setting up an example himself, and we can the speaker to restrict himself with the time. With that, I declare the session to be open, and we can go ahead and start with the session number 1. And it's my honor and pleasure to invite Dr. Kendrick C. from Hong Kong as the session in charge for introducing about what he's going to present to us. Thank you. Over to you, Dr. Kendrick.
Thank you, Dr. Rupesh. So welcome, everyone. So to our cornea session. So I'm very pleased to introduce our 2 chairs today. That is Professor TD and also Professor Mukherjee. So they will be chairing the session, and we're delighted to have 5 speakers and also 1 additional panel speaker today. So because in the interest of time, I'll introduce each of the speakers, followed by the presentation, and then we'll pass on the panel discussion session to our two chairs. So for the first speaker, I'd like to introduce Dr. Minu from Nepal. And Dr. Minu, please share your presentation.
Can you see it?
Yes.
Yeah. Can I start?
Yes, please go ahead.
Yeah, okay. Thank you so much. Good afternoon, everybody. I'm from Nepal. So for the topic of today, that is infected corneal laceration, pearls in management. I have no financial disclosures and conflict of interest. And we all know that corneal laceration is actually a cut in the cornea, and it is usually caused by the contact with some sharp object. And if the laceration is very deep, it can penetrate the entire thickness of the cornea. And if the laceration completely crosses the cornea, it causes rupture of the eyeball. And we all know that these corneal lacerations are serious injuries that require urgent medical attention to prevent loss of important vision. So now we come to our case, that is case 1. It is a 45-year-old male who had an injury with a stone while doing a construction work, and he presented with painful red eye, and he had a delayed presentation, treated with antibiotic and steroids elsewhere, had multiple foreign bodies, and we diagnosed him as a case of multiple foreign bodies with stellate laceration, and he also finally ended up having endophthalmitis. He had tectonic keratoplasty with intravitreal injections, and at the time of discharge, when we finally discharged him, he had no useful vision and only the globe could be saved. This is our second case, who is a 9-year-old boy who is an injury with an arrow, and because of lack of communication, being a child with the parent, there was lack of surgical and general anesthesia facilities at the local levels, socioeconomic problems. He also presented late, and he had already used traditional methods, and we diagnosed him as a case of laceration with ulceration of the wound, and he also again had endophthalmitis. So we did a primary closure with intravitreal antibiotic injections, but again at the time of discharge, he had only a visual acuity of 3/60 and he had cataract. And coming to our case 3, it's a 15-year-old boy who fell down accidentally on a stump of a bamboo plant while walking, and he presented with a full thickness bamboo stalk penetrating into the cornea, and he was taken to the emergency OT for foreign body removal and repair of the laceration. But even though doing this on the second post-op day, he developed hyphaema, vitreous, and had severe pain. We did a vitreous tap and AC tap and sent for culture sensitivity, treated with intravitreal antibiotics. The culture showed fusarium, again was treated with voriconazole. Finally, the patient had secondary glaucoma, trabeculectomy was done, keratoplasty was also done. But at the time of discharge, again, the patient had he had gone into phthisis bulbi. So what we found from all these cases is that these infected corneal lacerations, the infections was because of the foreign bodies, corneal ulceration of the wound, and endophthalmitis. So we can see that these endophthalmitis can happen because of these foreign bodies, which can be metallic, but usually it is most commonly due to the non-metallic foreign bodies like wood, vegetative matter, glass, graphite, and stone, etc., which again become infected. And we can also have ulcerations of the wound like what we see in this picture, and this can again lead to finally to endophthalmitis. So what we found in these cases is that the predisposing factor for infection in the laceration was trauma with the vegetative matter, foreign body in the wound, use of traditional methods, use of steroids, which is very common in our countries, especially in these developing countries, because we don't have proper laws, because these are children, lack of communication and delayed presentations because of the difficult terrains. So how do we manage these cases? It is very important that you do very good investigations in the form of anterior segment OCT to actually look for these foreign bodies, do a corneal scraping, send for grams, GIMSA, QH, and do a culture sensitivity, do an X-ray, CT, MRI whenever required, do an ultrasound B scan, and a photographic documentation is again very important for medical legal problems. So how do you manage? Whenever we have a foreign body, it's very important that we do a foreign body removal, send for culture sensitivity, flush these lacerated wounds with betadine, if required, do a gentamicin and voriconazole solution wash after dilution, treat these patients with antibiotics and antifungals according to the organisms which are isolated. And if it is small and shallow laceration, we can use a glue or a bandage contact lens. But if they are deep and large lacerations, suturing needs to be done, but suturing sometimes the sutures become loose and that they can also have sutural infections. And if it is an ulcerated margins of the laceration, it is very important that we treat them again as a corneal ulceration, do a good corneal scraping, send for culture sensitivity, manage intensively with antibiotics, antifungals, or intrastromal antibiotics and antifungals if required. And if they are deep and large lacerations, yes, we have to go for suturing, but sometimes the sutures give away, and sometimes we have to go for these tectonic and therapeutic keratoplasty. And as we know, like in endophthalmitis, we have to go for a vitreous tap, send these samples for grams, GIMSA, QH, and for culture sensitivity, give intravitreal injections like what we have been doing, and steroids if in case of bacterial infections. We can go for AC tab and anterior chamber wash, and sometimes we also have to do a very good vitrectomy. So what we found that especially the prognosis of these infected corneal lacerations, it is very important that the timely intervention and proper management is very important. Visual rehabilitation in the form of therapeutic and tectonic keratoplasty if you have corneas, retinal detachment surgery, or low vision aids are also again important. And in the end, I would like to say that take-home message is that early diagnosis and proper judgment in these cases with prompt surgical and surgical intervention, very good visual rehabilitation, and it is very important that there is a sufficient warning to the patient about poor prognosis of these infections, and possibility of an enucleation should be informed to the patient and the patient party. So I'd like to thank everybody, especially the organizers and Dr. Natarajan, Dr. Rupesh, Dr. Ganga, and Dr. Kendrick for giving me this opportunity to present in this prestigious conference. Thank you so much.
Thank you, Dr. Minu. So excellent presentation. So if you have any questions, you can enter it into the chat box and we'll try to address it in the panel discussion afterwards. So the next speaker is Dr. Sharida from Indonesia. And Dr. Sharida, please, can you share your presentation, and you can start anytime. Thank you.
All right, can you all see the presentation now?
Yes, we can. Thank you.
Okay, thank you. So thank you so much. Previously, I would like to say thank you to all the organizing committee for the invitation. And this afternoon, I would like to present my case presentation is about an Iridia IOL implant in post-disect patient. So it begins with, in a one lovely morning, there's one patient came with this kind of condition. So this patient has the fixed dilated pupil, and you can see also in here there's a cataract. And also this patient also had endothelial decompensated. So what will you do in this kind of patient? So this patient is like 48 years old, male, with happens in the right eye, and he complains about glare and also photophobic in his vision. And only right eye affected, and he said that he felt like something like hit him when he was riding his motorcycle. And then his visual acuity is like 0.05. There's no history of any medication and no family history with the same disease. So I think the differential diagnosis for dystrophy and also a previous acute glaucoma attack can be out, and then we can be between the severe blunt trauma or ophthalmomyiasis. So because there's no lava found in the cornea and also the conjunctiva, I conclude this patient may be having some severe blunt trauma. So this is the SOCT. We can see here that the CCT was increased, and also there's an abnormal DM image in here. So the cement membrane is like curly. And then what will you do in this kind of patient? We can divide it into two kind of intervention. One is the medication, and the second one is surgical. For the medication, you can use any bandage lens, and also the combination of bandage lens and hypertonic saline. But you have to remember the hypertonic saline only okay in the acute phase. But if it's already chronic, then most probably we have to do the surgical. So is it like one step for EK and also cataract in one step, or two step? And this is the surgery. We can see here that this is the dissect that I make. So after you remove all the epithelium using the sphere, and then you put like 8.0 diameter to like the edge of your decimate stripping, and then put the AC maintainer so the AC can be formed. And then using the Reversinsky, you strip out all the decimate, make sure that you can stripping the 360 degrees. And then using forceps, you can take out the descemet stripping using the forceps. And after that, you put the venting incision using the diamond knife. So if you want to make the graft central, after that, you can also do that. And don't forget to do the PI, because if not, the IOP will increase after the surgery. And then followed by you pull in the donor graft here, and then make sure that all is unfolded. After that, you put a small bubble inside, and then make sure that the graft is well centered. If the graft is not centered yet, there will be two kind of approach that you can do. The first one, after you put the small bubble beneath the graft, you can move it using the Sinski in the venting incision, or you can also do this. This one I use the 30 gauge needle, and then you just put the graft into the center, and after that you put the SF6 20%, and that's all. And after that, the visual acuity is increasing from 0.05 to 0.4, but the retinometry is only like 0.7. So there's something that bothering his vision. So in the end, I decided to do like the cataract surgery for this patient around like 1 year after he did the DSEC. And now the ECC before the cataract surgery is 2155. It's 1 week endothelial cell count. And this is the cataract surgery. So after you put the viscoelastic inside using the Ultrata, you can do the CCC, the anterior CCC. And after that, don't forget to do the hydrodissection on the lens, because it was only the cataract grade 1 and 2. So after that, you can like do the segment removal, continued with the IA. And after you took out all the cortex, you try to do the peritomy of the conjunctiva, and then you measure around like 9.0 using the caliper, because you know the optic diameter of the Iridia IOL implant is 9.0 or 10.0 also can.
1 minute to go.
Yep. And after that, you just put in the Iridia lens. And after that, you stitch. And make sure that the knots is all buried inside, and make sure that you do the IA correctly, because if not, the visco will cause the intraocular rise. So this is the post-op after the DSEC and also the cataract surgery. The visual acuity can be achieved 1.0 with a correction. And this is the endothelial cell count. You can see in 1 year, there's a loss of 10% of the endothelial cell count. So I think that's all for my presentation, and thank you.
Thank you, Dr. Sharita. Excellent surgery and excellent presentation. So for the next speaker, we'll have Dr. Ray from Singapore present on Stevens-Johnson syndrome. So Dr. Ray, can you share your presentation? And you can start anytime. Thank you.
Can you see my presentations?
Yes.
Okay, hi. Good afternoon. So I'll be talking about ocular Stevens-Johnson syndrome, and I have no financial disclosure to make. Stevens-Johnson syndrome is a complex immunological syndrome that is characterized by acute blistering lesions that is affecting the skin and at least 2 mucous membranes with variable involvement of the eyes. Severe ocular involvement can cause extensive and permanent damage to the ocular surface as well as the eyelids. We all know that syndrome could be triggered by certain agents, although almost a quarter of the cases, we don't know what is the trigger. It is rather a rare condition, incidence being around 1 to 6 per million. However, the ophthalmic involvement is pretty high, up to 80% of the patients who see the ophthalmic involvement. In the typical acute stage, you see this kind of hemorrhagic crusting of the eyelids. Papillary conjunctivitis is pretty common, that can range from mild to severe. And typically, you can see this kind of pseudomembranes, typically on the superior palpebral conjunctiva. Corneal involvement is rather common. It can range from punctate epithelial erosion to the large epithelial defect. And some neglected cases, you actually see the secondary infection. It has been even reported that some patients can develop corneal perforation, even panophthalmitis. Because of the rarity of the disease, most of the ophthalmologists do not really treat these conditions in the acute stage on a regular basis. Given the potentially devastating visual complications, it is imperative that all the ophthalmologists be aware of the conditions and they evaluate the conditions and they know the treatment of this disease. Patient must be evaluated as quickly as possible within the first few days of the episode. Look at the cornea, look at the conjunctiva, look at the eyelids, and based on this simple staining method, you can actually grade them, or you can classify them into mild, moderate, severe, and extensive. Extensive being the extensive, the staining of the cornea, conjunctiva, and the eyelid margins. Irrespective of the severity, all the patients should receive the topical antibiotics, topical steroids, lubricants. But what is more important is that since this kind of patients, typically they develop this kind of symblepharon, you have to see these patients daily. You have to do the daily rodding. And in extensive cases, you can even consider putting a symblepharon ring. But what is more important here, if your patient comes into this category, that is severe and extensive, you have to do an amniotic membrane transplant, typically within first 10 days of the incidence. And amniotic membrane transplant, it must cover the lid margins. It should cover the palpebral conjunctiva as well as the globe surface. And in extensive cases, even this amniotic membrane has to be repeated in 7 to 10 days time when the first layer gets degenerated. Although the outcomes of the newer acute interventions are pretty promising, the unfortunate reality is that most of these patients with acute Stevens-Johnson syndrome fail to receive needed interventions in the acute phase. And then this acute episode progresses to the chronic phase. If you're lucky, you can get away with this kind of mild chronic Stevens-Johnson syndrome, but most of the patient goes into other category that is severe and extensive. So most of the patient will develop ocular surface failure because of the stem cell deficiency, recurrent inflammations, and progressive scarring because of the mucous membrane pemphigoid-like pictures. So here you go. These are the huge challenges that you have to deal with the patients of chronic Stevens-Johnson syndrome. You have corneal complications, you have conjunctival complications, you have eyelid complications. Whatever is the severity of the disease, all the patients should receive this medical management in terms of preservative-free lubricants. Autologous serum has some essential components of the natural tear. If the puncta is still patent, you can even consider the punctal occlusion. There are some suggestions that topical trans-retinoic acid can actually prevent the keratinization of the ocular surface. And of course, if you have the inflammation of the surface, you have to use this topical steroid intermittently or the steroid-sparing agent like cyclosporine. Given the limited medical therapies available, the patients often require more advanced devices or procedural interventions to achieve visual improvement or even the pain relief. So one such device is the scleral contact lenses. These are gas-permeable custom-fit devices. It provides excellent kind of hydrated ocular environment. It protects your cornea from the blink-related injuries. But only caveat is that you cannot fit the contact lens in a patient who has severe symblepharon or ankyloblepharon. If you have any eyelid issues, that has to be sorted out quickly. If you have a dystrichiasis, trichiasis, or entropion, ectropion, correct that quickly. If you have severe keratinization, you might have to consider doing this kind of mucous membrane graft with or without amniotic membrane transplant. Now, severe conjunctival inflammation and the resultant cicatricial changes that you see in this kind of cases may result in total corneal stem cell deficiency. This could lead to persistent epithelial defect or even severe keratinization of the surface.
1 minute more to go.
Sure. So what are the options you have? You can either do this keratolimbal graft. If the ocular surface improve, then probably you can think about corneal transplant or either in the form of the penetrating or the lamellar keratoplasty. If that is not feasible, you can try this K-pros. If your ocular surface is relatively better, you can go for the K-pro type 1. Otherwise, you have to go for the K-pro type 2. And these are the basic difference. If your surgery is successful, then probably you can achieve up to 80-degree visual field in the type 1 K-pro. Otherwise, K-pro 2, you can get around 60-degree visual field. 80-degree in the K-pro 1, 60-degree in the K-pro 2. And this is probably the last option. If none of your options are really working, probably you can try this modified OKP. This is a multi-stage procedure. Surgery is a very complex. It involves different sides of the body, mouth, face, and eye. I'm not going to talk much about it. I know that Professor Liu is going to take this session at the end of this webinar. So I'll just leave it here. And if it is successful, again, the patient can get up to 60 to 70 degree visual field. So in conclusion, if you encounter a patient of acute Stevens-Johnson, or rather Stevens-Johnson syndrome, manage your acute stage well. Early intervention with amniotic membrane transplant is an effective treatment for the acute Stevens-Johnson syndrome. Emerging treatments offer increased hope for these unfortunate patients with significant ocular damage. However, prevention of the damage at the acute stage is probably the most crucial part of your treatment. Thank you for your attention.
Thank you, Dr. Ray. Okay, so the next speaker is Professor Stephanie Watson. I'll be sharing her PowerPoint. Dr. Ray, can you stop sharing your screen? Yeah, thank you.
Henrik, we need to play the audio.
Okay, wait, so hold on.
You tap?
Yep.
That's all right.
Sorry.
Nice fine.
Okay.
Corneal trauma can result in corneal opacity, which is responsible for around 7% of the world's blind. In fact, corneal opacity is the third commonest cause of blindness, and a third of it is due to trauma. Now, following a penetrating corneal trauma, the principles of repair are to restore the globe, restore anatomy to normal, and minimize the risk of complications. The overall aim being to preserve the eye and retain normal vision. Outcomes from penetrating wounds can be poor, so it's important to counsel the patient so that their expectations are realistic. In the US National Eye Trauma Registry, 21% of cases were no perception of light following the trauma. Generally, a sharp penetrating eye injury will have a better prognosis than a blunt one. The method of repair for a corneal wound depends on its size and morphology. If there's a wound that is self-sealing and around 2 to 3 millimeters in size with a good anterior chamber, you may not need to provide further treatment aside from cycloplegia for comfort and antibiotics to prevent infection. If in doubt, a bandage contact lens may be placed. The patient should be followed up closely. If the wound is less than around 2 millimeters with minimal tissue loss or a small leak, then a contact lens can be placed. This may be supplemented with glue. Consider prophylaxis with oral ciprofloxacin 750 milligrams twice a day, as there is a risk of endophthalmitis. Images on this slide show how to apply glue to seal a corneal perforation at the slit lamp. There is a supported disc used and a cotton bud, so this can be done upright. The glue can also be applied directly to the cornea using the insulin syringe with a very small spot with the patient lying down. It's important to make sure the cornea is dry before placing the glue on the eye. Our published results of corneal gluing show that it's effective at stopping leaking at day 1, but most patients go on to need a further treatment. The best way to think about it is that it's really a temporizing procedure, allowing you to make a plan for the definitive treatment. Glue can also remain on the ocular surface for some time. In this case, a 67-year-old female who had a perforation due to pellucid marginal degeneration had glue applied and then reapplied it 3 weeks after it came off. A bandage contact lens was placed with the glue, which is routine and replaced monthly. Now, this glue remained in place for over 5 years, and in the end, it was removed with a planned lamellar patch graft. In corneal wound repair, a general anaesthetic or low-volume local anaesthetic block is used to avoid an increase in pressure around the globe. The aim of the surgery is to have the globe watertight to remove lens or vitreous if it's disrupted, reposition any viable uveal tissue, and if a foreign body is present, remove it. Repair begins by aligning the limbus and the angled parts of the wound. Once this is done, you then bisect the remaining wounds continually with successive suture bites. Now, sutures or lacerations can flatten the cornea, so to counteract this, you should do large compressive peripheral bites and smaller, looser central bites with the suture. Sutures for corneal wound repair typically include 10-0 nylon for the cornea and 9-0 nylon for near the limbus. It's important to try to avoid the visual axis. A spatulated needle is used aiming for 90% stromal depth. Any knots should be buried, and the anterior chamber can be reformed with balanced salt by the wound or a paracentesis. It's best to avoid viscoelastic if you can, because it's hard to discern it from vitreous and requires removal. For a stellate wound, a purse string suture can be used. A laceration involves the cornea and the sclera, or the sclera alone. You must perform a protomy to explore the extent of the laceration. Remember that the sclera is thinnest behind the muscle insertions, so check there to look for a perforation. Another consequence of corneal trauma can be endothelial failure. Throughout lifetime, endothelial density on the cornea gradually reduces, and trauma can accelerate that loss. If corneal transplantation is required for corneal trauma, deep anterior lamellar keratoplasty can be considered, particularly for younger patients and those with Down syndrome who may be at increased risk of trauma, patients with deep corneal scars, or following corneal infection. And this is because in a deep anterior lamellar keratoplasty, the posterior cornea is left behind, which has some tectonic advantages and reduces the risk of infection. If there's endothelial in children, trauma to the cornea may occur at birth, such as with a forceps injury. If a corneal graft is required for pediatric
1 minute to
trauma, the success rate is around 64 to 81%, with an increase in vision in around 80%, but requires aggressive management with frequent examinations, high-dose topical steroids, control of glaucoma, and amblyopia therapy. The cornea is critical for vision and ocular comfort and can be affected in many ways by ocular trauma with vision loss and sometimes pain. When this happens, repair is needed, and the repair that you need to do depends on the extent and nature of the injury. Some options available include glue, sutures, or corneal grafts, and perhaps in the future we'll have new and innovative ways to repair the cornea. Thank you. In closing, I'd like to thank APOTS who've done an excellent job at putting this exciting program together. I hope you enjoy it.
Okay, so thank you, Professor Watson, for that presentation. Hope you enjoyed it. So for our next speaker, we'll have Dr. Aziz Kam from Hong Kong. So Dr. Kam, can you share a presentation? And you can start anytime. Thank you.
Well, thank you, Kendrick. Can you all see the screen?
Yes.
Okay, thank you. Well, good afternoon, everybody. Thank you very much for inviting me to speak at this wonderful virtual conference. I'm Kam from Hong Kong, and I'm here to share with you the SLED experience in the Prince of Wales Hospital. So before I begin, I'd like to acknowledge my teachers from India, Dr. Sangwan and Dr. Basu, for teaching me how to do SLED in LVP. SLED is short for simple limbal epithelial transplant. And basically, you can see that there is a donor eye, usually in the healthy, non-damaged side, and there's a recipient eye where you would transplant a small amount of donor limbal stem cell to the sick eye. So the indication of SLED would be usually a unilateral limbal stem cell dysfunction or failure, as you can see on this photo. Sometimes it can be done using an allogeneic donor, from a cadaver or living related donor in bilateral disease patient or during the acute stage following an ocular burn. The advantage of SLED is that it uses a smaller amount of donor tissue compared to the limbal conjunctival autograft, and it does not require a stem cell lab to cultivate and expand the stem cell. Also, the paracentral location of the explant will allow the central cornea to epithelialize first, usually within the first 2 weeks. However, there are contraindications to SLED, for example, a very dry surface or a blind eye without any visual potential, or an eye with adnexal problems such as atropine that is not corrected, or a very disorganized anterior segment. The efficacy of SLED is summarized nicely in this paper by Swapna that showed an overall success rate of about 80% at a mean follow-up of 1.5 years. 70% of patients would have achieved a 2-line improvement in vision by 1 year. So how do we define success? Usually clinically by examination of a cornea. If you see an avascular epithelialized corneal surface, then it's successful. Whereas if you see a conjunctivalization of the cornea or the recurrence of epithelial defect, it usually indicates failure. So let us go through a few cases. So this is Mr. Low, 52-year-old man who sustained an injury on duty with a caustic agent while he was cleaning his restaurant. The two eyes, the left eye was injured more significantly. As you can see, the Duos grading is grade 6 in the left eye. The right eye healed with medical therapy. However, the left eye required multiple amniotic membrane. This is what he looked like after the 3rd amniotic membrane. And this is about 8 months to 9 months after the injury. As you can see, a conjunctivalized surface. So we performed SLED, and this is what he looked like after SLED. As you can see, the clearing up of the cornea. And at week 2, you can see the explant on the above image in the upper part of the image where you can see the explant. And this is week 4, you can see an additional hyporeflective layer, which is the new corneal epithelium. So this is him 4 months after the SLED, and we decided to take out the cataract, which is mature. And this is about 1 year after the SLED. And now you can see there's vascularization in the upper part of the cornea. So I'm thinking, could the SLED have failed? So we repeat the anterior segment imaging, which shows there's still a hyporeflective membrane in the recipient eye in the below image. And confocal examination reviewed the presence of corneal epithelial cells. So from this patient, I learned that anterior segment imaging is very helpful in addition to clinical examination in predicting the outcome of SLED, in telling the outcome of SLED. Number 2 is Mr. Chung, a 66-year-old man with the diagnosis of left eye conjunctival SCC. He had multiple surgery followed by multiple cycles of topical chemotherapy. He then had a deterioration in the vision with a partial limbal stem cell deficiency. So at that time, I decided to do a SLED on this eye with a modified technique. As you can see from this diagram, there are 2 nylon sutures fixating the amniotic membrane in the superior cornea, which I regretted soon afterwards, because at 1 week, I can already see the migration of the explants compared to the first patient. So this patient at 2 weeks, the epithelial, the cornea is still not epithelialized. And only at 4 weeks, I see the breaking apart of the amniotic membrane. And then at 6 weeks, most of the amniotic membrane is gone, and I could not see any of the explants on the ocular surface. This is him at 3 months after SLED. The vision is 20/60. Patient is a bit is happier than before, but you can see that there is central corneal haze. So from patient number 2, I learned that for partial LSTD, perhaps just a conjunctival autograft plus amniotic membrane graft would have been a better option than doing SLED. And then because of the modified technique, I see there's an early mobilization of the explant. So it highlights the merits of the original technique described by Dr. Sain and also Dr. Sangwan. Our last patient is Mr. So, who is a 68-year-old man who had bilateral chemical injury by Lyme. He also sustained his injury on duty. This is the right eye, which is the worst eye. It had 2 amniotic membrane graft done. About a year after, he had a SLED in that eye from his relatively healthier eye. And this is the post-op day 1 photo showing you the limbal biopsy site on the left-hand side and the one with a SLED done on the right-hand side. Well, after the operation, his vision remained more or less the same. As you see, the amniotic membrane becomes thinner and thinner. And this is about 4 months after the operation, and he's still seeing 180. So we are suspecting that this patient may have some—
1 minute left.
May have some, thank you, may have some malingering issues. So we did an orthoptic assessment, which showed a vision of actually 20/80. The fundus appeared to be normal. This is him at 10 months after the operation. So a summary of the 3 patients I presented, all of them are in the 50 to 60s. They're all male patients. 2 of them had chemical burns. 1 had an iatrogenic cause of limbal stem cell deficiency. 2 of them had vision gain out of the procedure. And then 2 of them at the last follow-up, I would consider them having a successful surgery. And 2 of them achieved a 2-line increase in the vision at a mean follow-up of 15 months. So these are the photos of the 3 patients. And in summary, I want to tell you that for SLED, you have to select your patient very carefully. You have to review the indication and contraindication. You have to perform a good pre-op assessment looking at the donor eye and also the recipient eye. And in terms of post-op assessment, besides clinical examination, anterior segment imaging may have a role in defining the outcome of SLED. So thank you.
Thank you, Dr. Kam. Okay, so last but not least, we'll have Professor Christopher Liu from the Sussex Eye Hospital in Brighton give a presentation on his experience with OOKP. Because Professor Liu cannot be here in person, I have shared his video. So hold on.
Thank you, Dr. Shi, for asking me to speak on visual rehabilitation with the OOKP in severe ocular trauma. I have no financial interest to declare. Next slide, please. So what are keratoprostheses, of which the OOKP forms an example? Keratoprostheses are artificial corneas, and there are temporary capros, for example, the Eckhart, for carrying out vitreoretinal surgery when there is any corneal opacity, which stops the VR surgeon from seeing the retina. There are also attempts to replace cadaveric corneal transplantation, for example, with corneal constructs made from collagen. But finally, what we're talking about is to restore sight in corneal blindness. Next slide, please. And the way to do this is when corneal blindness cannot be alleviated by conventional keratoplasty, then we actually bypass the ocular surface and the host cornea. And this is very much a last resort. And in my opinion, this should only be carried out when there is severe corneal blindness in both eyes or one remaining eye. Next slide, please. There are 2 main forms of keratoprosthesis in clinical use. For the wet blinking eye and where there is no bulbar or tarsal keratin, the Boston keratoprosthesis type 1 is the choice, and it is relatively easy to perform. And the device you see on the top right is carried on the corneal graft carrier and sutured on as though it was a penetrating keratoplasty. This does less well with autoimmune diseases. However, with a dry eye or where there's lid defects or an incomplete blink, and you can imagine that with severe ocular trauma, there may well be a lid defect or incomplete blink. The OOKP would be the device of choice, and this is usually made with the patient's own canine tooth and tooth root. And this can last up to 10 or 20 years. You can see on the bottom left the clinical appearance of an OOKP, OOKP eye, and on the bottom right is the cross-sectional anatomy, which I will go through with you in more detail in later slides. Next slide, please. The OOKP stands for Osteo-odonto-keratoprosthesis. In other words, in plain English, bone, tooth, artificial cornea. Next, please. It was invented by my teacher's teacher, Benedetto Strampelli, but it was Falcinelli, my teacher, who made incremental improvements over 20-25 years, which improved the long-term retention and the visual results. Next, please. You can see that in his article that the majority, nearly 90% of the devices that he implanted lasted over 20 years duration. Next slide, please. Next slide, please. So let me show you the surgical steps. Firstly, you cut out a block of tooth roots and surrounding jawbone, and using the crown as a holder, you grind the tooth roots into a plate. And through that, you drill a hole and you fit an optical cylinder, as you see on the bottom right. Next slide, please. At the same time, you prepare the eye for a transplantation of a buccal mucous membrane taken from the inside of the cheek. And you suture that onto the recti muscles. And you can see that on the bottom right, there's a smooth piece of buccal mucous membrane which has been sutured on the eye surface. Next slide, please. So over the ensuing days and weeks, the initial epithelium is sloughed, and then a new epithelium is formed. And if you're lucky, then there's no need for any revision, and you can proceed with stage 2 after 2 to 4 months. Next slide, please. And here is the tooth plate, which had been buried in the contralateral lower lid under orbicularis muscle, and it acquires a layer of soft tissue. And on the bottom left, you see that the eye is being prepared to receive the tooth. The buccal mucous membrane is reflected, and a hole is made through the cornea. Next slide, please. The iris is removed, the lens is removed, much vitreous is removed, and then the lamina is placed on the eye and sutured on. The eye is refilled with air, and then the buccal mucous membrane is reflected back on and sutured. A hole is made in the middle for the optical cylinder to protrude, and it is through that the patient sees. Next slide, please. I've already told you that the success is due to Falcinelli's inventions and modifications, but also in Brighton, where I've been leading the national OKP service, we've made a lot of innovation as well that you can see in Current Opinion 2017. And also Dr. Iyer's team in Chennai, India also made many incremental modifications, improvements. Next slide, please. So here is the cross-section anatomy of the OKP eye. And if you look inside the eye, it's pretty much hollowed out with no iris, no lens, and little vitreous. And you can see that the tooth plate has a bone anteriorly and dentine posteriorly, and it hosts the OKP cylinder, which is made of PMMA. It is only the back part of the cylinder which goes into the inside of the eye. And then the whole complex is shrink-wrapped by buccal mucous membrane, and the bone of the OKP lamina is actually kept alive by the buccal mucous membrane. Next slide, please. The buccal mucous membrane is very tough, and it can keratinize when dry. So even if there were no lid and absolutely no tears, it can still survive, and it forms a biological seal onto the bone of the OKP lamina, which keeps out some microorganisms. And I've already said that it supplies the lamina with blood. So the lamina, through a gradation of living bone and hard dentine and non-living plastic, tricks the eye into accepting it, and rather than extrude it as a foreign body. Next slide. Because there's no iris, there is no breakdown of blood-aqueous barrier, and it reduces the risk of cystoid macular edema too. No lens means no subsequent cataract removal, and little vitreous, and ideally no vitreous, reduces the risk of retinal detachment, cystoid macular edema, and blockage of glaucoma drainage device. Next slide. Well, all keratoprosthesis can give rise to complications. The OKP, we're fortunate with that in that it gives usually months of warning before there are problems. So they do come back for 3-monthly follow-up, and we need to have comprehensive program and personnel to detect and manage various complications. Next slide, please. So let's have a quick look at keratoprosthesis and severe thermal and chemical injury. This study did by a previous fellow of mine and presented in Lisbon in 2017. Next slide. Over the course of 15 years, we had a number of patients with very severe chemical and thermal injuries. Next slide, please. So there's been 36 referrals, and then 14 proceeded with OKP surgery. And 9 patients had either NPL vision or evisceration of the contralateral eye, which means that 9 of the 14 patients had only one remaining eye. Next slide, please. 8 patients suffered thermal injuries, and 6 patients suffered severe chemical injuries. And all eyes had previous adnexal surgery, including 2 synthetic K-pros. And 1 case received an allograft lamina from a non-living related donor. Next slide, please. So the summary of the results is the visual results, 50% gained navigational vision. So you can see that pretty good vision in 43% and reasonable vision in 7%. But half the patients did not have good vision, usually because of end-stage optic glaucomatous neuropathy or a macular scar. And you can see the retention rate is pretty reasonable over quite a number of years. Next, please. 2 cases developed endophthalmitis, and 2 cases required removal of the laminae because of endophthalmitis or retroprosthetic membrane. Glaucoma was the most frequent complication, and 6 cases required buccal-mucous membrane repair. Next, please. So the thermal injuries were particularly difficult cases. Of the 8 cases in this group, post-op functional visual success was only achieved in 3 patients. Thermal injuries from explosions, direct mechanical trauma, and structural damage to all layers of the eyes. The assessment of the optic nerve and macula to measure the visual potential in eyes with opaque corneas remain a challenge, although it can be done endoscopically. Next, please. So the conclusion from that study was the OKP has the capability to provide long-term anatomical success in the most challenging cases of ocular trauma. But the visual outcome is limited by preoperative glaucoma and the condition of the optic nerve and macula. And glaucoma is the predominant complication in these severe thermal and chemical injury. Next, please. I also want to show you 2 pictures of dog bite injury. So in this particular case, nearly half the face was eaten by a pet dog when she was in a comatose state, and the other eyeball was also eaten by the little dog. But we managed to restore her sight for some years. And the next case is a gentleman in similar predicament. And you can see that there's no other eye because it was eaten by his dog. Next slide, please. So thank you, and I wish you to join the K-Pro study group if you're interested in keratoprosthesis, and we do have a new book coming out next year, and here are my contact details. Thank you very much.
So thank you, Professor Liu, for that talk. So with that, we finished all our sessions, and then now we'll move on to the panel discussion time. So I'd like to first of all throw one of the questions to both our chairs. So that's Professor TD and also Professor Mukherjee. So the first question is, what type of intracameral antibiotics do you use in trauma, and what dilution do you often use?
Henrik, you can switch on your video.
Okay. So Professor TD and Professor Mukherjee.
Yeah.
Okay. Professor Mukherjee, please. I do prefer with using the for the intravitreal, we use hello. Hello.
Yeah, we can hear you.
Yeah, I use the intravitreal is that for the anterior, for the anterior segment, but I prefer to do actually in the corneal restoration with infection first to clean up all the pathologic material in the cornea and also in the anterior segment. Then if it is necessary, then we do the intravitreal. I prefer to ask my vitreoretinal surgeon to do it because if it is supposed to be, it could be directly done together if we do with the vitrectomy and clean up all the infected material inside the eye. So on the other side, when we do have the corneal restoration which is infected, I do things that if we just suturing, like what Dr. Minu has mentioned, showing us, sometimes it's just in the area of the incision, in the area of the restoration is the infection is recurrent. So I do things whether it is, if we use the glue like Professor Watson showing us, because glue also even it is not only to as gluing, but also having the antibiotic antimicrobial action. Thank you.
Thank you, Professor Tidi. Professor Mukherjee, did you want to add?
We assess that wound first, whether it is contaminated or there are foreign bodies or it is lacerated type of wound, particularly in cornea. And we evaluate the posterior segment thoroughly, and if there is no damage to the posterior segment or nothing has gone into the posterior segment, sometimes perforating injury, the object can go into the vitreous. So if after removal of the object from the corneal side, one has to evaluate the posterior segment. And if under those circumstances, after suturing, we give the antivitreal injection in the form of vancomycin, or sometimes it is given in the form of combination of 2 or 3 antibiotics, depending on the situation. And just simple a clean-cut wound in cornea, we don't prefer to give any antibiotic injection into the intraocular portion.
Thank you very much, Dr. Mukherjee and Dr. Tidi. Henrik, go ahead. So there is a question also from the floor about experience of using Procera. Has anyone used Procera? Is that right, Manitos, which you wanted to ask?
Yeah, there is a suggestion that if you have a mild episode of acute Stevens-Johnson syndrome, and when you don't have the availability of the amniotic membrane in hand, you can actually use this commercially available Procera, which is a basically stretched amniotic membrane with a kind of circle around it. So I would like to ask if anybody has any experience or have the availability to their center.
Don't use material, but there is availability of the amniotic membrane there is plenty. So there is you don't go into this Procera.
Dr. Minu or Dr. Anyone, any other experience? Dr. Sarita?
I have no experience about using Procera, but as Martin mentioned, that we do the amniotic membrane. We in Indonesia have the dry amniotic membrane, so always available.
Well, why the Procera is useful, you see that most of the patients, when you encounter a patient of severe Stevens-Johnson syndrome or acute Stevens-Johnson syndrome, sometimes the patient is in ICU and you cannot take this patient to the operation theater to do the amniotic membrane under general anesthesia. So probably the Procera would be useful in this kind of cases because you can just place on the eye and you can just wait for the patient to, come out from the ICU to do your actual surgery.
So many thoughts and other panels. So there will be a talk which will be there tomorrow in allied health session on this thing, and we can watch out for that talk. Yeah.
You see, there are main problem of doing keratoprosthesis and main complication is the glaucoma. In about 70 to 80% cases of keratoprosthesis of any type, they suffer from the glaucoma. So do any of these persons or your panelists has got the experience of doing anti-glaucoma procedure before the keratoprosthesis procedure done?
So I think Dr. Mukherjee, Dr. Christopher Liu has given a video presentation, and he's one of the experienced. And Geeta here is not there on the call also. And I don't know anyone else we have more experienced in this panel. Manitos?
Normally,
no, not that I'm aware of, but I know and I do understand that these are the kind of desperate. Sorry. These are the desperate cases. I mean, even the checking the intraocular pressure in these cases is an issue, because how you are going to check pressure when you have a, so you have to do kind of find a device where you can actually check the intraocular pressure. Most of the time I understand if it is a OKP, you have to do either digital pressure. So is checking the pressure itself is not an issue. And doing a glaucoma surgery, I'm not expert in glaucoma. If somebody can give some insight from there.
I have done some vitreoretinal surgeries for detachment with the keratoprosthesis, but that's also quite a tough thing, because you have to measure. Pars plana is also, you have to measure from the edge of the keratoprosthesis about 8 millimeter, and it's a real, I mean, a tough job. But I think we have done, but
absolutely
glaucoma, I'm not sure. But we have used also silicone oil.
Glaucoma, we have to see that we have done OKPs about 36 cases in Rajan Aikar in Chennai, along with Dr. Srinivas K. Rao. Way back in 2007, we were actually the 7th center in the whole world to start this program. And the glaucoma, we have to see the disc and evaluate the glaucoma of these patients. There's no other way of testing the glaucoma in these patients. So you need to evaluate the disc very carefully every time the patient comes in.
Look, Kendrick, there is a request from the floor to keep all the panelists for session 1 to keep their video on. I think our supporter will like to take a kind of a screenshot maybe of the presenter. So the panelists for the session 1 can keep their video on. Sorry to interrupt. Go ahead.
So I just want to add a little bit about the Procura. So I think the Procura, although it does have a scleral ring, the problem is it doesn't cover the tarsal conjunctiva. So the other way that we do it is to actually just take one of those amniotecs, so one of those dried AMTs, long sheet, and then we can use a conformer to just fit it in. And because it reflects the amniotic membrane over the tarsal conjunctiva, they can also provide some of the protection on the lid margin as well. So we found that that is a little bit cheaper way, because Procura is very expensive for us. Yeah.
Thanks.
I also want to add my experience, because I already used the dry AMT, and then I put only
1 minute left.
Bandage lens just up the AMT, and then it works, but we have to tell the patient that for 2 weeks he will get like a reduced vision first. And then after the amniotic membrane is resorbed, and then the vision is getting better again.
Cool, thank you. So maybe with this, we'll conclude our session. So thank you everyone for listening to us. And we'll move on to the session to Dr. Mohan Rajan to take over as the cataract and refractive surgery session. Thank you, everyone. So thank you.
Thank you, Kendrick, for excellent session number 1, and most importantly on the time. Here is a couple of clips just to get started with the session 2. And maybe in the meantime, I can request Professor Mohan Rajan from Chennai. And I don't think he need any introduction as such, but probably I will let him lead the session 2. And with his team, which is not an IPL team though, but I think in the format of IPL, he can go ahead and start it. Dr. Mohan Rajan, over to you.
Thank you, Dr. Rupesh. And let me thank the APOTS, Dr. Natarajan, Dr. Gangadhar, Dr. Rupesh, and the entire team for giving this wonderful opportunity to me. It's always a pleasure to be in APOTS conferences. And this time it's a virtual conference, and we're hoping that we'll make use of this virtual conference to the maximum possible. We're going to have a very interesting session, because we're going to have a very good lineup of the faculty as well. And the faculty is really excellent. We'll introduce the faculty as they come in. But I'm going to introduce I'm the moderator for this session. I'm Dr. Mohan Rajan from Chennai, as Rupesh said now. And we have the chairman of this session, Dr. Purendra Basin from Gwalior. He's one of the top surgeons in Gwalior. And along with him, co-chairing the session is the father of the ocular trauma in India, as well as in this part of the world, Professor B. Shukla. And Shukla is also there with us. And also a very leading ophthalmologist from Nepal, Dr. Indra Podial, co-chairing this session as well. So we'll start off this session. Purendra Basin, Dr. Shukla, and Dr. Indra Podial are there on the line, and we have got an interesting faculty and lineup of speakers as well. Unfortunately, Devendra Sood is not able to join this program, so we'll start off with Shams Norman, and he's going to talk to us on. He's from Bangladesh. He's going to talk to us on hyphaema challenges in management. So I kindly request the speakers to stick on to the time of 7 minutes. The end of 6 minutes, you'll get a small signal there so that you can wind up by 7 minutes. And at the end of it, we'll have a very good discussion, a panel discussion as well. Over to Dr. Shams Norman.
Honorable panelist, my slide is visible?
Yes, sir, Shams.
Thank you for inviting me in this conference. And I don't have any financial issues. So my presentation on hyphaema challenges in management in Bangladesh. So we know what is the hyphaema. Blood is in the anterior chamber, the eye, called the hyphaema. And to combat the challenges, we have to know the pathophysiology, classification, gradings, history, like systemic history, and management. And what is the pathophysiology? You know, the compulsive force due to blunt trauma that cause the shearing forces due to injury can tear the vasculature. That may create some hemorrhage from the angle and also from the pupillary margin. And we have different classification. We know that traumatic hyphaema, strenuous condition like whooping cough, blood dyscrasia, like aplastic anemia, leukemia, and neovascularization where the spontaneous hyphaema may occur. And some other causes like herpetic keratosis, uveitis, intraocular tumors, actually the retinoblastoma, juvenile xanthogranuloma, and also some other secondary intraocular surgery, and with some medications like aspirins, NSAIDs, warfarin, etc. So these are some gradings of hyphaema, which is very important to know. The grade 1 is, first one is the microhyphaema. Some blood cells is in the anterior chamber. In the grade 1, less than 1/3. The anterior chamber layered blood, you can see, and then to 1/3 to half. Grade 2, more than half. Grade 3, and the total hyphaema or equal hyphaema is grade 4. The presentation with a local hyphaema, then with the settled in the lower portion of the anterior chamber, then it gradually it increases and it may just cover the whole anterior chamber. And it's very much important to take a very good workup. You have to take the history, the mechanism of injury, time of injury, history of medications like aspirin, warfarin, history of sickle cell disease, very important, and history of coagulopathy like bleeding gums and epistaxis. And some ocular examinations is very important, like any rupture of the group, we have to exclude first, and visual acuity, intraocular pressure, slit lamp examination, face scan, and sometimes CT scan is very much important to exclude any intraocular foreign body. And the management, the principles of management is quick absorption of blood, and prevention of complications, avoidance of recurrence, and discontinuation of any anticoagulant medicine, and limited activities. The common treatment protocol is sedation, is really very much helpful. Cycloplegics to raise the people, anti-inflammatory, prefer the steroid and ocular hypotensive agent if there is a possibility of glaucoma, and treatment of the cause. And surgical maneuver is very much important. AC paracentesis, irrigation and aspiration when the medical treatment fails. Indications, if any possibility of corneal blood staining, surgical visual deterioration, usually intraocular pressure if more than 60 millimeter of mercury for the 48 hours. This is we have to evacuate blood to prevent peripheral angiosynechia. If intraocular pressure more than 25 millimeter of mercury with total hyphaema for the 5 days. Any transient increase of intraocular pressure more than 30 millimeter of mercury in sickle cell disease. we know the complications. The most commonest complication is raised intraocular pressure, peripheral intrasynechia, post-synechia, corneal bloody staining, ray bleeding, pupil bulk, and neuropathy in case of pediatric patient. And what are the challenges we face? Rest. We are telling that we have to take rest, but rest is not very usual in case of children. So we have to take care of that. And pupil movement, we have to stop the pupil movement without atropine. But sometimes in case of children, it may cause fever. So we have to refer the patient to the internist, and we have to consult the patient before giving the atropine. Pupil movement can be stopped with bilateral patching, sleep, or eye closing as much as possible, or staying in the dark room. And associated bleeding disorder or intake of blood thinner, we have to exclude. And in that case, we should not stop the blood thinner agent without any comments from the cardiologist. We have to take care of that because it's a life-threatening condition. And re-bleeding, it is also challenges like clot retraction, and it may be associated with a bleeding disorder. Usually can occur within the 3 to 5 days. So we have to take care of that, and we have to follow that patient. Visual prognosis reduced from the 75% to 65% if rebleeds, and common in the total hyphaema. And different studies shows that tranexamic acid works very good or prevent the rebleeding. Raised intraocular pressure. So we have to prevent that raised intraocular pressure. We have to grade. We have to know the time of intervention. We have to give the tranexamic acid, anti-glaucoma medication. For me, the beta blocker is a good choice. Prostaglandin may induce inflammation, but carbonic anhydrase inhibitor can aggravate sickling of RBC if it is associated with sickle cell trait or sickle cell disease. Corneal staining. It is also a challenge. It's 2 to 11%. Usually, if it is a total hyphaema, large hyphaema, or rebleeding with secondary hyphaema, prolonged clot retraction, sustained increase of intraocular pressure, previous endothelial dysfunction, but it improves in centrifugal pattern with time. But in case of children, amblyopia is a factor.
1 minute.
Some other associated features like deep anterior chamber, deep, if it is deep, you have to think of the posterior subluxation. You have to think of the angle recession through the gonioscopy, and it may create angle recession glaucoma. And we have to separate it from the diffuse hyphaema from the iritis. We have to take care of the dialysis, striated macular edema, choroidal tear, retinal detachment, vitreous hemorrhage. Different studies suggested that tranexamic acid works better, 8 to 10 times more potent than aminocaproic acid. It prevents the rebleeding and also glaucoma. This is my study. In my study, I saw those patients have an angle recession and those patients have a history of hyphaema. They have the probability of development of glaucoma is 20% more. So challenges during intervention, hypotony is a challenge. A rupture group, you have to identify the rupture globe and you have to repair it. And retinal detachment, large clot, you have to. And and also key message, timely intervention is needed. Systemic history should be excluded. Collateral damage should be cured. Choice of anti-glaucoma medication.
Dr. Roman, very nice presentation. Do you have a video on that hyphaema?
Yes.
How much time does it take? Can you just quickly show the video about how you work at the hyphaema? Yeah. Probably a few seconds you can show that.
Yes, sir. Actually, that is a patient of total hyphaema, and there was a rebleeding, and I could not remove the blood clot, and I did the vitrectomy from some vitrectomy from the angular structure. Some blood clot was in the angle area, so I did the vitrectomy. So sometimes I do the vitrectomy to remove the blood clot from the angular structure.
Okay.
Thank you.
Thank you very much for the nice presentation. I think hyphaema is a very, very important thing because as far as the trauma is concerned, especially many patients are on blood thinners nowadays. So we need to keep that in mind because even a trivial trauma can cause an hyphaema in these patients. So we'll discuss that in more detail, probably at the end of the session, the panel discussion. We go on to the next speaker, and who is none other than Dr. Victor Ko from Singapore, and he's going to talk to us about hypotony after trauma. What, when, how, and why. Dr. Victor Ko, can share the slides now.
Doctor,
can you just stop sharing?
Dr. Shams, will you stop sharing? Yeah.
Yes, sir. Thank you very much.
Are you able to see my slides?
Yes, Victor.
Thank you very much, Professor Rajan. Thank you for the kind introduction.
Thank you very much.
Yep. Thank you, APOTS, for this kind invitation to speak. And I would like to present my talk on persistent hypotony after blunt trauma. I have no financial interest relevant to this content of this talk. The causes of hypotony that is persistent after blunt trauma, we have to first make sure that there is no open globe injury. So because occult defects can be missed, especially in situations where the mechanisms of the injury is not well established, or in patients who are difficult to examine, especially in young children. Some of the common causes, if the trauma is indeed blunt and not open, is cyclodialysis. Includes cyclodialysis, where there's a separation of the ciliary body from the underlying scleral spur that allows direct communication of aqueous from the anterior chamber into the suprachoroidal space. Ciliary body injury itself, retinal detachment. And this last point here, anterior proliferative retinopathy, is something that must be watched in the long run, because these tractional membranes that progresses and keep pulling onto the ciliary body, damaging it both structurally as well as reducing its function. I find it sometimes difficult to diagnose this, except the use of a UBM via a skewed operator. I would like to focus a bit more on cyclodialysis because I'm only given 7 minutes, so I'd like to focus the scope on this particular condition. As mentioned, it is a separation of the ciliary body from the scleral spur. The complications include hypotony maculopathy or edema. And to me, this is a very clear-cut indication for surgical intervention if the vision drops due to maculopathy. There can also be cataract formation. And we must also remember that if the impact of the blunt injury results in cyclodialysis cleft, then the rest of the angles can also be damaged due to angle recession, and the trabecular meshwork can be damaged as well. So if we subsequently close this cleft, there is a risk of raised intraocular pressure resulting in glaucoma, and frequently that in my hands that happens. We could do gonioscopy to diagnose the condition. I find it tricky when the eye is soft, so I would like to top up the anterior chamber with viscoelastic either at the slit lamp or intraoperatively just before I move in to repair the cleft. There are also my preferred choice is the use of UBM. I find this particularly useful and allows me to plan the surgery much better, including the diagnosis of the condition as well as the extent of the cleft. I would like to show some images using anterior segment OCT as well. The difference between anterior segment OCT and UBM, I think we are all well aware of it. Whereas the UBM remains the gold standard because it can visualize structures posterior to the iris pigment epithelium. It requires a skewed, however, this requires a skewed operator and also requires contact and takes a longer time. The anterior segment OCT, on the other hand, is non-contact, does not require a skewed operator, and with the Swepsos OCT allows us a higher axial resolution. You can see here UBM images of how a normal eye should look like. The ciliary body is attached to the underlying scleral spur. And in the hands of my skewed operator, you could see the cyclodialysis clearly in terms of clock hours. So this will aid in surgical intervention. You can also see the part that is labeled as E, that is the separation between the choroid and the underlying sclera. With the anterior segment OCT, you can also see how the 3D reconstruction of the images can show exactly where the cleft is, where the iris is separated from the iris root as well, and gives you an indication where you should target when you're doing surgery. The gonioscopic view that comes with this particular device also gives you a very good image of where the iris is separating from the underlying iris root, as well as where the PAS is formed as well in the anterior chamber. Intraoperatively, you could use Vision Blue to localize where the cleft is. You can see over here that the use of Vision Blue into the eye, and by allowing the flow of Vision Blue into the cleft, you could see where and localize where the cleft is. With a gentle pressure on the eye, you can see the reflux of the Vision Blue out of the cleft, and that confirms that fluid is indeed moving in towards the cleft in that area. The management of cyclodialysis cleft can be divided into small or large. The smaller ones, especially if the vision is not affected and there is not much maculopathy, we can observe or use topical cycloplegic agents. But in my hands, in my experience, rarely there's limited success with conservative management. And my preferred approach to repairing this cleft is through direct suture cyclopexy. There are, of course, other methods that have been described as listed in this table over here, which I personally don't have any experience with. In this particular multi-centered retrospective case series that looks at the cyclodialysis cleft repair, you could see that comparing laser and conservative management versus surgery, the surgical intervention clearly have a higher rate of success. But overall, the prognosis is good if we manage to close up the cleft and normalize the intraocular pressure. This is a video that's courtesy of Professor Lingam Gopal that I work with very closely. You could see that after localizing where the cleft is, we do a partial thickness scleral flap, 4 mm from the limbus. You can see the flap is being raised, and we do a full thickness sclerostomy directly over the uvea tissue. And you can see that over here, you can see the underlying ciliary body, and using either 8/0 nylon or 8/0 Vicryl, we will suture the
1 minute left.
Suture the ciliary body to the sclera directly under direct visualization, and depends on how many hours this cleft is. You may require up to 4 to 5 sutures to close this completely. So in conclusion, I think cyclodialysis cleft is a really important cause of traumatic hypotony. I also showed that UBM is perhaps the best way of diagnosing the condition, as well as determining the extent that will help in surgical intervention. We also showed that anterior segment OCT can potentially be another useful way of imaging the cleft. And direct surgical cyclopexy has can very effectively reduce the size of the cleft, control intraocular pressure, and improve the patient's vision postoperatively. These are my acknowledgements. Thank you very much.
Thank you. Thank you very much, Victor. It was really a brilliant talk. I know it's a very difficult problem to treat cyclodialysis. We used to do cyclodialysis a long time back. My dad was an ophthalmologist, and he used to do the cyclodialysis as an anti-glaucoma surgery long time back. Know how difficult it is to close a cyclodialysis cleft, and you have shown it very well. We'll have some more discussion at the end of it, and we'll go on to the next talk. Thanks for sticking on to the time. And we'll go on to the next talk, which is a very interesting topic as well. It's on traumatic subluxatory cataracts by Daphne Han from Singapore as well. And she's going to talk to us on this very important topic. Daphne? Is she there? Hello? Dr. Daphne Han is there?
Dr. Mohan, maybe we can move to another one.
Not yet. Maybe you can go ahead.
We'll go ahead. We'll go ahead with the next topic, which is by Dr. Sujata, and she's going to talk to us on she's from Chennai, India, and she's going to talk to us on wobbly Sinkling IOLs.
Is she from Chennai, India,
and wife of Sujata Mohan,
wife of Dr. Mohan Raj,
and also Shankareta alumni.
Go to Sujata, please.
Yeah. So good afternoon, everybody. At the outset, I'd like to thank Dr. Gangadhar and Dr. Rupesh for including me in this wonderful workshop. So my topic is on wobbly sinking intraocular lenses and how to fixate them. So I'm going to show you two different scenarios of how I fixated a dislocated IOL using an ab-interno fixation. And the first case was a 70-year-old male who had a phaco foldable done 15 years back by us, had an excellent vision of 6/6. And he came with an oscillopsia, which was there for about 6 months. And on history, he says he just had a very trivial trauma with an elbow. And, and when he noticed that he also had a pseudo-exfoliation. And you can see this video, how the lens is wobbling. I think probably the pseudo-exfoliation accelerated the traumatic dislocation as well. So he was very uncomfortable with it. So though he had a 6/6 vision, so we decided to go ahead and try to glue the same intraocular lens. So I'm preparing the eye for doing a glued IOL. I'm using a posterior infusion, a trocar, and creating the Chariot's pockets. and making a sclerotomy. So now you can see that I'm using a second instrument, just lift the IOL, and it's coming, the entire bag IOL complex is coming out very easily. There's no vitreous at all. And so the next step would be to remove all the capsular components around the lens. This can be done either with the cystitome, but here I've used an anterior vitrectomy probe also to remove the posterior aspect of the capsule. And once a little bit of the lens has become free, now we can go in and use the same intraocular lens for intrascleral fixation. So using the handshake technique, you can see the left hand is holding the lens and the right hand is exteriorizing the one haptic. And just make sure that the lens doesn't fall into the vitreous. And then you use the other hand, again the handshake technique, and bring out the other haptic. So we didn't make any incisions other than side port incisions. Now you can see the intraocular lens haptic has been tucked into the pockets which have been created. I'm doing just a little bit of a vitrectomy. Actually, there's no vitreous, just removing the capsular components and making sure there is no vitreous. And the patient had an excellent visual recovery post-operatively. And the lens has been stable for the past 2-3 years since we have been following him up. And you can see the first day post-op, you can see a very stable lens, and he regained his vision 6/6, which was what he was worried about. So this is one case, and the next case I'm going to show you is a very similar case. And he had a fall, and since then he says his vision started worsening over a period of time. And then what we noticed was he also had extensive pseudoexfoliation and a dislocated IOL back complex. So you can see that the whole lens is dislocated towards one side, and it was moving quite a lot, and his vision had dropped down to 2/60. So what I'm going to do in this patient was to create some Hoffman's pockets and do an intrascleral fixation of the same intraocular lens. And just a little bit explanation about Hoffman's pockets, I think most of us know it, is to create a pocket, a scleral pocket going from the cornea so that you don't have to dissect the conjunctiva. Once you've done that, make paracentesis so that you can put the 26 gauge needle through this. Go one portion goes under the lens haptic, the other needle goes on top, and so you pull it towards the sclera. So this is quite a simple procedure, and it can be done in patients who have a single piece foldable lenses. So once you've done that, you exteriorize the sutures and tie it. So this is what I did for the second case. I'm sorry. So creating Hoffman's pockets, you have to be a little bit careful to make the correct depth, and also just to make sure that you have enough of a pocket. Sometimes you might create a pocket and then you will be going outside the pocket, which then you might have to repeat the whole steps. So just check to make sure that you have enough pockets. You can always mark around the pocket. Now I'm using a 26 gauge needle, which I passed under the haptic of the lens, and the 10-0 proline is threaded into the needle, is railroaded, and it's pulled out. Now the other end of the 10-0 proline is introduced on top of the haptic, and now you can see that the whole lens is being pulled towards one side. You have to be a little bit gentle because this is not a completely dislocated lens. It's not dropping, so nothing may happen, but sometimes you can, if you pull too fiercely, then it can drop in. So it's important that you do it a little bit gently. Now I'm exteriorizing all the sutures, and I'm doing the same thing on the other side. You can see much more clearly that the lens, under the lens haptic, the 26 gauge needle is gone, and the 10-0 proline is threaded. Again, now it's going on top of the haptic. So you have a loop of 10-0 proline on both sides, and then you exteriorize the sutures and make sure that they are even on both sides, because before you tie, make sure that the lens is well centered, and then you tie it. Don't tie it first too tightly, then you might actually tie the lens towards one side, maybe decentered. Just make sure that you are well centered, and the whole procedure is over. So again, this patient also had an excellent visual recovery. And both the cases were managed ab interno, that is without opening the eye, and both of the patients did extremely well. So now I'm going to talk to you about another case, which is a dislocated phakic intraocular lens. The patient was operated by us about 15-20 years back, the Verisace model. And then after about 5 years, she developed a trauma with a tennis ball, and there was a sudden drop in vision. So the lens had dislocated, and because of the injury, she had a fixed dilated pupil. So though at that point of time, I recommended that she should put the lens back, the enclavation has to be removed and refixated. Her vision was about 6/18, and she was very reluctant to undergo another surgery. So she kept quiet, but then she came now with a cataract, as well as you can see that there's a dislocated IOL, phakic IOL. So the idea in this case was to remove the intraocular lens, because already the cataract has come. So we're going to remove the intraocular lens. And you can see that one portion was easy to disenclave, the other, whereas the other side, which was well enclaved, was a little bit difficult. And then once this was done, the lens was removed, and it was sutured, and we went ahead with the regular phacoemulsification. This patient had a fixed dilated pupil, and so she also had a lot of glare. So the next step after phacoemulsification was to do an iris suturing. That was a plan. And this was an uneventful surgery. The patient had very high myopia, so that was the primary reason she came for a phakic IOL, and she needed a +5 diopter intraocular lens. And here you can see that I'm injecting a multi-piece intraocular lens into the bag. And the next step was to do, just to see, I wanted to see whether how much of iris is there. And I think in some areas, except under the superior aspect, most of the iris was quite pliable. And so here I'm using a 10-0 Proline to suture the iris. You have to take multiple stitches as close as possible, and then go all around. And sometimes the iris can be very friable and can cheese wire, as happened in this case. Particularly in this area, there was a lot of cheese wiring. And I was not able to, though I had repeatedly put the sutures, it was not staying back. So anyway, I went all around. I had to go superiorly, sit superiorly from temporal to superior position. And finally, I was able to get some amount of encirclage done, though it didn't look really very good on the table. It looked quite large. Post-operatively, with a little bit of constriction of the pupil, her pupil size came down. From a very large pupil, it came down. And this portion, which was under the lids, it actually didn't bother her. Because of that, her glare came down significantly, and her vision also improved. So if I have time, I can show you one more case. This is my 4th case. And again, a patient who had a shuttlecock injury and came after about, say, a month or so. And you can see that the lens is dislocated. Fortunately, there was no other problem. There was no retinal problem in this patient. So using the first technique, we used the same lens. It's a multi-piece lens. So we used the same lens and exteriorized the haptic and brought it out and did a glued IOL on this patient as well. So ultimately, the most important thing is in patients where the lens can be salvaged, it's important that we try to salvage the same intraocular lens as I did in these 3 patients. But in cases where it's not possible, you might have to remove it and then refixate or reintroduce another intraocular lens. So with these few cases, I'd like to thank once again Dr. Rupesh and Dr. Gangadhar for giving me this opportunity to speak on wobbly sinking lenses and to take part in the 5th APOTS. Thank you once again.
Thank you, Sujata, for the wonderful videos and the wonderful presentation. I think the different ways to skin the cat, and you have done it so well. And since we have some time, because these speakers they are not there, and we have some time for discussion, let's start the discussion with the chairpersons, Dr. Parindra Basam, Dr. Shukla, and Dr. Indra, and for the first 3 talks. That is on hyphaema, and then followed by the hypotony by Victor, and then the wobbling and sinking IOLs as well. So, Purendra, you have anything to add on this first three topics?
I think all three were taken care very nicely, and we'll go one by one. I think let us discuss on hyphaema. First, we should take hyphaema and how to proceed in cases. So, I was thinking, Dr. Shams, when should we think that we should see that we should remove the total hyphaema case and remove the blood clot from the anterior chamber? When do you think it is? Dr. Shams, are you there?
Yeah, he's there.
Yeah. You unmute and.
Yes, I'm here. In my clinical practice, usually I used to see if it is a total hyphaema, then I used to see the intraocular pressure. And if intraocular pressure is rising gradually and it is more than 2 days, the intraocular pressure is almost 50 millimeter of mercury. In that cases, the total hyphaema to remove the blood clot. If it is a half, one third or half hyphaema, and intraocular pressure is 25 millimeter of mercury, and it is more than 5 days and not responding to conservative management. In that case, then I used to plan for the removal of the hyphaema, and in that case, if it is a small hyphaema, even partial hyphaema that covers the half thickness of the anterior chamber, I used to do a very small incision. But if it is a very large clot, and in that cases, I used to go through a scleral pocket and through the manual small incision cataract surgery like that. I used to remove the clot.
The way you have shown in the video. Actually, this thing, what I want to bring into is the glaucoma part and this blood staining of the cornea, which I want to highlight over here, bring to the fore that we have to avoid blood staining of the cornea, and secondly, we have to avoid the damage to the optic nerve due to rise in intraocular pressure. So if the intraocular pressure is more than 50 millimeter for more than 48 hours, and there is a total hyphaema, then we should do a simple paracentesis. What I personally do is I just go and do a paracentesis and remove the blood from the anterior chamber. Just by paracentesis, just depress the posterior lip and it comes out. That helps us to decrease, and most of the blood can be removed that way. And if the pressure is on the normal side, then we can wait for a week. If the pressure is around 25 or so, then even with the full chamber, we can wait. And what I have observed is after a week or so, it starts coming down, and within a week, it decreases. Thank you. Dr. Mohan, anything you want to add?
Tell me. Yes, with all this precaution to prevent the blood staining, if the blood staining happens, then what do you do?
Keratoplasty. If the optic nerve is good, yeah.
You can wait for some time. Normally, over a period of time, it can become all right. But
no, but I think dense blood staining. What I have seen is that we have to do keratoplasty in such cases if it is not cleaning, if it is not clearing.
That has done a few cases.
What do you do if there is blood staining?
You're asking me.
No, Sujata. No, if there's a blood staining, what do you do?
No, blood staining, I think we should not allow it to go that far.
I know, but if it happens after all the patient reports to you with blood staining.
Late.
Then, if the cornea is not improving, then we'll have to go for a lamellar keratoplasty. Desec.
Okay, that's what I want. I think. Surendra, that's what I think.
Cornea is very forgiving. Most of the time.
That's why we need to wait for some time. Depends on the severity of the pressure.
If it is a small kid.
Can I say something, Mohan?
Yes, sir.
Yes, sir.
And if the normal symptom is that you'll have to wait for 3 to 6 months if the blood staining is there, and then you can go in for any corneal graft procedure. One
yes, sir.
Too hurriedly to just.
That is what I said, sir. That is what exactly it seems.
Most of the times, cornea is very forgiving, and
most of the time we have to.
they improve very well, so we can wait. And then maybe as a last resort, go for surgery.
But if it is a child, you are also concerned about amblyopia.
Amblyopia.
Amblyopia. Need to be
Amblyopia.
Dr. Indra, you have anything to say?
Thank you very much. Many times, IOP, we have to be very careful regarding the intraocular pressure because people jump into trabeculectomy, so at least traumatic hyphaema, we can wait for after the we remove the blood and whatever, what procedures all Dr. Norman has shown very well. We can at least wait for a month, before we do a trabeculectomy.
Right. Absolutely.
We shouldn't jump into doing trabeculectomy too early. And also I want to add one point to Dr. Norman's presentation, that diabetic retinopathy, especially proliferative diabetic retinopathy, we are getting people with hyphaema. Even they just say that small injury, like I had a patient saying that her granddaughter just threw the remote, remote control, and she didn't have any injuries external, but she has total hyphaema. So later when the hyphaema, we had to remove the plot and everything, and later we saw that she had proliferative diabetic retinopathy, new vessels. So this is also another important thing.
New vessels in the iris. Yeah, that's
the new vessel actually, I give antivascular endogenic growth factor, and usually it clears. If it's due to a new blood.
Anti-VEGF.
Yes.
And because all these people, these patients, they are on antiplatelet and anticoagulant agents. So we have to stop them also carefully.
That's what
there is a hyphaema here.
Yeah.
So another hypotony.
Can I share one thing?
Yeah,
So this is very much important.
Quick one or two comments. Yeah. Yes, sir. Yes, sir. Please make it short and sweet so that we'll, because we have one more talk that is by me, and that's on the keynote address. I'll give it.
Yes.
Yeah. Please make the comment, sir.
Sir, I want to tell that after 1 month, it is very much important to do the gonioscopy to exclude angle recession. For the residents, some residents are also seeing this presentation. An angle recession related with the hyphaema, the possibility of glaucoma is more, 20 to 30%. In my personal study, I've seen that this is very important, that if patient have an angle recession, we have to check the intraocular pressure gradually. And another one thing is, if there is a early corneal staining, and if the intraocular pressure is normal from the very beginning, in that cases, I saw 3 or 4 cases in my experience, the corneal staining gradually diminished, and if prior the intraocular pressure should be normal, because if the intraocular pressure is higher, that corneal endothelial decomposition may occur. So in that cases, intraocular pressure should be controlled. Either you have to go for the keratoplasty. Thank you.
Okay. What I will do is I will just make
our audience is desperately waiting to listen to you, sir.
Yes,
so
sir.
Maybe with that, can I
invite?
Yeah, so can I invite the keynote speaker for this session?
Thank you.
And who's none other than the champion and of the IPL, the Trauma Premier League, or whatever you call it as a cataract Premier League. So Dr. Mohan Rajan to you, and Master of Master, Trainer of Trainer. I think without further ado, Dr. Mohan Rajan. Thank you.
Are you able to see my screen there?
Yeah.
Make it full screen.
Ophthalmic Premier League. He has done about 50 successful winner.
Yeah.
55.
55, sir.
55, sir. Anyway, let me thank again the APOTS, Dr. Gangadhar, Dr. Natarajan, and Dr. Rupesh for the wonderful opportunity. I'm going to show you 12 different cases, scenarios in my 12 minutes talk. And as you all know, traumatic cataracts is a different ball game because of the pre-existing posterior capsule rupture, zonular dialysis, posterior synechiae, hydrodialysis, problems in the cornea, calcified anterior capsule, and you can even have nucleus drop because of the hydro rupture or the pre-existing posterior capsule tear. This is a 16-year-old male, blunt injury with the cricket ball. You can see that I'm doing, it's a fairly intermittent cataract. The cataract is a little intermittent. It's very difficult to find out whether the posterior capsule is torn or not. And because you can see here, as I'm doing the phacoemulsification, and you can see that there's a burr hole on the posterior capsule, which is nothing but a pre-existing posterior capsular tear. You can see that the pre-existing posterior capsular tear. Being a soft cataract, I introduced this viscoat into the anterior chamber to make sure that the anterior hyaloid is fairly well protected, and then went ahead with the phacoemulsification. And now and then injecting viscoat. The viscoat acts as a very good tamponade and makes sure that the anterior hyaloid is not ruptured. But in this case, because of the posterior capsular tear was little large, there was definitely an anterior capsular rupture, and there was a vitreous loss as well. So fortunately, I was able to remove the nucleus and the remaining the epinucleus as well. And then I did an anterior vitrectomy and put in a lens, and the patient did very well. This again is another patient with the 8-year-old male. While he was playing with his brother, he had a stick injury. You can see there is a small corneal tear as well. You can see there is a pre-existing Argentina flag sign on the anterior lens capsule because of the stick injury. And you can see that the Argentina flag sign is nothing but the capsule getting extended to the periphery. And being a very soft cataract, I just did a lens aspiration by means of a coaxial lens irrigation aspiration. And you can see that 2 pillars of the anterior capsule, which is typical of an Argentina flag sign, and introduce viscoelastic every time you come out of the eye, then convert that Argentina flag sign into a semicircular capsular excess, and then go ahead with the lens implantation in the bag, and the patient did very well. Again, shuttlecock injuries are probably the worst injuries as far as the anterior segment injuries are concerned. As far as the cataracts are concerned, subluxated cataracts are concerned, you can see the subluxated, huge subluxation there, and almost about 4 or 5 clock hours or even more than that. I put a CTR right in the beginning because I want to make sure, and I want a good this thing. You can see another patient with a stone injury, 10-year-old female. You can see a gross subluxation. These patients, it's very difficult to fix this and maintain this thing. So you can see the lens is also wobbling there, and you can see the tremors on the lens as well. I did a pars plana or what you call pars plicator lensectomy. I put scleral flaps at 180 degree and went ahead with the pars plana lensectomy. You can see that. And I always use a pars plana infusion for these patients, or you can do with an anterior chamber maintainer also. And more importantly, the 180 degree flaps are there to make sure that this patient, we do a glued IOL after this procedure, and the patient did very well after the surgery. So this is a stone injury, which is very, very common. Again, a blunt injury. Again, you can see this traumatic cataract. It's very difficult to find out whether there's a pre-existing PCR or not. You can see there's a sudden deepening of the anterior and the posterior chamber, which is again very, very important for you to understand this. Okay, and once you find that the anterior hyaloid is ruptured, always do the vitrectomy first and then remove the cortex. Because every time you remove the cortex, the vitreous will get you can produce traction on the vitreous base. And you can see that since the anterior capsular excess is intact, I put a multi-piece lens in the sulcus and captured this lens into the capsular excess margin, and the patient did very well. And this, by capturing doing the optic capture, you are able to prevent this UGH syndrome and also maintaining long-term centration of the lens as well. You can see another patient with a cracker injury. This cracker injury, this patient came to me almost after about 7 or 8 months. You can see there's a calcified anterior capsule, which is very fibrotic anterior capsule as well. And you can see this is a 37-year-old male and a fairly dense nucleus sclerosis also. And another important thing is that you can see that I'm doing a capsular excess. There is also some synechiae inferiorly. There's also a corneal tear which has been previously repaired, and you can go ahead with the bimanual irrigation aspiration in this particular patient. I can see that epinucleus. As I am removing the epinucleus, you can see there is a hole in the posterior capsule as well, which is again very, very, very typical of these cracker injuries which you get because of the fibrosis which the cracker injury produces on the anterior capsule as well as in the posterior capsule. So this, you can see that posterior, you can see something like a fibrotic anterior capsule as well as the posterior capsule. There is a posterior capsular tear. Fortunately, there is no disturbance of vitreous, and the patient was able to put the lens in the bag, and the patient did very well. Again, posterior synechiae, because of chronic inflammation, because of trauma, and posterior synechiae, which the trauma itself induces. And you can see that I release the posterior synechiae. there is usually a small membrane which is there, and the membrane also I try to remove that, and you can go ahead with the iris hooks and dilate the pupil, and then rest of it becomes a child's play for you, because once the pupil is dilated, the only thing is you have to be aware of these patients of zonular weakness and zonular dialysis, and sometimes the lens can start sinking into the vitreous as well. Again, another patient with a 30-year-old injury with the cricket ball, you can see the dense fibrosis which is there in the anterior segment, and capsulocortical adhesion, the iris, there is a lot of membrane, because again it's a patient who had an injury for almost 2 to 3 years and came to me, and there is a fibrotic anterior capsule, the young fellow, 30 years old, and he had an injury about 3 years or 4 years back, and slowly progressing cataract and slowly progressing inflammation in the eye. And I tried to do a lensectomy, but I thought the lens will be very soft, but unfortunately for me, to my shock, I found the lens was quite this thing. So I did a phaco and intracapsular phaco in this patient, and the patient did very well after a glued IOL after 3 months. Again, be aware of the hydrodissection in these patients. If you do hydrodissection, you can have a nucleus drop. Again, the patient with the traumatic cataract, with the trauma he had with the shuttlecock long time back, and can see that as soon as the assistant puts the viscoelastic on the cornea, the nucleus disappears. This is because of the pre-existing rupture. If you do a hydrodissection, there can be a blowout, something similar to what happens in the posterior polar cataract, and can lose the nucleus rapidly into the vitreous cavity as well. So again, the nucleus going into the vitreous cavity, don't try to chase this nucleus. Always clean up the anterior segment and then go into the vitreous cavity. And since I do both anterior and posterior segment surgeries, I brought the nucleus up and then went ahead with the patient with the lens in the sulcus, since the capsular axis was intact. Again, another patient with shuttlecock injury with iridodialysis and traumatic cataract and posterior synechiae, and see that the posterior synechiae, you can see the inferiorly there is an iridodialysis as well. And another important thing is I left that synechiae there because I didn't want to release that synechiae, because I don't want the iris to come forward. So this is they have to do some improvisation in traumatic cataracts. On the table, you decide what is good to have a plan A, plan B, and plan C, and work accordingly. You can see that this is a small flap there, which I think, being a soft cataract, I just aspirated the whole thing, and the whole thing came out. And then I went ahead with the iridodialysis repair, and the patient did fairly well with a fairly good vision. Again, another patient with the corneal tear, traumatic cataract. Again, I think it was a stone injury with the corneal tear. I'm sorry, the carpenter working with the scissors and hammer. You can see that there's an intralenticular foreign body as well. The intralenticular foreign body, that is inside the lens, is a very, very tricky situation. So the corneal tear was repaired. I went ahead and because you do not know whether it is penetrated the posterior capsule, whether it is lying in the angle, whether it is lying in the zonules as well. So you do not know exactly where it is. So I did the anterior capsular axis with the trypan blue. I tried to locate that foreign body, and you can see that this is a metallic foreign body which is there inside, fairly big one, and it's about almost 2 to 3 millimeters in size. And you can see the axis, the long axis of the foreign body has to be kept along the long axis of the incision. And this is very, very important. I tried to remove with the McPherson forceps, but ultimately I used another forceps to remove this foreign body. You can see here, this is the lens holding forceps, which you use for the lens folders, for the Acrisoft lenses, the holder and folder. I used that to remove the foreign body and went ahead with these things. Please be aware that sometimes these posterior this can damage the zonules, damage the angle as well, and damage the posterior capsule as well. We have to be very careful and use the slow motion technique. Fortunately for me, this patient did very well, and I was able to remove the cataract and put the lens, and with fairly good results post-operatively as well. You can see there's another patient with Jallikattu injury. Jallikattu is very, very popular in a place where I come from, that is in Tamil Nadu. It's a game with the Bulgur, and the Bulgur injury you can see here. And this is the subluxated cataract, and totally subluxated. Actually, the part of the lens was tilted into the vitreous, the part of the lens was tilted into the anterior chamber. I tried to do a phaco, but to my seeing, it is only showing overconfidence. The entire lens dropped into the vitreous cavity as well. So I had planned for a glued IOL. You can see the 0-180 degree flap in this particular patient. You can see the pars plana infusion of also for this patient, and I went ahead with the glued IOL.
1 minute remaining.
Yes, in this particular patient, and you can see that I was saying pressure cooker injury. I showed this in the JEC webinar a couple of weeks back. You can see this pressure cooker injury wherein it can produce very bad injuries and rupture of the globes, and very commonly seen. You can see that the whole lens has got, because through the rupture it has come out, and I'm doing what is called an extraocular lens extraction. You can see that opening the conjunctiva. Once I open the conjunctiva, I find that the lens is there underneath the conjunctiva, and the whole lens is taken out through that small incision there in the conjunctiva. And subsequently, you can see the rupture of the globe also, which is there taken care. You can see that I'm doing something like an extracapsular extraction, which is extraocular. You can see the huge rupture of the globe as well. And this patient did very well with the rupture globe repair, and followed by a secondary implantation of the lens of the glued IOL after 3 months. So the take-home message is, as far as the traumatic cataracts is concerned, avoid hydrodissection, low flow parameters, slow motion phaco, anticipate PCR, always use bimanual techniques with the bimanual irrigation as bimanual vitrectomy, anticipate the worst. All is well that ends well. Thank you very much, APOTS. Once again, I'll stop sharing the screen. We have quick, I think, another 5 minutes for a quick discussion on this, all the topics which we mentioned. Thank you very much. Purindra, all yours.
Thank you. Very nice presentation. I think you have covered all gamut of trauma cases in your 12 minutes presentation, and how to manage them so nicely. Very well managed, all these variety of cases, but at times you have rightly said that there is a high chance that we should avoid hydrodissection because of the high chance of primary posterior capsular tear in, and that's why we avoid hydrodissection. And secondly, we should always be very, very careful, because many people, they do not hydro, but visco dissection.
Yes.
That also should be avoided in such cases, and that is how. And the phaco should be done very carefully and gently in these cases. That is a low flow and low bottle height, low parameters should be done.
I mentioned that as well.
Yeah, that is cool.
Indra, Indra, I would like to say something, Dr. Indra.
Doctor. Very great videos, and the way you tackle the traumatic cataract, it's always a nightmare, So I just wanted to ask, how about using the capsular hooks? How about your experience with the capsular hooks?
The capsular hooks are done with the, I wish Dr. Daphne had given a presentation. Capsular hooks are done with for the subluxated cataracts. For the subluxated cataracts, I use the capsular hooks regularly for the capsular excess margin. Many people use iris hooks for the capsular excess margin, but I don't do that, because the iris hooks please rest on the capsular excess margin. There is a possibility of tearing the excess margin. And if the excess margin is torn, the whole battle is lost. So I always use the capsular hooks for the stabilizing the bag. I want circumferential stability as well as radial stability. Radial stability is given by means of the capsular hooks, the circumferential stability by means of a CTR. So these two things I will do that in the case of subluxated cataract. Because I thought I will not go into the details, because there was a talk by Daphne on the subluxated cataract. I didn't go into the details of the subluxated cataract.
One more thing that we have to have, all of us are not having the capacity to do VR surgery also at the same sitting. So we should keep our VR person ready when we are managing such traumatic cataract cases. So that OT should also be ready to manage posterior dislocation of cataract or lens fragment. Yeah.
Very Purindra, exactly that's the point I was trying to ask. So Dr. Mohan Rajan, definitely all great videos, and you should put a disclaimer that this stunt should not be used by the new surgeons and all. Maybe because our delegates, some of them will be new surgeons or not so experienced as you. Can you say them some words of caution, like Dr. Purindra said, there should be a VR surgeon backup, just so that they should not go home and then suddenly start trying?
You see, traumatic cataracts, as I told you, it's you have to have a plan A, plan B, and plan C. So every case is going to be different.
Okay. 1 minute
You
remaining.
need to have a VR surgeon backup, definitely. 100% you need to have a VR surgeon. Anytime the lens can drop into the vitreous. Only thing is, if you don't have a VR surgeon backup, don't chase this lens with the phaco probe into the vitreous cavity. You end up in a giant retinal tear. Only thing is, you can close up the anterior segment, do something, or put a lens in the sulcus, and then refer it to the VR surgeon, or ask a VR surgeon to come and do it at a later point of time.
Last thing that we should have all these things available with us, like CTR, like capsule retractors, like Prolene or other sutures available to us. And we should not do things in a haste. We can do, like if we want to place an IOL, we can do it on a secondary sitting if we are not comfortable, if we are not having things with us. So trauma should be tried to be managed in one sitting if you are comfortable. Otherwise, you can close it nicely, remove all the vitreous from the wound and from the section, and make the eye clean, and so that the corneal endothelium is also protected, cortex is removed, there is no secondary glaucoma, chances of secondary glaucoma, and then you can manage, put the IOL as a second sitting. Thank you.
Absolutely.
So we'd like to thank Dr. Mohan Rajan. Maybe you'd like to conclude the session so that we can.
Yes, we'd like to, because I think
I just wanted to say, Dr. He has presented on, Dr. Victor has presented very nicely on hypotony. I think that has to be appreciated over here. I really appreciate the way he has presented and covered this topic beautifully. Thank you.
Very nice. All the topics have been well covered. And any other person has to say anything, because we got another 30 seconds more. Yeah, I will conclude the session then, Rupesh.
Thank you, Dr.
I would like to sincerely thank all the speakers for this wonderful session. I'd like to thank APOTS for this, and also like to thank Dr. Purendra, Dr. Shukla ji sir, and Dr. Indra for chairing this session and making this session very interesting and very stimulating, very exciting as well. Thank you very much.
Thank you very much, Dr. Mohan Rajan and the team, and we really appreciate. And it was a really wonderful video. And I think I've seen Dr. Sujata's video for the first time, but probably I need to now think about where to send my traumatic cataract, to Dr. Mohan Rajan or Dr. Sujata. I think that's very tough now for me.
Thank you very much. Thank you very much, Rupesh.
Yeah, thank you very much for everyone. Now you can continue to see these clips which are going on as you are enjoying the clips, and I will request the backend team to kind of switch off the videos and everyone. And we'd like to take a commercial break here. But in this commercial break, what we are going to do is we are going to thank our supporters, and these supporters are none other than the team Microvision, led by Mr. Ashok, Mr. Navneet, and the entire crew of Microvision, who has been working tirelessly, immensely, and I've never seen such an industry support ever happening. And a lot of times in the real meeting, we don't have that much of time to interact with them. But I think in the last few weeks of interaction, I'm sure Dr. Ganga and Dr. Prasad Mohan and all will agree how this team has worked very closely. I think with that, we'd like to have Dr. Ashok Kumar Subramaniam from Microvision to kind of say a few words about how they have kind of taken us to this stage. Thank you very much.
Thank you, sir.
Ashok.
Thank you. Yeah.
Thank you, Ashok.
Thank you, sir. Firstly, I'll say namaste to all doctors across the globe. And on behalf of Microlabs, I take this opportunity to thank APOTS and the organizing team headed by Dr. Gangadhar Sundar for considering my organization, Microlabs, to be a part of this wonderful academic initiative. We are a leading pharmaceutical organization in the areas of cardiology, diabetology, psychiatry, critical care, general medicine, and of course, not the least, the ophthalmology. We are present globally from east to west. We have world-class manufacturing units across the country and also outside with all international accreditations. Our strengths are well-equipped R&D with more than 600 scientists engaged in formulation research. Doctor, today, Microvision in 2020 successfully completed 2 decades of supporting ophthalmologists in providing the best care to patients through our innovative formulations manufactured in their self-owned manufacturing units approved by US FDA and other important global accreditation. This is our factory at Bangalore, which is a US FDA plant, and this is our factory at Sikkim, which has recently started in 2017, which is a complete robotic equipped factory. Both these factories are totally dedicated for ophthalmology. Microvision caters to all ophthalmic conditions through its wide range of ophthalmic medications with a special focus in the areas of ocular surface disease and glaucoma. Micro Labs is committed to stay alongside the ophthalmologists in extending the best global eye care to the patients. Today, this conference is of great clinical relevance, and we wish APOTS a great success. And thank you very much.
Thank you, Ashok. Thank you.
Thank you very much, Ashok and Navneet. And I should give credit to Dr. Giridhar for introducing microvision to APOTS. And since then, Micro Labs and APOTS have been working together. And we hope to continue to seek support from it. And is that right, Dr. Natarajan?
Yeah, definitely, I think so. Definitely, I think thanks a lot for the support, Ashok and Navneet and the entire Microvision.
Maybe I have a quick word from Dr. Ganga about the support from Microvision before we move on to the next session. Dr. Ganga, sir.
Yeah, no, I appreciate it. When we conceptualized this meeting, we were looking for a partner who will probably just make sure that the scientific content is what pushes through and be organized in a very efficient way, because we are not just a Asia Pacific meeting, we're a global meeting. And without any restrictions whatsoever, without saying no, I've not heard a single negative word. Microvision, Micro Labs, and the organizing team of APOTS and all the speakers and all the chairpersons have come together. So a big thank you to them. And this is probably going to be only the beginning of things of even more higher quality presentations from APOTS. Thank you. Thank you, sir.
Thank you, Dr. Ganga, President APOTS. Now we'll continue with the session. And it is through the Microvision we all got connected onto this technology platform, and then different parts of the world, we are all connected on this weekend. Now with that, session number 3 for day 1 is will be taken care by none other than our very young, extremely dynamic, motivational leader. I can call him as a leader, Akshay Nair from Mumbai. I present to you Akshay, who will introduce his team and will take us through why APOTS is called as APOTS, not ocular trauma, why it is called as ophthalmic trauma. Akshay, over to you.
Thank you so much, sir, for those kind words. As we come from inside the eye to outside the eye, the ocular becomes extraocular and adnexal, and hence ophthalmic trauma. Joining us in this session is the chair, Professor Ashok Grover, who will be with us shortly. Padma Shri Award winner. He is currently the oculoplastic surgeon at Vision Eye Care Center in New Delhi. Joining him are our 2 co-chairs, Dr. Yunia Iravati, the senior oculoplastic surgeon working with JEC Eye Hospitals in Indonesia, Jakarta since 2004, and Dr. Rohit Saiju, who is an oculoplastic surgeon, very active on the Southeast Asia Ocular Center in Nepal. Our first speaker here is Dr. Preeti Uday, and it's an honor for me to introduce Dr. Preeti Uday, who is an oculoplastic surgeon with DRR Hospital, fellowship trained at Shankar Netralaya. Many, many years ago, a decade ago, my first ever teacher in ophthalmology was Dr. Preeti Uday, and coincidentally, it's Teachers' Day in India today. She'll be speaking to us on orbital fractures and complications, the lessons learned. Dr. Preeti, if you can start your screen sharing.
Happy Teachers' Day.
Happy Teachers' Day to everybody. My teacher is Dr. Natarajan.
Dr. Preeti, you're on mute, so if you can unmute yourself.
Good afternoon to all of you, and namaste from India. Is my screen visible? Okay, so I'll be speaking on orbital fracture complications and lessons learned. though there is a whole list of complications that is described in the textbooks, both intra as well as post-op complications. In my 7 minutes talk, I will be discussing the most common ones and the lessons that we have learned from this. So this was our first patient who had a zygoma fracture and he had a repair done, but he came to us with lacrimal mucocele. And my first point that I want to reiterate today is check the lacrimal drainage system in all trauma patients and repair along with the fracture repair. So if you need to do a DCR, do it along with the fracture repair. So in this patient, we have done a CT-DCG. You can see that there is flow in the right NLD, but there is no flow in the left NLD. And so a CT-DCG is a very useful tool in these patients because you can know the relationship of the sac with the existing fractures, with the existing plates, and decide your site of ostium in these patients. There's another patient here who had a naso-orbito-ethmoid fracture, and we have done the fracture repair with a plate and done the DCR in the same sitting. He had a lower canalicular block, so we have used the upper canalicular intubation system in him. His enophthalmos was corrected and the DCR was done in the same sitting. Another patient who has an orbital trauma with bilateral nasolacrimal duct obstruction. This was the 3D printed skull model. We have used a virtual imaging as well as intraoperative navigation system, done his orbital repair as well as a DCR simultaneously. You can see the silicone intubation in him. He had a lower lid defect like this, a lower lid retraction, and we have used dermis fat graft to augment his soft tissue in the lower eyelid, which was corrected pretty well. But the problem now we had was that he needed a transnasal wiring for his telecanthus. And now we had two ostium here, and we had this plate very close to the ostium. And it was difficult for us to do the transnasal wiring. Though we managed it, the lesson that we learned from this case was that the telecanthus repair should be done along with the DCR surgery. Now, another important problem that we see in the fracture patients is diplopia. And many a times we find that even if there is no muscle entrapment, if the ocular movements are full, still the patient has diplopia because there is a hypoglobus. So the globe position is the first important thing that you must see in a post-trauma patient. He has a hypoglobus and a pseudotosis, not because of a floor fracture, but because of a roof fracture. And we have used a bicoronal incision and used titanium mesh to reconstruct his roof, and his hypoglobus gets corrected, diplopia gets resolved, and his pseudotosis also gets corrected. Now, another important reason for persistent diplopia in patients is the surgeon has not done the force duction test properly. So I like to reiterate here that force duction test should be done at various stages during the surgery of fracture repair. Not only when you start the surgery, but also after you reduce all the intraorbital contents and also after placing the implant. Now, this is the last step which is missed by many surgeons. After placing the implant, you must do a good force duction test to rule out any impingement in the implant, which will then later lead to diplopia. Another important reason that we find is delay in the surgery. Sometimes when there is a large fracture, the muscle may be just prolapse into the fracture, in which case we ask them to wait for a week or 10 days for the edema to subside. But if you have muscle fibers entrapped in the fracture fragment, there is no point in waiting for a week or 10 days. You must take up these patients early so that the muscle necrosis and trauma is prevented and post-op diplopia is prevented. Now, another common complication that we see in post-op patients is a residual enophthalmos. Now, whenever you have fat atrophy, the enophthalmos is not this gross. The most common cause of enophthalmos is inadequate bony wall reconstruction. Like in this patient who had a zygoma fracture repair, but the surgeon has left behind the floor and the medial wall, and also the zygoma is inadequately repaired. Now, the most common mistake that is made in these repairs is use of a sheet implant. When you use a sheet implant, you are not able to reconstruct this normal S shape of the floor. This posterior convexity is important to correct the enophthalmos. And also another mistake is non-alignment of this sphenozygomatic suture. So many a times, if the fracture is comminuted, I use a mini plate to fix even this suture if the fracture is not stable after 2 or 3 point fixation. So we had used intraoperative navigation for this patient, and this was the result in the post-op period. So as I said, inadequate reconstruction is the most common cause of enophthalmos. We have another patient here who has post-op enophthalmos, a lid retraction, as well as a lag of thalmus. Now, this lid retraction we very commonly see in post-traumatic patients because we deglove this entire anterior lamina, And post-operatively, when there is fibrosis, this entire cheek tissue pulls the lid down. And this most commonly seen in transcutaneous approach, but we also see it in transconjunctival approach, in which case we also get entropion many a times. So what I do is, when I do secondary reconstructions of these patients, I do a mid-face lift and anchor the soft tissue to the drill holes in the inferior orbital rim, so that this does not happen in the post-op period. And also, when you do a second surgery in these patients, the chances of fibrosis is more, and therefore we use antimetabolites like 5-FU in the post-op period. Another problem that this patient has is this kind of a deformity because his zygomatic arch was not reconstructed. So this was the CT scan when I saw the patient, and you can see the zygoma is inadequately reduced, and again the floor is left behind. So we have used intraoperative navigation. This is the eye tracker. And I have used a pre-auricular approach, which is a useful alternative
1 minute remaining.
For the zygomatic repair. And you can see that the enophthalmos is well corrected. The lagophthalmos is also corrected because the enophthalmos is corrected. And the zygomatic arch is also corrected, and the facial width is restored. So these are the important points in post-op enophthalmos. When you have a severe soft tissue injury and bony injury, you must do the bone as well as soft tissue at the same time for you to get a good result. This patient has residual ptosis and he needs a small scar revision to improve his cosmesis. Similarly, when you have a lot of soft tissue loss in the lower eyelid, dermis fat graft is a useful tool to reconstruct and augment the soft tissue in the lower eyelid, as we have used in this patient with good results. Now, sometimes when you use porous polyethylene implants, when there is a lot of scarring in a complex fracture, and if the implant is not anchored well, it gets pushed anteriorly and you can palpate the implant in the lower eyelid. So in this patient, we have to remove the implant and augment the soft tissue with dermis fat. We need the canthoplasty in the cosmesis. So this is another patient where there is ptosis as well as a traumatic telecanthus, which we have repaired along with the bony wall reconstruction using navigation. Thank you very much for your kind hearing. I'm sorry for overshooting the time by a few seconds.
Thank you very much, Dr. Pradeep, for the nice presentation. Now I would like to call up second speaker of the session, Dr. Farzad Pagdil. He is a dynamic oculoplastic specialist from Middle East, and he is working in Farabi Hospital, Tehran University of Medical Science in Iran. And he is the author of many high impact publications in the world, and his main interest in the oculoplastic field is lacrimal surgery. Thank you very much for loading your presentation. Good to see you, Farzad. Are you okay to proceed? Over to you.
Thank you very much. Am I visible?
Yes. Yes, you are.
So, thank you very much for your introduction. I'm going to talk about optic canal decompression. I want to say if there is any still role for optic canal decompression in optic neuropathy. So I have no conflict of interest to declare. So we know that the visual loss after trauma relevant to optic neuropathy is termed traumatic optic neuropathy. The mechanism of injury differs in the different series. In our series, we showed that road traffic accident is the most common cause of the traumatic optic neuropathy. In some other actual series, falling down or assault have been reported to be the most common cause of TON. So we know that we can classify TON based on the mode of injury and location of injury as direct or indirect, anterior, posterior. I will show you like anterior TON, like avulsion when you have torsion of the globe over the axis of the optic nerve, or direct actually trauma by an object or laceration of the optic nerve behind the globe. It's another example of anterior direct TON. In the case that we have bone impingement or bullet, the posterior part of the optic nerve, we have posterior direct traumatic optic neuropathy. Sometimes we have both. We can have both partial avulsion and optic canal decompression, both direct and indirect causes for the traumatic optic neuropathy. So the most common cause is indirect TON. It happens when we have trauma to the forehead or mid-face, that the force is transmitted to the orbital apex, especially the optic canal, and when the falciform ligament touches the optic nerve when it comes into the cranial fossa. This is the most common actually site for injury after indirect traumatic optic neuropathy. So basically, we have two types of damage, primary and secondary. When we have coup and anter-coup, or acceleration, the deceleration energy transmitted to the apex or through the falciform ligament to the optic nerve, we have shearing forces or compression or stretching of the axons of the optic nerve. It causes disruption of optic nerve microcirculation. It can cause contusion necrosis of RGC axons. This is called primary damage, when the force directly damages the axon. After a while, we have edema in the axons. It causes compartment syndrome inside the bony optic canal. It causes exacerbation of ischemia and RGC necrosis as a secondary damage. I won't go through the cascades like calcium dysregulation or bradykinin or other mediators here. That's the rationale for optic canal decompression, to reverse the compartment syndrome inside the optic canal. I want to show you that several reviews have shown that even if you do not do anything, just observe the patients after indirect traumatic optic neuropathy, about 50% of patients have been shown to show some kind of improvement in visual function. And again, with treatment like optic canal decompression or high dose or mega doses of corticosteroids, still we have about 50% actually visual gain in this patient. So let's summarize it. In direct TON or in anterior TON, we cannot do anything at the moment, but for posterior optic indirect traumatic optic neuropathy, we have options like medical treatment or surgical treatment like optic canal decompression. So I want to show you that we have different options for surgery in TON. I want to talk about just optic canal decompression. The rationale is to remove the compartment syndrome. We have different approaches to decompress the bony optic canal. We can do it like transethmoidal, transsphenoidal by using microscope, and nowadays by endoscope. We can approach intracranially or extracranially, transorbital, sublabial, or even supraorbital, like the recent article about that. So we have traditional indications for OCD mentioned in many articles and textbook, like optic canal fracture, fragments impinging the optic nerve, and non-improving visual acuity after treatment or observation in patients. So an ideal patient for OCD has been shown to be a case with profound visual loss like NLP or hand motion and optic canal fracture with bone impingement. Although I really doubt about that, because I've very rarely seen patients with bone impingement to show some recovery. So I doubt about these traditional indications for OCD. So basically, nowadays for OCD optic canal decompression, we prefer navigation-assisted endoscopic approach, transethmoidally or transsphenoid. This is actually a couple of years ago when I just started to do optic canal decompression. I started with transethmoidal decompression, just doing myodectomy classically, then approaching to sphenoid sinus. This was the case with NLP vision after optic canal fracture. You can see the optic canal here. This is the lateral optic keratoprosthesis. This is a very important landmark when you're doing the optic canal decompression with endoscope. You should take care of that. So we have many anatomic variations in this region. You should take care of the thing that you should do. Remove. This is the site of the fracture. You can see this is a linear fracture and the bone impingement of the optic nerve.
1 minute remaining.
So this is the classic one. So we want to say that is it a tradition to do optic canal decompression, or just we have evidence about that? We have lessons from international optic nerve treatment trial. It showed that there is no difference with doing optic canal or observation or corticosteroid patients with traumatic optic neuropathy. It's very difficult to interpret the results of the OCD because most of them have small sizes, are retrospective series, and very methodological heterogeneity and inclusion criteria. Cochrane systematic reviews and very recent systematic reviews have shown that, including that some studies, they have shown that OCD code resulted in actually significant improvement in vision when compared to observation. This is the forest plot favoring the optic canal decompression in these patients.
Time's up.
Okay, just let me summarize it. So we cannot say, because of that, evidence, we have low evidence of that to say this is the first line for treatment for traumatic optic neuropathy, but still we can offer to some patients with the severe visual loss. You should remember that OCD is not without any injury. It can injure the optic nerve. It can have injury the optic nerve, and OCD can be recommended or should be can be shelved. So we cannot say it should be shelved, nor we can say that it's the first line, but we can keep it for patients not improving in vision, and still it's still viable. But what we need RCTs to say something more about OCD. Thank you very much for your kind attention.
Thank you so much. We'll be taking questions altogether at the end of these sessions. So can I now introduce our next speaker, Dr. Syed Mehboob Qadir, who will be speaking to us on orbital foreign bodies and lessons learned. Dr. Mehboob is the oculoplastic surgeon at Bangladesh Eye Hospital in Bangladesh.
Thank you, everyone.
Yes, we can hear you, sir.
Okay. Am I audible?
Yes.
Okay. Okay. Thank you, everyone. Now I will talk on orbital foreign bodies and lessons I learned. I have no financial interest. I want to start with few case presentation. Case 1, the 11-year-old girl presented with chronic discharging sinus in the left upper eyelid. CT scan of the orbit show hypotenuse foreign body in the left superior orbit, supramedial quadrant of the orbit. MRI showed hypointense foreign body in the posterior part of the left orbit. We explored the patient and extracted multiple pieces of wooden foreign body. So lessons are, for detection of orbital foreign body, need good imaging modality. MRI is better to visualize or identify the wooden foreign body rather than CT scan. And if you found one foreign body, search for another foreign body during exploration. Now come to case 2. A 16-year-old boy presented with anti-wound point with pus with periocular swelling and pain. Plain X-ray showed radio-opaque foreign body in the right superior orbit. We removed a large size metallic foreign body that was 3.5 centimeter. So lesson is all large metallic foreign body and contaminated foreign body should be removed from the orbit. Now case 3, a 21-year male patient presented with anti-wound point that was sealed automatically and periocular ecchymosis. CT scan of the orbit showed hyperdense metallic foreign body in the posterior part of the left orbit near to lateral orbital wall with presence of sticking artifact. Patient was managed conservatively and we left the foreign body in the orbit as it is. So lesson is, if small, inert, well-tolerated metallic foreign body not causing any symptoms or sign or any reactions or functional deficit, better to leave as it is. Now case 4, 22 years male patients presented with the ruptured globe, diffuse subconjunctival hemorrhage and periocular swelling and pain. CT scan of the orbit revealed loss of contiguity of the globe and a metallic foreign body in the posterior part of the left orbit. Enucleation was made and removal of the foreign body was done at the same sitting. So lesson is, in the cases of ruptured globe, it is better to remove the foreign body at the time of surgery. Now case 5, a 50-year-old lady presented with chronic discharging sinus with history of DCR 6 months ago, and he presented pain and swelling and infection of chronic discharging sinus. Swab and culture sensitivity revealed no growth, no improvement of infection despite intravenous antibiotic therapy. Incision biopsy was done and histopathology reported chronic inflammatory cells. So we explored the patient and we found a gauze piece that was used in the DCR surgery. So lesson is, every surgery should be done meticulously to prevent postoperative ocular morbidity. When you have to suspect orbital foreign bodies, if the patient is presenting to you with the following presenting features like chronic discharging sinus, non-healing infection, anti-wound point, granuloma, periocular ecchymosis, painful proptosis, restricted ocular motility, loss of vision with a history of periocular trauma. Keep in mind, the patient may forget or omit the details of initial injury in some cases. A careful history should be taken to assess the possible nature of injury and pattern of orbital foreign body. Meticulous ocular examination is helpful to rule out ruptured globe, intraocular foreign body, traumatic optic neuropathy, orbital fractures, and orbital hematoma. Physical examination is helping to assess the associated injury like intracranial injury, injury to paranasal sinuses, facial injury, and any injury in the other parts of the body. It is difficult to identify the orbital foreign body without an imaging modality. There is no role to identify orbital foreign body by ultrasonogram. Plain X-ray only identify a radiopaque foreign body, but nowadays it is using as scanning purpose prior to MRI scans. The useful modality is non-contrast CT scan of the orbit, especially in the acute stage. In chronic stage, contrast CT is better. A CT scan with 1 mm cut, axial, corneal, or reconstructed sagittal section is helpful to delineate the orbital foreign bodies. But CT scan may give false result. The size of the foreign body is less than 0.5 millimeter, or especially in the acute stage of wooden foreign body. Wooden foreign body is better visualized by MRI, and it can be done after ruling out of metallic foreign body by plain X-ray or CT scan. We evaluated 44 cases. Among them, organic foreign body was 43%, metallic foreign body was 34%, and non-organic and non-metallic foreign body was
1 minute remaining.
23%. The most common cause of injury was accidental trauma. The younger age group was commonly affected than elder age group, and male was common than female. The most common presenting feature was chronic discharging sinus. All organic foreign body and large and contributed foreign body was removed from our patients. Now discussion, most of the reported cases showed the most common foreign body is metallic foreign body, but in our cases, the organic foreign body was highest in occurrence, that was 43%. Now take up message for identifying or examining a case of orbital foreign body requires high index of suspicion. CT scan of the orbit is the first choice of imaging modality. MRI can be done for wooden foreign body after ruling out of metallic foreign body by plain X-ray or CT scan. If you found one foreign body during exploration, search another foreign body. Remove all organic foreign bodies, large and contaminated orbital foreign bodies. Early diagnosis, surgical exploration, and extraction greatly influence the visual prognosis and final outcome. Thank you all for patient sharing.
Thank you, Dr. Mehboob, for the interesting cases series. Yeah, and especially in the South Asian countries, there are many vegetative traumatic orbital foreign bodies we do see in our practice. I am pleased to introduce next speaker for the session, Dr. Mariel Angelo Parulan from Philippines. Dr. Parulan recently finished fellowship from National University Hospital under supervision of Gangadhar Sundar in Singapore, and she is practicing in Philippines today. And she is going to talk about unusual pediatric trauma cases. Dr. Parwal, microphone over to you, please.
Hi, can you hear me?
Yes.
Okay, thank you. Hold on, let me sorry. Okay, good evening. It's an honor for me to be here today. I'm Mariel Parulan from the Philippines, and I would like to thank Dr. Ganga and the rest of the organizers for inviting me to share our case entitled No Trauma is Too Mild. So this patient came to us for periorbital swelling. 5 days prior, she was allegedly hit by a broom on the head by her 3-year-old sister. The next day, periorbital swelling was noted, which prompted consult with another hospital. CT was done, which showed normal findings, so they were sent home for observation. In the interim, however, there was progression of swelling, prompting consult with us. Birth and medical history were unremarkable, as well as systemic problems. So VA at the time was 2,400 for both eyes, but patient was extremely irritable and uncooperative. IOPs was 20 for both. There was bilateral chemosis with discharge. Cornea was hazy with superficial defect, and the rest of the intraocular examination was unremarkable. Her mother was actually able to document the patient with photos, and this was her on admission. So note the progression of swelling and proptosis. There was no RAPD. There was limited gaze on all directions. Note the bilateral lid edema, ecchymosis, ptotic lids, and significant lag of thalamus. And there was also axial and non-axial downward proptosis with resistance and retropulsion and no appreciable buoy. Extraorbital examination, importantly, showed diffused scalp swelling, and the rest was unremarkable. In summary, we have a patient with mass effect from bilateral superior orbits, subacute in onset, presenting with periorbital swelling and rapid proptosis in a 5-year-old Filipino girl with a primary working impression of a periorbital contusion hematoma with intraorbital hemorrhage. So her CT scan showed hyperdense lesions in bilateral orbits, displacing both globes inferiorly. There is effacement of the superior rectus levator complex with no bony defect seen. Zooming out, we will appreciate a significant subgaleal hyperdensity in the region of the vertex, extending up to both frontoparietal regions. So some differentials considered were an infectious cause, a neoplastic cause, a post-traumatic vascular malformation. Of course, we also suspected foul play from domestic violence because of the mild trauma, but very severe-looking hematoma and periorbital swelling. So we initially opted to do a temporizing procedure with canthotomy canthalisis and a trial of supportive therapy. We also referred to social service for investigation, but fortunately, systemic evaluation was normal, making foul play unlikely. Unfortunately, the patient did not improve. So this was her 2 days post-canthotomy canthalisis. And with the development of corneal abscess and a pending corneal perforation, a decision was made to do orbital evacuation. So we plan to do a needle aspiration, possible superior orbitotomy in case we encountered a dry aspiration. Needle aspiration resulted in 3 cc and 2.5 cc's of dark blood from the right and left orbit respectively. So this was the patient 1 day after, still with proptosis and lag of thalamus, but decreased. Also of note is the decreased lid edema. So note how there's already the presence of lid folds. 3 weeks later, she came back to us with BCVA of 2400 on the right from corneal scar and 2030 on the left eye. So this then confirmed our diagnosis of subgaleal hematoma with orbital extension. SGH with orbital extension is an uncommon complication of head trauma. It may be difficult to diagnose because the mild injury may be misleading and onset of symptoms may be delayed. It is actually common in neonates from instrument delivery and in young children from a scalp or head trauma. So recall our anatomy. At the level of the aponeurosis or Yergalia aponeurotica is a potential space that contains small emissary vessels. Any shearing forces applied even from a minor trauma would result in accumulation of blood. Yergalia extends anteriorly to reach the arcus marginalis, an area in the superior rim where it fuses with the periosteum. So blood can dissect and disinsert attachments here and accumulate within the orbit subperiosteally. Further migration is explained by weak and immature adhesion of periosteum and bone in young patients, and there is a unidirectionality of hematoma movement with backwater valve effect from that sharp angle between the roof and the forehead. And finally, orbital roof has no suture separation, which would have prevented movement of hematoma into the space. Besides trauma, there have also been non-traumatic causes such as the following, and spontaneous forms have been reported in the elderly. Pain and blurring may be variable, but evolution of symptoms can be drastic. No? So RAPD and lag of thalamus are contributing factors to severity. In these photos, notice the typical appearance of your hypoglobus, ecchymosis, your outstretched upper lid with significant corneal exposure. So when you have a constellation of these findings and a minor trauma of few days duration, look for your scalp swelling, and this would give you clues in making the diagnosis. So actually, this is the typical appearance of these patients. You have that swollen head, swollen forehead, and swollen periorbital area. Gold standard of diagnosis is still CT to delineate size and extent. It would usually present as a well-defined, high-attenuating extraconal lesion, commonly at the roof of the orbit. It would also rule out a fracture, which is important for needle aspiration, and of course, other mass lesions. But still, MRI is best for that. And another benefit is that it delineates different phases of bleeding, important in evacuation. So here it shows a well-demarcated T1 mild hyperintense and a T2 hyperintense signal in the superior quadrant of the orbit. This combination is telling of a late subacute bleed, and you might want to consider orbitotomy if evacuation is warranted. Blood tests and coagulopathy.
1 minute is remaining.
There have been reported cases of factor 13, 7, and sickle disease causing hematoma formation. So what to do? Spontaneous resolutions have actually been documented. Hence, asymptomatic patients may be observed because sometimes evacuation may cause bleed and infection. With increased IOP, exposure keratopathy, and decrease in vision, you may do a trial of medical management, even systemic steroids. But if progression is seen, a timely surgical evacuation should be done. If caught early, your needle aspiration can be done. It's quick, less invasive, with less risk of infection, and can be done as outpatient basis. But it won't remove your blood clots, for which your anterior orbitotomy would be the better option. You can actually do a subbrow incision approach, dissecting up to the periosteum and leaving a Penrose drain to allow for continuous drainage. If there's no further expansion and non-resolution, you might have to ask your neurosurgery friends to do your subgaleal hematoma evacuation. So what have I learned? Don't let mild trauma deceive you, especially in pediatric patients where it can actually lead to a large subgaleal hematoma with orbital extension, in which case a rapid ophthalmic deterioration may happen. It's important to make that diagnosis, and when vision starts deteriorating, immediately, without hesitation, go for your evacuation to avoid permanent complications. Thank you.
Thank you so much. Our next speaker is Dr. Tengku Ain Kamaldeen, who is a VR surgeon and an associate professor at the University of Malaya Medical Center in Kuala Lumpur. And we'll be hearing on an unusual case of intraocular and intraorbital foreign body. Over to you, ma'am.
Thank you very much, Mr. Chairperson. Assalamualaikum and good evening, everyone. I'll take you through our experience with an IGS-assisted intrascleral foreign body removal. I've got no financial disclosures, relevant disclosures to make, and acknowledgements to all those listed, especially to Dr. Kamala Devi, who finally delivered the foreign body. So we start out with a 21-year-old male foreign worker who sustained a right eye injury while hammering at work with no protective eyewear. So, that's the chipped head of the hammer, and that's a magnet, a round magnet on the hammer to demonstrate that it's magnetic. So what he was doing was he was using one hammer as a fulcrum, a second hammer to hit the first hammer to get a nail out. And hence that came out as a projectile chip of the hammer into his eye. So at presentation, he presented with a 636 vision and 6.6 on the left eye. There was just a conjunctival laceration at the infratemporal area, about 2 mm from the limbus, with pseudos negative, no vitreous presenting. Cornea and lens were clear. AC was deep, just formed cells, no hypopoia, no RAPD. OTS was scored at 4. He received tetanus and prophylactic intravitreal. So it turned out to have a self-sealing 23 gauge size wound, 4 mm posterior to the limbus. And so this was his picture at arrival. So you can see a linear T-shape or T-shape wound inferior to the fovea. Preoperative imaging, X-ray showed a tiny speck of a metallic foreign body, followed by a foreign CT scan. And at the cuts there that you see that it is located just next to the optic nerve. And this was the intraoperative view. Just 24 hours later, you can see the vitreous hemorrhage has increased, covering the linear wound. And this demonstrates the linear wound that you saw earlier. It almost looks like there were actually 2. So we proceeded to do a PPV, and this video shows an intraocular magnet hovering over the linear, trying to get the foreign body out. Nothing, no movements, still nothing, hovering there. We even tried with aspiration, and there were nothing coming out. So we closed up and put gas and lasered. I put C3F8. By day 4, most of the gas has dissipated. So it turned out that it actually escaped through the exit wound. And so this was how it looked like. It was clear enough for us to get a view of the fundus. And you can see the linea is dangerously close to the fovea. And you can see a shining surface there, which I thought was the foreign body. It turned out that it wasn't. And that was the accompanying B scan, which showed what you can't see here, which you can see on the B scan is a hugely elevated macula with a very high echogenic material in the intraretinal. Again, I thought it was foreign body, but and the OCT concur with some intrascleral high density lesions with orbital with some shadowing. We repeated the imaging. Again, it showed an unchanged metallic foreign body there. And again, same place, not changed, temporal to the optic nerve. So we proceeded to plan a multidisciplinary surgery since it's more complex. We cannot remove it from the intraocular path. So we referred the case to the orbital surgeons. We had a detailed pre-op planning, consulting, discussing with experts, including Dr. Ganga and Prof. Gopalingam. And the trick was getting everybody on board to get the coordination on logistics right. And this includes arranging the operating list with the management, the nursing, getting the machines ready, and creating using social media platforms or WhatsApp group to get everybody on board, the VR, the orbital, the neurosurgeons, the anesthetic, the nursing, and the support team, to be mindful not to share identifiable patient details. But it's really helpful because in such a short space of time, you can't quite have a physical meeting, and it's COVID. It's a COVID era too. So this is what we have in our hospital, the image-guided system under neurosurgical. So that what I wanted to show is that's the probe, which is a 20 gauge, just a simple metallic sterile probe. So in theory, you can actually use it in intraocularly, although I've never used it. So what is IGS? Just briefly, it is similar to how a GPS tracking system on the car. So this is cartoon shows how the car sends signals to the satellites, to the control tower, and we get the real-time feed on our handphones. So similarly, this is what it looks like in the IGS. We've got the satellites, the receivers, which is placed below the bed and next to the patient's head. It doesn't interfere with the operating region. That's the control tower, that's part of the machine, and that's the probe, the sterile probe. It talks to each other to give us a screen on the monitor. And so that's our young neurosurgeon who is painting or putting landmarks, recording landmarks feeding it to the system where we've already uploaded our CT scan. And so the landmarks on the nasal bridge and the lateral aspect. So that's painting it. So it's just getting the machine used to it. So that little blue thing is where the pointer is. That's where he's holding the metallic 20 gauge pointer. And this is what it looked like in real time. 2 weeks later, a right orbital exploration, lateral rectus disinsertion, and foreign body removal. So that's
1 minute remaining.
Thank you. That's the inferior rectus sling, that's the sclerobruising, that's the inferior oblique, and that's the foreign body. So it was a boomerang shaped flat, 0.3 times 0.3. It was under the IO muscle. Post-op, there was nothing left. And this is how he looked like. So eventually, the macular edema resolved, and so did the macular edema on the B scan, and there's no longer hypoechoic lesions, and he recovered to 624, between 624 to 645 with no cataracts. 2 months post-trauma, you can see the scar getting more well-formed. So learning points for the surgery: prepare for all possibilities intraoperatively, including failure to locate. It takes a multidisciplinary team effort in this case. Get everybody on board, disseminate accurate and clear information. You need to use the social media if you can. Careful planning, suitable surgical timing, and clarify everybody's role during surgery because it helps to prepare the equipments and get the nursing team involved. So for the patient, detailed informed consent to explain the complicated surgery, high risk of optic nerve injury and visual loss. So that's the recent paper that talks about the role of IGS. Basically, you can refer to it. So thank you to the organizers.
Thank you so much. We will now move on to our keynote speaker for today. And I will be sharing the video. It's a pre-recorded talk, but we also are lucky enough to have Dr. Susan Freitag with us, who will join us for the question and answer session.
Dr. Freytag is the Director of the Ophthalmic Plastic Surgery Services at Massachusetts Eye and Ear. Previously trained at the Wills Eye Hospital and the Johns Hopkins Hospital, she currently directs the ASOPRIS Ophthalmic Plastic Surgery Fellowship. In addition, she is also the Editor-in-Chief of the indexed peer-reviewed journal Orbit. It is our honor to have Dr. Suzanne Freytag deliver the keynote address in the oculoplastic section of the 5th APOTS Virtual Conference 2020. Dr. Suzanne Freytag.
Trauma, 25 years of lessons learned. So these are my disclosures. I thought a long time about what I would talk about today, and my brain kept coming back to a book that was quite popular in the US a number of years ago, titled All I Really Need to Know I Learned in Kindergarten. And I think appropriately for my talk today, all we really need to know we learned in medical school. So lessons learned regarding trauma. Number one, always take a good history. So I present a 16-year-old female who had a brow laceration in gym class 4 days ago. She was sutured at an outside emergency department and had returned there 3 times in the intervening days with worsening pain. She finally arrived at my office, and this was her appearance. It looks like they did a fairly good job suturing her brow laceration, but she was having increasing pain, and there was tense skin and fluctuance of the right upper eyelid. So I took her into my busy clinic and sat her down and said, "Tell me what happened." And the first thing she said was, I was playing capture the flag in gym class. And I'm thinking to myself, oh my goodness, I don't have time for this whole story. And then she said, I spun around and I banged into a friend of mine who's a big football player. And so I said, gosh, are you injured anywhere else? And she said, no. And I'm trying to figure out exactly what happened. So I said, did he get injured? And she said, yes, he chipped his tooth. And I thought, oh my goodness. And so I looked again, and this is consistent with an inadvertent human bite. And so my next thought was, where's the tooth that broke? So the tooth had been found on the ground and was already reconnected by his dentist. So I didn't have reason to believe there was a tooth present. But we opened this, drained several cc's of purulence, and the organisms that grew on culture were Peptis, Streptococcus, and 3 other oral flora organisms. So this was a case of a human bite that had gone completely undiagnosed by the physicians taking care of this patient. They had never asked her, and they therefore had not treated her with any antibiotics. So this was potentially all preventable if someone had just asked her to say what happened. My next case is a 9-year-old girl who was brought to the emergency department with her by her mother with a left upper eyelid edema and erythema for 1 day. She denied visual loss, trauma, upper respiratory infections, or sinusitis. Chemosis was noted on examination, as well as a trace limitation of abduction. And as a result, orbital cellulitis was suspected and a CT was ordered. This is her CT. So there's a BB in her orbit. She failed to mention this to anyone. You can see a little bubble of air anterior to the BB, and this suggests that this is a newly acquired BB. Now, this is another good example of why we get CT and not MRI when there's any doubt about the situation, because obviously putting this metal in an MRI machine could cause her problems. So the question is, what's going on here? So we were able to talk to the patient further, and she explained that her brother had shot her unintentionally playing with a BB gun in their home. It was under the watch of their mother's new boyfriend. Now, they liked this guy because the last string of boyfriends that she had had at the house were abusive to the children, and this guy was actually good to them. And so they didn't want him to get into trouble, and therefore she was willing to hide the fact that this had happened. So there can be many things going on with the patient besides their injury. We may think we're experts, but there are always new lessons to learn. I thought I was a real expert on the topic of domestic violence in ophthalmology. I wrote, as a first-year resident, a paper at Wills Eye Hospital based on emergency department cases titled Ocular Injuries in Battered Women. It was published in Ophthalmology in 1996 when I was a resident. And I confidently worked through my residency, ready to deal with any trauma and domestic violence situations that came my way. One of the most important things we found in this paper was the poor level of documentation of injuries in these women. It might say struck with fist, it might not even say that, and it almost never explained who had done the assault to the victim of violence. It's really important to document this because these women will eventually decide that they want to press charges in the legal system, and they need the documentation. Also, we are their doctor, and we need to recognize and discuss the situation, make sure the women are safe, and help them to get set up with social services if they're not. So along these lines, I got a call from a 34-year-old male. He called in the middle of the day, and the page operator bothered me. I took the call. They said it was important. He'd been seen in my emergency room by me 3 years prior. He and his boyfriend had been assaulted on the street. They were a same-sex couple, and they blamed this on this situation. The boyfriend had declined medical attention because he was less severely injured. The patient, however, had an orbital blowout fracture and injuries consistent with a fist, a blunt injury. He said, "You're probably not going to remember me, so I'm going to try to give you some clues so you can remember my story." And after he told me, I remembered absolutely clearly. He had needed a CT scan. The CT scanner was in the basement of the hospital, and it was very isolated late at night. The female CT technician felt unsafe going to the basement alone with these two men, so she asked the boyfriend to remain upstairs in the waiting room. He had refused and created quite a difficult situation requiring security guard intervention. So I remembered this very clearly. He said the reason he was calling now 3 years later was to collect his medical records. They had lied that night 3 years ago about what had happened. He had been beaten by his boyfriend, and the boyfriend's minor injuries were his defense. He had been the victim of severe domestic violence for 7 years prior to leaving the situation. He needed his records to take his ex-boyfriend to court. And to complicate matters, the medical records were under the boyfriend's name because the victim did not have health insurance. So me thinking I was such an expert didn't figure this out at the time. Clearly the behavior was unusual, and this emphasizes this point. Always speak to trauma victims alone, away from family and accomplices, to give them the opportunity to tell the truth or to ask for help. The next lesson I selected because I asked my fellows, what's the most common thing I tell you over and over again about trauma? And they all laughed and very clearly said, there's almost never any tissue missing. So this is a 35-year-old woman who was in a motorcycle accident. Her face hit the pavement. And I got a call from the residents late at night saying, there's a hole in her brow and her cheek and her lateral canthus, and we need you to come in and help us with a skin graft. And we took our time, we pieced everything together, and as per usual, there was no tissue missing. So here she is on the right side several weeks later, healing incredibly well. And here she is a few months later with a really amazing result. Her brow looks so good, but there was a lesson learned for me here as well. Always clean the wound well to remove the dirt and the microbes, not only to prevent infection, but in this case to prevent tattooing of the skin. So below her right eye, there's some dark pigment, and this was able to be lasered by our dermatologist, and she did great. She was very appreciative, but several good lessons here. There's almost never any tissue missing. And here's a few more similar lessons. So on the left, this is a young man who fell on the edge of a brick step. I got the same phone call, Dr. Freitag, come in, we need help with a skin graft. And we were able to vertically reapproximate this, and there was no tissue missing. On the right side, this was a very severe motor vehicle accident with a ruptured aorta and a ruptured globe. We finally got our opportunity in the operating room at the end of all of these other procedures. Now the tarsus and lid margin are intact, but then we have a deep, deep cut to the bone filled with windshield glass. So we spent a long time pulling out the glass fragments, and at the end we were left with this deficit. And we looked around a bit and we saw a little piece of dark tissue, and we unrolled it, and it perfectly fit into the defect. So again, there's almost never any tissue missing. However, gunshot wounds and some dog bites are exceptions to the rule that there's almost never any tissue missing. So the left slide is a self-inflicted gunshot wound entering the palate and exiting the cheek and orbit. So there is a lot of tissue missing in this exit wound of the maxilla. In fact, the globe was missing as well. The right slide is a dog bite, and there is some lower lid margin absent in this case. But these are very unusual. Usually everything is still there if you look for it carefully. So, and we also want to remember to clean our wounds thoroughly. Another thing the fellows reminded me that I tell them all the time is there is no role for titanium in the orbit. And people may debate this, but I see a lot of titanium madness. I've never put titanium into an orbit, but I've had to take a lot of it out. So this is a 32-year-old man, motor vehicle accident 4 months ago, left orbital floor blowout fracture repaired by a general plastic surgeon the next day. He had no preoperative diplopia or enophthalmos, so it's unclear why the surgery was undertaken. Now, after surgery, he had double vision in primary and all directions of gaze. So he has a severe right hypoglobus. He has restricted upgaze of the right eye, including on forced duction testing. And he had enophthalmos of 4 millimeters on the right. The CT imaging was interesting to us. The titanium mesh is obvious along the right orbital floor. The contour of the implant is not bad. And in fact, when we looked through the whole sequence of scans in the different planes,
1 minute
the placement
remaining.
wasn't bad. But the inferior rectus muscle was badly scarred to the mesh we found out intraoperatively, and this was the nature of his problem. So Dr. Nunnery reported a similar series of patients. This was back in 2009. 10 patients had had orbital fracture repair with titanium mesh. 9 out of 10 had double vision from motility restriction and adherence. 5 out of 10 had eyelid retraction and double vision, and 1 out of 10 had eyelid retraction only. 6 patients underwent removal of their hardware, and he found significant fibrosis and inflammation at least 5 millimeters from the mesh. I prefer porous polyethylene implants for orbital fractures. I use patient-specific porous polyethylene implants on rare occasions when I have a challenging case. These are really revolutionary and becoming easier and easier to get. So CT image data is used by the manufacturer to create a custom implant. Mirror image subtraction technology determines the shape and volume. The goal is to create a symmetric bony volume between the 2 orbits. For very small fractures that need minimal short-term support, such as the one in the drawing and on the CT, which are just little entrapped fractures in young people, I like to use an absorbable 0.075 millimeter gelatin film implant. It's great in kids with these fractures. It absorbs in weeks to months, so there's no long-term hardware present in these young people. So, lessons learned: always take a good history. Speak to the victim alone. There's almost never any tissue missing. Clean the wounds thoroughly. And I don't think there's any role for titanium in the orbit. Slow down and think and go back to basic principles. In the end, most patients are less appreciative of your technical abilities than your compassion and humanity. And wear protective eyewear. Thank you.
All right, Dr. Grover and our panelists, can we have some questions for our speakers?
Excellent session, Akshay. Congratulations to the team for planning it out so meticulously. I think we've had 4 sets of trauma that we have been talking about. One is about the bony injuries and their complications, how to prevent them and how to take care of them. We can spend maybe a couple of minutes discussing all these 4 aspects. Second was regarding the foreign bodies in the orbits, their effects, globe as well as the orbit. The third set was regarding the soft tissue injuries. And fourth was the traumatic optic neuropathy. I think we can spend a couple of minutes on each one of them. We can start with Preeti.
So I just wanted to compliment, I think the Dr. Susan Freitag, I think learn from the basics. I think I'm very impressed with the slides because I think every resident has to be told what to do for a trauma. And I think because usually they are the first ones to see the patient. And I think history is really important, which I keep driving for the last 35 years. Thank you.
Yeah, those were excellent lessons. Very, very basic and well driven home by illustrative cases. So we'll start with the discussion on the fractures maybe. And I would request all panelists to chip in with their thoughts. Preeti.
Yes, sir.
Excellent presentation. I think you drove home the complications that relate directly to the fracture such as the remaining volume deficit as well as the those related to ocular motility problems. And you stress that things need to be done in time. Any incarceration should be taken care of early to avoid any permanent damage to the muscle. And you think holistically about the whole volume. And I think Susan added the same point by talking about the mirroring and having customized implants. She, of course, differed from you regarding the nature of the implant. They have customized polyethylene implants. They can use them. But if you don't have really well customized implants, I think titanium ones, either which are customized or even non-customized one, are quite helpful to us for orbital and especially for orbital floor and medial combined fractures. But you very well stressed that the concomitant associated problems need to be taken care of. Other fractures need to be taken care of so that a holistic view of the volume is taken, and any associated soft tissue problems like the nasolacrimal duct problems should also be dealt with. Now, if you were to give one major lesson, one major carry home point from your talk, what would that be?
I think since my talk was majorly on the bony reconstruction, I would say that reconstructing the orbit along with its curvatures is very, very important. If you have smaller fractures, sheet implants are okay. But if you have complex fractures like 2 or 3 wall and comminuted fractures, then you need to reconstruct taking into account the curvatures, that is the posterior convexity, the medial convexity in the posterior aspect in order to recorrect the enophthalmos. And titanium I prefer in complex fractures. If it is a child with green stick injury with a smaller fracture, polyporous polyethylene is good. But for larger fractures with zygoma, with medial wall, wherein you need tensile strength, then you need titanium because then it can be fixated well and it stays in place, because porous polyethylene for large defects, when there is scarring in the post-op period, it tends to displace.
I think that's very well emphasized. And since we are short of time, we'll just spend a couple of minutes more, 1 minute more on the foreign bodies. And then I think we'll need to quit as the session time is up. We'll ask the panelists as to how they would make sure that they don't miss out on inorganic foreign bodies, because that's the one, especially if it is small, is missed out on the CT scans and can sometimes create major problems. So I'd like to hear Suzanne or Rohit, somebody speak to us on their experience with inorganic orbital foreign bodies. Suzanne?
I think, may I take this question?
Yeah, please.
Just shortly. So inorganic foreign bodies are, in compared to the organic, they are relatively safe because high velocity and heat will make it sterile, and it can, most of the time, it can remain in the orbit silently without causing any reaction. As Dr. Mehboob had mentioned, if it is a small one as inertly staying, it is better to not harm. to anatomical structure of the orbit by doing any orbitotomy, because I have experienced that even I see in the big, in non-organic metal that I confident that I will check out easily, but when I swim inside the pond, it is very difficult to find out, and I have left some of the time. That's why organic, yeah, we have to take out because it is a degrading type of material we have to take out definitely, and we have to search and spend most effort to get out that. But it's non-harmful, I mean the inert one, non-organic type, I would better to leave that.
Doctor, time for the next session, sir, please.
Yeah. So I think we'll close with handing over to Akshay with the final word that a high index of suspicion in organic foreign bodies with an unexplained reaction. Sometimes the wound is just too small, and then look for better ways to do a good close imaging with the CT scan, and you are able to pick it up. Akshay, you're closing, and then we hand over.
So if you want to take 2 minutes, because I spent 2 minutes introducing you, if you want to kind of take up 2 more minutes here, then we can close it.
Maybe we can talk about traumatic optic neuropathy in that case.
Dr. Prem Subramaniam is going to, I think, give a keynote address.
Okay.
Maybe we can just ask Dr. Suzanne to tell that 5 lessons, I think, which is important for take-home lessons for the entire.
I think that's a very important, that has come through video. It is something very good.
Dr. Suzanne?
Suzanne, you can highlight your 5 points.
Sure. Ask a great history. I think the most important thing is talking to these patients alone. You can save their lives by taking them aside and asking them questions that they're afraid to answer or afraid to speak up in front of other people. And it's a simple thing, but it's a bigger picture than just the trauma that they have on their face at the moment. And then gathering our lessons over the years, figuring out what we teach on a daily basis and compiling it, because I think sometimes we're not aware of it, but if we ask those around us, what do you tell me all the time? For me, it's the basic soft tissue, take your time, piece it together. Fractures are an enigma. They're very difficult, and I wish we had so much more time to talk about all of these topics. But thank you all for the opportunity to be here today.
Excellent carry-home point, Suzanne. We enjoyed the talk.
Thanks a lot, Suzanne, for joining us, and really honored that you could join us and share your experience. If there's one thing that you've been changed in terms of practice from what you were a resident and a fellow, in terms of fracture, what you were told, what you think now is a myth, what will that be?
I repair much fewer fractures than I used to. We're taught the textbook, if it's 50% of the floor, or if there's more than 2 millimeters of enophthalmos, they should be fixed. And I rarely fix blowout fractures these days. Certainly the entrapped ones in children go right away. About 10 or 15% definitely don't need to be fixed. 10 or 15% need to be fixed right away. And then there's this big gray zone in the middle. And I tend to follow them, and most of them do fine and opt not to have surgery. So, and this is for the blowout fractures. Certainly the rim involving fractures and others are different, but I see the majority of blowout fractures, and patients do really well without any repair.
Thank you very much.
Can I take the time to ask a few words from Farjad that?
Rohit, we don't have time. We're going to move on to the next session, I think, if you don't mind.
Okay.
Right?
Yeah,
right, Robert and Akshay?
Thank you.
Yeah, we will carry on. We'll discuss
Akshay?
it.
Thank you.
Right. From one teacher of mine to the other, I will now ask Dr. Rashmin Gandhi to take over as the in charge and chair of the neuro-ophthalmology session. And
So thanks, Akshay, for handling the session very, very well. I just wanted to remind the speakers as well. We will have half an hour at the end of the day where we can kind of again go through that. Dr. Rohit, we have still time left for the discussion, which will be immediately after the session. So I request the speakers from the session 1, session 2, and even the session 3 to please stay on, and there we will have the real kind of discussion which can go on. And those people who are staying, we can go on forever, like whatever you want to do it. Right, Ganga? Dr. Ganga, is it?
Absolutely, absolutely.
Okay, so now we'll move on, and as you can see, the clips by one of the young dynamic surgeon from LV Prasad, Dr. Tarjani, was put up, and we'll move to neuro-ophthalmology session, which is again very, very important, and as comes to evaluation of trauma. And I'm sure Dr. Rasmin Gandhi will probably stress on that point, why does optic nerve is so important and where you have very limited tools to examine. Thank you. Dr. Rasmin, over to you.
Thank you. Thank you so much, Dr. Rupesh. And I would like to thank Dr. Ganga and Dr. Rupesh for having this lovely session on neuro-ophthalmology. So I'm joined by Dr. Bikram Thapa from Lumbini Eye Institute, Nepal, and Dr. Anis Wong from Eagle Eye Hospital, Singapore, as the chairs. Let's move on and have our first talk by Dr. Havu Chen. Dr. Chen joins us from China. He's a professor at Shantou University. He's going to talk about the anterior segment trauma in pediatric population. Dr. Chen, over to you.
Dr. Chen, you need to unmute. You need to unmute.
Can you hear me now?
Yes,
okay.
Yes.
Sorry. It's my great honor to join this great meeting. And today the topic, the pediatric anterior segment trauma may be too big for this 7 minutes talk. And I will focus on the small topic that is pre-existing posterior capsule rupture in pediatric trauma cataract. So I have no financial disclosure or conflict of interest. And pediatric cataract, the most common cause of pediatric cataract is congenital, but it may also secondary to some eye diseases such as uveitis or intraocular tumor, or it may be iatrogenic. But trauma is also an important cause of pediatric cataract. However, there's some children may not be able to tell the history of ocular trauma. So this is a first case that she's 4 years old girl, and the chief complaint is the whitening of the right eye for 1 month. It is identified by the parent, and there's no prenatal and birth history is unremarkable, and the girl denied history of ocular trauma. The visual acuity was hand movement in the right eye and 0.5 in the left eye, and the left eye is unremarkable. And this is the anterior segment photo of the right eye, and we can see that there's a white cataract and there's some iris posterior synechia in the 6 o'clock. And also some reveal some vitreous opacity. Furthermore, we can find that there is discontinuity, a disruption here at the posterior capsule. So we suggest that the posterior capsule is ruptured. And so this is the video of this girl, and you can find that there's a posterior synechia here. And the anterior capsule is intact in other region, but maybe disrupt here. And then we separate the posterior synechia. And also we did not perform the hydro dissection, and we used by manual to remove the cortex. So after we remove most of the cataract or the cortex, then we can find that there is posterior capsule rupture here. So after we remove this cortex, then yes, there's the rupture here. Then we implant a 3-piece IOL. And then and then use cutter to cut the posterior capsule at the visual at the central of the posterior capsule. And after 1 month, the visual acuity recovered to improve to 0.3, and after 1 year, the visual acuity was 0.4, and the retina is normal. And there's another case that also a 4 years a boy, and also the whitening of the left eye for 2 months, and the visual acuity was hand movement for the in the left eye, and the cornea and the anterior chamber are all normal, and we can see that the anterior capsule is also normal, but the ultrasound we scan also identify there is a rupture at the posterior capsule, and during operation we can see that after staining we can see that the anterior capsule is intact, and then we use very low bottom height and also low aspiration to remove the cortex, and we can see that there's the vitreous here and suggests that the posterior capsule is ruptured. So it is a big PCR here, and we also use the anterior vitrectomy to remove the vitreous, and then insert a 3-piece IOL. And finally, we use the cutter to remove the vitreous at the anterior chamber furthermore. And the visual acuity improved to 0.3 at 1 week and 0.5 at 1 year. And this is fundus photo of this boy. So we have 2
1
patients
minute left now.
Both at 4 years old and unilateral white cataract, and both of them cannot tell the history of ocular trauma, but the ultrasound scan identified posterior capsule rupture, which suggests that the cause of this cataract is a trauma, and the PCR was confirmed during the operation. And for the first case, it may be caused by restoration because there's anterior capsule restoration and also posterior iris synechia. For the second case, it may be a broad trauma because the anterior capsule is intact, but the posterior capsule is ruptured. So the identification of the PCR before the operation can help us in diagnosis and also planning the operation, which we can reduce the button height and reduce the aspiration and flow, which may be safer for the operation. And this is all my presentation. Thank you very much.
Thank you very much, Dr. Chen, for that very succinct presentation on what to do when you have a trauma. Next, I invite Dr. Arianti for delivering his talk. She's going to tell us as to what should we prefer, CT or MRI in the setting of trauma. Dr. Arianti joins us from a neuro-ophthalmology service, Jakarta Eye Hospital, Indonesia. It's all yours, Dr.
Thank you so much, Dr. Rashmin Gandhi. So today I was assigned to give a talk about the utilization of CT scan versus MRI in the setting of trauma from the ophthalmology perspective. So I have no financial interest to disclose. And as a brief reminder that ophthalmic trauma remains one of the potential cause of blindness worldwide, accounting for over 1 million cases of blindness globally. And it's usually associated with multiple trauma, including the head and facial injury. Therefore, patients often came to the emergency department with additional life-threatening injuries, hindering us from making a thorough clinical examination on initial presentation. In this kind of setting, imaging can help us greatly in identifying presence of ophthalmic trauma and helps us in the early management method. So the role of imaging is to serve as an adjunct to clinical examination in the management of trauma. Several options are available, but tonight I'm just going to be covering on the CT scan and MRI. So how do they usually work? So CT scan utilizes X-rays to produce cross-sectional images of the body. So the end result is an image with a dense appearance or whitish appearance for bony structures, and less dense tissue appear grayish with less detail. So it's more superior for the evaluation of bony structures. But because it utilizes X-rays, it came with the risk of radiation exposure, making it quite limited to be used in certain population, and it has poorer resolution for soft tissue. For MRI, it uses non-ionizing radiation. It uses both strong magnetic field and radio wave frequency in order to manipulate the direction of hydrogen atom. And in the end, we will get an image of MRI that we all know of today. And it's more superior in the evaluation of soft tissue, including the brain tissue and optic nerve, and also periorbital soft tissue. And the usual images that comes with MRI will be the T1 weighted image marked by the dark appearance of fluid over here, and the T2 weighted image marked by the bright appearance of fluid. And one important thing is that there's a fat suppressed sequence in which the fat tissue will be suppressed, and it's superior in detecting periorbital structure. So because it used strong magnetic field, it's contraindicated in patients with ferromagnetic implants and in any suspicion of presence of metallic foreign bodies, because it can be really harmful to the patient. And in the acute setting of trauma, MRI has the disadvantages of it's quite time consuming and impractical. But you can see the difference here between the CT and MRI images. CT scan gives a more defined bony structures appearance, while MRI gives a more defined soft tissue appearances of the periorbital tissue. So we can manage accordingly to each cases which modality should be used. So when is the right timing to order either one of them? CT scan remains the gold standard for acute setting of trauma because it's readily available, it's fast, and it can detect multiple injuries at the same time, including life-threatening brain injuries that needs urgent intervention. While MRI is more reserved for secondary assessment, especially in the subacute or chronic phase of trauma. It's superior for soft tissue and also for non-metallic, especially organic foreign bodies. And in cases with persistent neurologic deficit in TBI with normal CT, or to detect axonal and brainstem injuries. But remember that it's contraindicated in the presence of metal, and certain types of MRI, such as diffusion tensor imaging, has been deemed very superior in detecting microstructural injuries, axonal injuries in TBI or traumatic optic neuropathy. Special cases like CCF as a late complication of trauma might be useful to utilize the CT or MR angio and then continue to angiography. This is a patient of direct traumatic CCF as shown by the MRI images with the great dilated superior ophthalmic vein and congested orbit confirmed with the angiography. We don't have the MR angio in this case, but in terms of vascular lesion detection, CT angiography is a bit more superior than MR angiography. So why order at all? So CT scan can help us in the assessment of trauma because it readily evaluates presence of fracture of orbital wall with its soft tissue involvement. It can also evaluate globe integrity and identify presence of open globe injuries if the patient is deemed impossible to be examined clinically, for example. And it can readily detect presence of intra or intraorbital or intraocular foreign bodies. And it can help us evaluate traumatic optic neuropathy in terms of presence of optic canal fracture or hematoma, or presence of orbital compartment syndrome, and also the acute phase of traumatic brain injury. As for MRI, it can be useful in the evaluation of orbital apex anatomy and as an adjunct in the evaluation of traumatic optic neuropathy and in the subacute or chronic phase of traumatic brain injury. In terms of traumatic brain injury, MRI is a bit more superior in the subacute or chronic phase in which there is a persistent neurologic deficit with normal CT scan. So this is a case of persistent right pupillary mydriasis with normal CT, but MRI showed findings that is compatible with traumatic cranial nerve injury around the right oculomotor nerve in the brainstem. In terms of traumatic optic neuropathy, some findings in the CT and MRI is highly associated with TON, presence of multiple bony fractures and intracranial bleeding, for example, or certain types of fractures, and also evidence of blood in the posterior ethmoidal cells. Certain types of MRI, the DTI, as I mentioned before, is also reported to be quite useful for TON evaluation and prognostic study. Although other studies stated that neuroimaging finding is still inconsistent for prognostic evaluation. In traumatic brain injury, both CT and MRI has a high prognostic value in terms of morbidity and mortality, as shown by these studies. In summary, the use of imaging modalities can really help us in decision-making of ophthalmic trauma and also in the evaluation of traumatic brain injury. And which type of modalities has its own advantages and disadvantages, and we need to choose which one is better in certain types of situation. But the general rule is that CT is more for the acute setting of trauma, as for MRI is more for secondary evaluation. But remember that if there is any bit of suspicion of metallic foreign body, it is contraindicated to order for MRI. So that's all my talk for today. Thank you so much for the Asia Pacific Ophthalmic Society for the opportunity given to me today.
Thank you. Hello. Thank you, Dr. Chen Irawati. And next, it's my pleasure to introduce Dr. Angar Wan. He's an eminent ophthalmologist from Taiwan, and he will be talking on topic traumatic cranial nerve palsy. Dr. Wang, please.
Okay. Thank you for inviting me here. And can you hear me?
Yes, yes, Dr. Wang.
Okay, thank you. Today I'm going to talk about traumatic cranial nerve palsies. And I would like to thank the organizing committee for inviting me here. And I have no financial interest to disclose. And there are about several studies, and you can see that there's one from Korea and one from Dr. Fujiri. And they talk about the preference of all the... Hello? Can you hear?
Yes, sir, go ahead.
Okay. Third nerve palsy consists about 35 to 40% of the case, and fourth nerve palsy consists of about 20% of the case, and you can see that sixth nerve palsy consists of about 35 to 40% of the case. Among the etiology, you can see that vascular etiology is the main cause for the third nerve palsy and sixth nerve palsy, and the trauma underlies about 10 to 20% of the cases. However, for the fourth nerve palsy, trauma may have a more important role. It may consist up to about 60% of the cases. Let's look at the anatomic hotspot for the injury. And for the third nerve palsy, there are two hotspots for the injury. One is the site for exit from the brainstem, and the second hotspot would be the nerve when it penetrate underneath the petroclinoid ligament and penetrate into the cavernous sinus. And these two spots would be the hotspot for the injury. And for the fourth nerve, it has the longest intracranial course for among all the cranial nerves. And so it also have a very slender connection to the brainstem. And this kind of morphology accounts for its fragility and the susceptibility to trauma. For the sixth nerve palsy, sixth nerve, and it also have 2 points for the hotspot. And one is that when it penetrates through the dura, that's what we call the dura entry site. And the other one would be when it penetrates into the Dorellas canal beneath the petroclinoid ligament. These two spots would be the hotspot for the injury. And we know that careful clinical assessment is very important, and it helps to distinguish between a cranial nerve palsy and a soft tissue injury. And it helps the patient to be well counseled and about their prognosis. And in the soft tissue injury, that they may have the diplopia at the initial presentation, since there is pain, soft tissue swelling, and the entrapment of the fat or muscles over the orbital fracture side, and that will cause the ptosis and the diplopia. And However, most patients with soft tissue injury may settle spontaneously or within 4 weeks of repair, and only 5% of cases may have a residual diplopia. When we are doing the clinical assessment, the ptosis, the mechanical ptosis is mostly due to edema and ecchymosis. That will be resolved in days to weeks. However, trauma may also cause a persistent ptosis due to the levator disinsertion. And the proptosis is a common finding after the ocular trauma. And we should look at the concurrent presence of corkscrew vessels, which may imply the possibility of the traumatic CC fistula. And the orbit should be carefully inspected and palpated for any sign of optofractures. And the direct blunt injury to the iris sphincter muscle may cause traumatic mydriasis, which will stay dilated in response to 1% of pilocarpine. On the other hand, mydriasis in the cerebral palsy will constrict with 1% of pilocarpine. And also, that will be very important to careful assessment of the ocular motility, sometimes with force reduction test if required. And it will help to differentiate between a neurogenic and mechanical restriction patterns. And in a case of vertical diplopia, we should look at if there is a large vertical fusional amplitude and a chronic head tilt, which may suggest a long-term congenital palsies. However, if the patient was presenting with acute diplopia with torsional symptom, it may indicate a traumatic fourth nerve palsy. In a case of sixth nerve palsy, we should pay particular attention to the other cranial nerve signs and also the pyramidal tract signs. So the neuroimaging study should be done in all patients to exclude the presence of the optofractures or the brainstem injury, hemorrhage, skull base fracture, or cervical spine fractures. And for the treatment, many patients may adopt a head position that may minimize the diplopia and enable them to continue their daily lives. There are other measures such as patching, prism, and also buttocks, and all are the temporary measures that may help to increase the field of binocular vision during recovery. And strabismus surgery is generally not done within the 6 months to allow for the maximal spontaneous recovery. There are several different muscle operations have been used to treat the chronic cranial nerve palsies, and with a wide range of surgical success rate. And you look at this patient will be a patient with left side sixth nerve palsy and after the traffic accident, and there's a limitation of abduction in the left eye, and he received the transposition of the vertebral muscle, and he recovered well. And this would be a gentleman. He had a right third nerve palsy after the traffic accident, and you can see that there is a limitation of adduction, and he received a periosteal fixation with a large recession of lateral rectus muscle in the right eye, and he recovered well. So as for the prognosis, patients with paralytic strabismus secondary to traumatic cranial nerve palsy usually will have a much longer recovery time, about mean time of 10 months. And the recovery rate for the ptosis and the external ophthalmoplegia after the traumatic cerebral palsy was reported to be 100% and 60% respectively, although this would be a very small case number studies. And the recovery rate for the traumatic fourth nerve palsy was about 44%. And the recovery rate for the unilateral and bilateral traumatic sixth nerve palsy was approximately 62% and 12% respectively. Thank you for your attention.
Next, we'd like to invite Dr. Bikram Thapa from Lumbini Eye Institute, Nepal, to talk to us about optic nerve avulsion.
Thank you. Thank you so much, Doctor. I am audible?
Yes.
Okay. Yes, Bikram.
Respected Chair Rosmin sir, and respected veteran delegates, I will be talking on a rare devastating ocular trauma, that is of optic nerve avulsion. I have no nothing to disclose financially. Separation of optic nerve fiber from the globe at the level of lamina cribrosa or the optic nerve head margin without rupture of the optic nerve sheath or the adjacent sclera is called optic nerve avulsion. So optic nerve sheath and adjacent sclera is not affected in this disease. And it is a part of anterior traumatic optic neuropathy. So it is not a separate entity, it is a traumatic optic neuropathy. The most common mode or cause of the injury till date, according to the various literature, is finger poking and stick injury, but these all are reported in the literature. Why this site is for the site of injury? It's due to optic nerve head is a relatively weak structure due to absence of connective tissue fiber between the optic nerve fiber, as well as absence of myelin sheath around the optic nerve in the intraocular portion of optic nerve and at the optic nerve sheath. So for the mechanism of this rear entity, there is many hypotheses. Among them, most accepted one is the forceful rotation of globe around its axis due to any injurious agent is the cause of the this optic nerve avulsion. Another mechanism is that due to deformation of globe by the blunt trauma lead to the raised intraocular pressure, which lead to the posterior displacement of optic nerve and leading to the this optic nerve avulsion. So these are the two major mechanisms which are hypothesized for the cause of this disorder. So major ophthalmoscopic or fundal finding that we see is vitreous hemorrhage. So in case of dense vitreous hemorrhage, we cannot see anything behind, but that is the one of the commonest finding. Following that is dense peripapillary hemorrhage, which we can see on this figure also. And then the avulsed optic nerve is a round defect at the optic nerve head, which we can see again in this figure, are the common finding, including these other findings. So our case is a slingshot injury case. I have not seen any case in literature, though I may miss some of them. This was the 17-year male from hilly village of Western Nepal presented to us with total loss of vision, flowing injury to right eye with a return projectile from a slingshot while targeting a bird 6 days back. On examination at our clinic, his visual acuity in affected eye was no perception of light, with maximum illumination of indirect ophthalmoscope in a dark room. He has ecchymosis at medial half of the upper lid and subconjunctival hemorrhage in the superior nasal aspect. And on pupillary examination, there was total afferent pupillary defect. The direct light reflex was absent. On fundus, I cannot see anything, so there must be the hemorrhage or media opacity. On USCB scan, there is dense vitreous hemorrhage along with the alteration in the contour of optic nerve globe junction, which we can see here. It's not clearly round. And there is a hypoechoic area adjacent to the nerve. Then we order MRI, but this MRI is not of my case. I lost that image, so it's taken from Sif et al. And it was similar to this finding. There was widening of optic nerve globe junction in this eye, just like this. If you see left eye, it's narrower than this right eye, which is the affected eye in his case also. So cause of no perception of light after blunt trauma, I have gone through the literature and I could find out two common entity, rear entity, that are optic nerve avulsion and optic nerve transection. But as there is vitreous hemorrhage and ultrasound as well as MRI are detecting that entity, so our case is right eye traumatic optic nerve avulsion. Now, big problem is here. What to do? It's a devastating problem. Generally, in acute traumatic optic nerve injury, we give pulse steroid, or in some case when it does not respond and there are indications for optic nerve sheath decompression, we do that. But here the vision is no perception of light, and there is optic nerve avulsion. And
1 minute left.
We don't. Hello.
1 minute left.
Okay, sir. So we, in benefit of doubt, we give pulse steroid for 3 days, but there was no improvement. And then we discharge patient, counseling his about the poor prognosis and nature of disease, and called for regular follow-up, but unfortunately I lost him from follow-up. The optic nerve avulsion should be kept as a differential diagnosis in case of blunt trauma with no perception of light vision and afferent pupillary defect, either relative or the total. Ultrasound B scan is very helpful in initial investigation where ophthalmoscopy is not possible, and MRI brain and orbit confirm diagnosis if we take very thin slice. Pulse steroid therapy and optic nerve sheath decompression are not helpful in its treatment. So take home message from this is optic nerve avulsion is a rare traumatic optic neuropathy which is currently untreatable and has poor visual prognosis. Differentiating it or diagnosing it from other traumatic neuropathy help us in preventing unnecessary treatment and informing the patient regarding it. So any new management that I am interested to know from all of delegates, I could not find that. I want to acknowledge my teachers from Madurai. Thank you.
Thank you. Thank you very much, Bikram. That was a wonderful presentation. We'll move on and we'll go to Dr. Emily Wong. Dr. Wong joins us from Hong Kong. She is a consultant at Hong Kong Eye Hospital. And her main areas of interest is pediatric ophthalmology, strabismus, and retinoblastoma. She's going to talk to us about management of eyelid trauma with special relevance to children. Dr. Wong, all yours.
Okay, thank you very much for the organizing committee to invite me to talk about eyelid trauma with special relevance to children. So today, I hope that my topic will be useful, especially for residents when handling on-call emergencies. So as our previous speakers have mentioned in their excellent talks, overview of any traumatic injuries in ophthalmology include a proper history and full examination. When there comes to be a trauma with eyelid involving children, we must think about some common causes. For example, dog bites, collisions with sharp objects, and especially watch out for possible child abuse. There's also importance in asking about the environment in which the wound occurred. If an animal bite was involved, for example, dog bites, there is a higher chance of involving the lacrimal apparatus, including the inferior canaliculus. In these cases, vigorous cleansing and irrigation of the wound, checking the rabies status of the animal, plus or minus human diploid vaccination and antibiotics coverage is definitely needed. For the complete ocular examination, as a rule of thumb, we need to rule out any life-threatening conditions and also rule out any emergency ocular conditions, which is any associated ruptured globe, orbital fracture, and we also need to have a very careful examination of the wound to invert the lids if possible and do not miss any lid margin lacerations. An overview of common sutures that we use include the 5 or 6 micro to silk sutures that we commonly use in eyelid lacerations. In children, we may also consider some fast-absorbing sutures, as it may be difficult to remove these sutures postoperatively. Vicro Rapid, which is a suture that provides support for 7 days and absorbs completely in around 2 weeks, is a possible option in these cases. There's also possibility of using tissue adhesives, for example, Dermabond, which can replace sutures for skin laceration repairs. These are good choices for children because no needles are needed, and it's also fast acting with maximum bonding strength at 2 minutes. However, we cannot use these tissue adhesives if the wound is irregular or contaminated or involves mobile areas like the hands or the perineum. So I'd like to go quickly through some very important eyelid laceration repairs, especially for residents. So the eyelid anatomy is very important when we are dealing with these sort of laceration repairs. For lid margin repair with no or minimal tissue loss, in children, we preferably repair this under general anesthesia. We always start off by aligning the lid margin first using a vertical mattress suture. In our center, we often use the 6-0 silk, and this goes through the meibomian gland orifices. We keep this suture long for traction. And then we suture the tarsal plates in 2 to 3 interrupted sutures in a lamellar fashion. And we usually use 5-0 vicro sutures here, and as the tension bearing should be at the tarsus instead of at the lid margin. We then tie the lid margin suture aiming for slight eversion to avoid notching. And we try to close the skin with a separate suture, which is either a silk or vicro suture, and incorporate the long ends of the margin suture underneath. We then we might consider using a BCL to protect the cornea against irritation. The lid margin sutures tend to be removed at around 2 weeks post-op, and the skin sutures around 1 week post-op. So in children, if it's very difficult to remove the sutures post-op, there are authors suggesting to use buried vertical mattress techniques in which the sutures are used, absorbable sutures like vicro. And in these cases, the suture does not need to be removed post-op, and there's no problem with cornea irritation. As a rule of thumb, we should preserve as much tissue as possible and avoid excessive debridement, as the ocular anexa has good blood supply, and even ischemic looking tissue often heals. And then I'd like to go on to talk about canalicular injuries, which is also common as a result of trauma in children and young males. It's assumed that any laceration that involves the lid margin and that is medial to the punctum involves the canalicular, unless proven otherwise. It is more common to affect the lower canaliculus than the upper, and if not repaired, it can result in tearing, blurred vision, and irritation. So the principles of repair include early direct anastomosis, usage of internal stents, and proper magnification to repair under a microscope or a loop. We also have 3 important steps, including identifying the cut ends, intubation of the lacrimal system, and accurate approximation of the eyelid margin. So one part, probably the most difficult part with repairing canalicular lacerations is identifying the cut ends. This is facilitated by a probe. However, to identify the medial cut end, it is sometimes difficult. It is most commonly found to be a rolled, pale in the edge, and also circular with shiny mucosa. We can also inject some substances, for example, air, the bubble test, methylene blue, fluorescein, and also water for us to help to identify the medial cut end. We can also consider applying sympatomimetic drops to blanch the pericanalicular tissues or cause retraction of the surrounding muscle fibers. Some surgeons advocate delaying the primary repair, allowing the swelling to reduce after 24 to 36 hours before doing the repair. The choices of intubation include a circular pigtail probe, a monocanalicular intubation, or bicanalicular intubations. If commonly there's only one involved canaliculus, we would prefer a monocanalicular intubation to avoid traumatizing the uninvolved canaliculus. Mini Monoca is a commonly used intubation device that we use in our center. So we would identify the cut ends and insert the Mini Monoca stent through the lateral and medial cut ends, and then suture the lid margins. The advantage is that it only threads through the involved canaliculus, it maintains proper alignment, and prevents stricture. It's also very soft and pliable silicone, and it minimizes ocular irritation.
1 minute left.
We can also use a 24-gauge angiocatheter in cases of very emergency situations where we do not even have access to Mini Monoca. We've used this in our center in a few cases, and it has come out with good results. So it's controversial as to how long the stent should be placed, but it needs to be there as long as the mucosa healing can take place. So at least we put it there for 3 months in our patients. So if there's no proper repair of these lid margin lacerations or canalicular lacerations, it will obviously have a chance of infection and poor aesthetics. For example, lid margin notching and lid position abnormalities like ectropion, retraction, exposure keratopathy, and also tearing. So thank you very much for your time.
Thank you so much, Dr. Emily. And now we move on to the keynote address for this session. And it's my pleasure and honor to invite my mentor and my friend, Dr. Prem Subramanian, who is joining us from Denver. Prem, good morning. I'm sure it's quite early for you. Prem is Professor of Ophthalmology and Director of Neuro-Ophthalmology at University of Colorado at Denver. He also looks after the residence affairs. Prem, all yours.
All right, thank you very much, Rashman. It's a real pleasure to be here and to speak to you today about traumatic optic neuropathy and TBI to some degree, what's state of the art, and I have no relevant financial disclosures. A typical patient who's going to develop traumatic optic neuropathy is here. A young, unrestrained driver runs off the highway at high speed, strikes the forehead perhaps against the dashboard or windshield, loses consciousness for 15 minutes, but then is stable, awake and alert when examined 2 hours later. And no light perception in the right eye, normal in the left, an amaurotic pupil suggesting optic nerve injury, and the rest of the exam is normal. In these cases, traumatic optic neuropathy is a clinical diagnosis. You can be helped by neuroimaging and other studies, as other speakers have shown you, but it remains a clinical diagnosis. So when we are suspicious that this is what the patient has, are there data to guide us as to what to do? It's been over 20 years since the IONTS was published. And what did this study, which was really a prospective case series, tell us? It was not randomized. It included any patient with vision loss within the last 3 days, judged to have traumatic optic neuropathy, and treated according to the treating physician's preference. They could get steroids at any dose the physician chose. They could get surgery to decompress the optic canal or orbit or both, or they could be observed. And so thus it had limited power, numerous confounding factors. It did demonstrate that at least the ONTT type of steroids, 1 milligram per kilogram per day at oral or 1 gram daily of intravenous methylprednisolone, seemed to be safe in patients with isolated traumatic optic neuropathy. And canal decompression perhaps is useful with an identifiable fracture. There was a previous talk on this. I will mention it briefly again in a few moments. It encouraged individual clinical decision-making, whatever that is supposed to mean, right? That's not particularly helpful when you, as a doctor, are facing a patient with a traumatic optic neuropathy. So what can I tell you that we have learned in the interim and could help you? Steroids, corticosteroids, have been suggested because of theoretic effects on neurological function, preservation of axonal health, and then the North American Spinal Cord Injury Study, published in 1990, demonstrated that megadose steroids, 30 milligrams per kilogram loading dose and then 5.4 milligrams per kilogram per hour for the next 23 hours, helped patients with spinal cord injury if given within the first 8 hours. There were then case reports, controversial over the next 15 years, that maybe steroids could help patients with head injury as well. But then the corticosteroid randomization after significant head trauma crash in 2005 was halted early, started in 2001, because not only was there no benefit in those patients, but there was increased mortality. And interestingly, in 2000, 20 years ago, Ken Steinsaper, in a research study in animals, demonstrated that if you crush the optic nerve and then look at axonal preservation, those animals given saline, placebo, actually had better preservation of optic nerve than those who were given very high doses of steroid. So all of this has made me more skeptical. And remember, many patients with traumatic optic neuropathy may have traumatic brain injury as well, significant head injury. So steroids may not only do nothing, they may actually harm them. How likely is that to happen? In a series from Emory University, 326 patients with TBI were evaluated. Now, most of them had come from a rehabilitation unit, inpatient unit, so they were quite neurologically impaired. 8% of them were judged to have a traumatic optic neuropathy, so not insubstantial. If we look at more of a population survey, 200 patients with TBI, no indication as to whether they had a visual complaint or not. Just all 200 in series were evaluated. They were examined prospectively, and only one was found to have traumatic optic neuropathy. So maybe it is a little bit less common if you just take the head injury population as a whole. And we, as orbital surgeons, take care of facial trauma patients. A recent study demonstrated that of over 5,700 facial trauma patients, of whom 19 had vision loss, only one was attributed to traumatic optic neuropathy. So I want you to take away from this that TBI and optic neuropathy can coexist. My colleagues at Walter Reed Medical Center recently published from their trauma database, out of 890 eyes that were enrolled with any kind of vision loss, 20% had some type of neuro-ophthalmic injury, and of those, 79 were optic nerve injury. So again, emphasizing, I think, that when you have a serious brain injury, the likelihood of having an optic nerve injury increases. That's not too surprising. Optic nerve injury was associated with a systemic neurological injury in this study, and worse visual outcomes were seen with any neurological injury. So what should you use these data to help you, or how do you use them to help you when you have a patient with traumatic optic neuropathy? It makes me even more hesitant to give them steroids because there may be an occult neurological injury that you could make worse. There are lots of other things that happen with vision and TBI. There are complaints like light sensitivity, diplopia, reading deficits, and a number of ocular motor disturbances that constitute an entirely different area of study and teaching that I will not cover today. But keep in mind, when you see those patients who have TBI, you're not just looking for evidence of afferent visual loss. They may have significant efferent dysfunction that it's your job to ferret out. So getting back to some of the data to guide us in terms of what to do for our patients who have a traumatic optic neuropathy, we do have some small prospective studies looking at the role of corticosteroids, because you may say to me, okay, fine, you don't want me to give it to patients who have TBI, but what about isolated traumatic optic neuropathy? In a series of 31 patients, evenly divided between placebo and steroids, you can see in the graph here that both groups improved. There's a suggestion that the steroid group improved more, but the error bars, the confidence intervals are so wide that that would not be an accurate conclusion, and you cannot conclude from this study that steroids are better than placebo. Similarly, erythropoietin, a drug that has been studied in a number of neuro-ophthalmic conditions because of its potential to be neuroprotective, has been tried and compared to both steroid and observation. And you can see that although it seemed like erythropoietin, like steroids, resulted perhaps in an earlier improvement in visual function, at the final time point there was no significant difference amongst the three groups. So unfortunately, at this point in time, I cannot recommend any medical therapy for the treatment of traumatic optic neuropathy. I feel that when we give steroids to the patient, we are treating ourselves. We're making ourselves feel better, and we have to remember that steroids are not without risk, even in young, healthy people. Surgical management I'll touch on briefly since others have done this. Optic nerve sheath fenestration we have written about in patients with intrasheath hemorrhage. You need an experienced neuroradiologist to be able to confidently tell that there is in fact hyperdensity within the sheath and that it represents hemorrhage. And like other surgical interventions, I feel that it is best when there is evidence that the patient is having visual decline, ongoing visual decline. So for example, in optic canal decompression, if there is, as in this patient, with a fragment on the left side displaced laterally into the optic canal and compressing the optic nerve, and the patient was visually declining in front of us, we recommended surgery. ENT went in and decompressed that optic canal, and vision loss stabilized and perhaps improved slightly. So here is where I recommend surgical decompression, but I think, again, we have to be careful in treating our patients who have these conditions. The patients who get traumatic optic neuropathy, I alluded to at the beginning, they tend to be perhaps young, reckless. In the study I showed you with the patients with TBI, you saw that there was a big spike of patients between ages 16 and 30, and they tend to be overwhelmingly male. In a study of patients who had the misfortune of having a repeat traumatic optic neuropathy, 12 patients over 18 years, they were followed out to at least a year after their second injury. And all of them, almost all of them, had been given steroids at their first injury, and every one of them had some degree of visual improvement. Maybe not to baseline, but they improved. After their second injury, their vision dropped to the level of their first injury or worse, and unfortunately, despite treatment, medical, surgical, none of them improved after the second injury. So TON leaves the patient with a significant injury. A classic neurological injury model is spinal cord, where you lose the axons, you may preserve some function, but there is still significant axonal loss that the patient suffers from for the rest of their life. Animal models to simulate this have been done with axonal crush. You can do this on the spinal cord or the optic nerve, but real-life traumatic optic neuropathy is a complex injury to axons, to the vasculature, supporting structures, and it occurs because of transmission of force, not because a person comes along and compresses the optic nerve discretely with a pair of forceps. And so much of what we know about traumatic optic neuropathy has been developed from animal models, from crush models, but recently 2 additional models have been developed. One involves the application of ultrasound to the orbital ridge. And this provides energy that goes to the orbital apex, disrupts the axons, and you can see it does a tremendous job. In the treated eye, there are almost no axons or cells left, but unfortunately it works so well that the control eye, the contralateral eye, is also injured. And so that makes it a little bit difficult to know exactly if you're going to do a treatment, whether you are having a significant effect or not. So a more recent development, and we are working on a similar model in the pig, is to take an animal and deliver a controlled impact to the brow. And so here in a stereotactic device, a hammer delivers force to the orbital ridge, and it delivers either a 2 or 3 meters per second impact. And with that impact, comparing to the contralateral eye, there is a definite decrement in optic nerve function that persists over time. And so in graphs that compare the function of one eye versus the other, one optic nerve versus the other, you can appreciate that the function in the control untreated eye is preserved while the function in the contralateral eye is diminished. So I am very excited that these types of models will allow us to better understand traumatic optic neuropathy and to develop better treatments for our patients. Because as it stands now, what would I like you to learn from this? Traumatic optic neuropathy in reality is related to force transmission, and we are developing models to better recreate that in the lab so we can come up with better treatment strategies and validate them. TBI and TON can co-occur. It's not a high co-occurrence. There are also efferent visual concerns that remain poorly understood. But remember, anyone with a head injury and vision loss may have other sources for their vision loss other than TON. I think by and large, TON treatments unfortunately remain unproven, and prevention is the key, especially because patients who get one TON are at risk of getting a second one. Thank you very much.
Thank you so much, Prem. Wonderful talk. And with this, we have come to the end of all the talks in this neuro-ophthalmic session. We, I think, have a couple of minutes. So any of the panelists, if they have a question for the speakers or any other comments, because there have been overlap of the talks with other specialties as well. So Rupesh, would you like to have some questions thrown in?
No, I think the talks were great. And definitely, I'm sure there are a lot of questions which may be there from the floor. We can continue to discuss, and let's see if we. I'm just checking if there are any questions. So there, I'm just picking up. I'm just picking up some questions, Prof. Subramaniam. They have written there, what type of eye protection is adequate to avoid traumatic optic neuropathy?
Great question.
And I'm sure you and Marcus have worked a lot on this thing. If you can share some of those work. Yeah.
I put a picture of eye protection, but really it's going to be more head protection because you have to protect the brow, right? And so a helmet when someone is riding a motorcycle, and then when playing sports, making sure they're, just as you've advocated for prevention of eye injury, but also a face shield to avoid objects coming and striking the brow. So these types of protective devices. In American baseball, you can see now that some of the players are wearing this shield that comes across in front of part of the face to protect them from that 100-mile-an-hour hard ball coming at the face. So these types of protective devices, I think we have to be creative to help our patients.
Thank you. Thank you, Prof.
In the initial session, there was also a talk where a speaker recommended optic canal decompression. And there were some recent reviews where he also quoted that the optic canal decompression seems to be now coming in vogue. What's your impression of that?
Sure. There have been some series that have been published, primarily in the ENT literature, of seemingly very good outcomes in patients who have had optic canal decompression. I think the morbidity of it has gone down, and I still am most impressed by the outcome when the patient is awake, alert, and you can document that their vision is still actually declining, because that to me is the best evidence that there is ongoing compression. Again, in the hands of an experienced surgeon, I think the risk is lower than it used to be, but we still need to be careful. It's general anesthesia. It is right there by the carotid artery. You need skill and judgment in order to do this.
Is Farzad there? Is he logged in?
Yeah, Ganga.
Do you find any indicators of which patient is likely to do well with your surgical decompression versus which patient is not? Could you share your learning curve? And what do you really tell or promise your patients when you embark on this journey of optic canal decompression, please?
So speaking from the evidence-based aspect, we cannot say which actually mode of treatment and observation is the first line you can follow. But for some subtypes of the TON, we may prefer to do something. First of all, you should consider that every treatment you're giving patient may have some side effects and unwanted effects. I may give you some examples. If you see patients after optic canal decompression with 20 or on 40 visual acuity, the patient may drop in visual acuity after OCD. So it's very surgeon dependent. So I realized that the ideal patient for OCD may those that did not improve in visual acuity after 1 week, despite taking, neuroregenerative or neuroprotective agents. That's my concern. As you know, I've been working on erythropoietin and EV for like 10 years, and we found that we have, cytoprotective, neuroprotective properties of erythropoietin in toxic optic neuropathies and traumatic optic neuropathies. All the size of effect is not that much dramatic. So after the failing of that, and in those with severe visual loss, I prefer to do OCD to give a chance, especially for those with bilateral traumatic optic neuropathies. I need to say that in contrast to some beliefs that if you have optic canal fracture with bone impingement on the optic nerve, I've operated many of these patients. I personally did not see that much improvement after that thing. If the bone enters the optic nerve, even if you're doing a very delicate, very sophisticated surgery, after the surgery, I didn't see that much improvement among these patients, although it's an indication for doing OCD in these patients. So for now, I usually consult with the patient. I say there is no definite treatment, but if you want, there are some suggestions like erythropoietin, like optic canal decompression. Considering the general condition of the patient, I may advise the patient and actually offer the patient with these treatments.
Those are actually really good points, and we have to keep in mind there are two different reasons you might do canal decompression. One, where, as you mentioned, there's a fracture, maybe piece impinging on the optic nerve. I agree. Sometimes the trauma was so severe that caused the fracture that removing that bone is often not going to do any good. And then the second is the potential benefit of giving more space to the optic nerve in the setting of trauma if there may be some swelling or some other process within it that you're trying to relieve with the canal decompression. So two different reasons to do the procedure.
Sorry, one more pointed question to both of you. There was a beautiful presentation of a case report at WOC. I know Prem, you were there, not Farzad, you were there, where they invariably combine not just a bony optic canal decompression, but given the trauma or the edema to the nerve, they combine it with an optic nerve sheath fenestration at the same time. Your thoughts on that, please. And Farzad, would you do both or one? And Professor Prem, your thoughts, please.
Yeah, Prem, you may start, or
sure.
Otherwise,
I'm happy. Sure.
Comment.
Okay, so just quickly, Ganga, I would be very hesitant to do the optic nerve sheath fenestration as well, unless there was clear indication that there was significant disc swelling or intra-sheath hemorrhage. I don't feel like that's going to give the patient great benefit. And in fact, if you're doing a good canal decompression, then giving that space for everything to expand should be adequate to relieve whatever pressure you think may be there on the optic nerve. So I would be unlikely to advocate for doing both together.
Thank you.
So, Ganga, about opening the dura during the optic canal decompression, you know that it's kind of practice when you are doing OCD, you may open the dura to let the CSF coming out, and some believe that opening the dura may relieve much more pressure and relieving the, compartment syndrome. Personally, I didn't see benefit of that, and I have seen CSF leakage for a while after operation. Unfortunately, I never saw meningitis after OCD and opening the dura. For a couple of years, I never do it again. I just recently saw a publication that compared those that the dura was open to those that they did not open the dura. And interestingly, among those that did not open the dura, the visual improvement was higher than those that the dura was opened. So I can say that during OCD, the optic nerve that's exposed, you do not need to open the dural sheath. But in terms that you go for optic nerve sheath fenestration from other approaches, I agree with Prem. You do not need to go for that unless you have a rational like intra-sheath hematoma or something like that. That you need to very clearly show that hematoma is compressing the nerve.
Thank you. Over to all other section chairs, please.
Thank you.
And
yeah. So basically, yeah. So thank you, Dr. Rasmin, for having a wonderful neuro-ophthalmic session. So maybe at this stage, I can, if I can invite all the session chairs. Dr.
Can I bring a question if I have time?
No, we are going to bring up all the questions. There are a few more questions there, which are there. Yeah, we'll bring up.
Can I bring up one challenge, one debate?
Yeah, definitely. Just give me a minute. Give me a second. Give me a second, Farzad.
Yeah.
Yeah, let me invite everyone. Kendrick. And we have from session 2, Dr. Mohan Rajan. And from session 3, Akshay, are you there?
Yeah.
Okay.
Yep.
Now we have another 15 minutes for additional discussion. But as now we are talking about all the sessions, so I really request all the panelists and the session in charge to keep in mind that we'll probably need to kind of donate a little bit of time to every other people so that we cannot be just going into too depth of each topic. Maybe I'll just, before I give it to Farzad, there is a question for Dr. Emily, and then we'll go to Farzad. So Dr. Emily, they have asked a question about use of 24G catheter for canal laceration, the technique, and which they can use. And after that, Dr. Farzad, you can pop up the debate. Thank you.
Okay, so thank you for the question. So in our center, we've encountered situations where there's an emergency and we couldn't find any pneumococcs in this operating theater. So we tried using the 24 gauge as usual, use a probe to find the medial and lateral cut ends, and then guide the 24 gauge catheter in, then take out the choker, and then we repair the limb margin suturing as usual, and we fixate the 24 gauge catheter with micro sutures. and we cut off the yellow bit of the catheter in the end. We leave that in situ for around 3 months, as you would do with a mini monoca. And the results are actually okay with this technique. But obviously, if there's a stent possible or available, we would prefer using a proper stent for these canalicular lacerations. And this is only for a laceration that involves a single canaliculus instead of by canaliculus.
Excellent. Dr. Ganga, any points before you can ask Dr. Fazad to start the debate?
No, I agree that, I mean, any canalicular laceration should be repaired. If you don't have medically grade approved canalicular intubation systems, whether they are monocanalicular or bicanalicular, and I have a personal bias towards bicanalicular rather than monocanalicular systems, then you can improvise. And I think a lot of under-resourced countries make do with what they have. The important thing is not just the stent material, but the duration and how well you're able to anchor in a child who's more likely to irritate and pull out a Penflon stent, for example, which is sutured to the eyelid. So it's not just the technique, but the duration as well.
Dr. Fazad?
So, sometimes we have multiple facial and cranial fractures. At the same time, we have TON. And what I want to ask the panel, what do you do in this situation? You have decreased visual acuity in one or both sides because of the TON. You have unstable fractures, and you need to repair those. What do you do? Do you wait for a while or not?
I think Dr. Ganga is the best person to answer
Akshay and Preeti and Dr. Ashok Grover.
Yeah.
And yeah.
I think that's very apt, because that is exactly one of the other questions for Dr. Preeti as well on the list.
Yes, so if there is a traumatic optic neuropathy and patient is on treatment for the same, I would prefer to wait for the fracture repair for some time till the edema comes down, because sometimes when you're moving the fragment, you can, there is a chance of, tripping the optic nerve on the other side. So I would like to wait for these patients at least for a week or 10 days.
Excellent.
Right. And Dr. Preeti, there is a similar question of when there is a complicated orbital or a NOE fracture, along with soft tissue fracture, what are the things that you consider before deciding whether you can do it in a single setting or multi-staged? In probably this would mean in terms of orbital reconstruction along with soft tissue.
Yes. So this is a practical problem that we have, because when there is a lot of soft tissue injury, the patient comes to you in an emergency. At that time, the patient may not be financially prepared to undergo the orbital fracture repair also, because the implants are expensive. It needs a larger and longer time for surgery. Secondly, the surgeon may not be equipped with the expertise. Usually soft tissue repair can be done, but many of the surgeons are not very comfortable repairing zygomas and NOEs also. So if you don't have the right setting, then I would say that protect the globe first. So if it is a very large laceration, you will have to close it. The advantage of doing both together is you have all the wounds open, you have a free access. And therefore, if you can do the bone and then do the soft tissue, it is the easiest thing to do. But if you don't have the facility, if you do it in 2 stages, then you will have to undo what you have done previously in order to expose the fractures. Always doing it primarily both together is advantageous.
Right. Thank you. Another question related to traumatic optic neuropathy, and I know this is, since traumatic optic neuropathy is probably the most controversial topic that seems to be getting most questions. Dr. Farzad, in your series where you performed decompression, and also Dr. Prem, you highlighted the utility of different agents like erythropoietin, steroids, and none. How important is the timing of intervention from the duration between the onset of injury and the onset of treatment? Because whenever you compare different modalities, that seems to be a big confounding factor. How big a role is that confounding factor?
So I'll start. Akshay, that's a great question that goes between the theory behind treatment and the actual practical matter of doing it. And so in terms of potentially neuroprotective agents like erythropoietin, the animal studies would suggest that maybe you have up to 2 weeks before apoptosis is irreversible and that treatment after that is not going to do any good. Theoretically, treating earlier should be better with something like that. Steroid, if you believe that you're mainly treating swelling, is going to be an early treatment. I think the neuroprotective effect of steroid is probably quite minimal. And then if you're going to do surgery, it's a matter of whether you have a slowly developing compressive process, whether you are trying to relieve compression that was created at the time of the trauma. So to answer your question, I would say that theoretically, we should always treat as early as possible, because you are going to ideally reverse whatever injury to the axon has occurred and tell the axon to start to heal, to reverse the apoptotic process. But in practical terms, I would say 2 weeks tends to be a cutoff beyond which any of the treatments that we prescribe are probably going to be ineffective. And Farzad, I'd be very interested in your opinion on that.
Just an interesting observation. We are all ophthalmologists looking from the front. Professor Prem Subramaniam is coming from behind. And look at his slide background. You'll realize he's looking at the program from behind, like the David Apple view.
That's what I was thinking. Mine and Dr. Subramaniam are laterally.
Truly is a neuro-ophthalmologist. Sorry.
I was saying mine and Dr. Prem Subramaniam's slides are flipped laterally. I don't know. Need to fix it.
Behind, the hindsight.
Hindsight. Okay, we need to move on, and because we have other couple of sessions to cover, are there any?
Can I answer, Prem, please? Can I answer the question by Prem?
Yeah, please. Yes.
Yeah, actually, when I provided the protocol for APOTS in 2009, when I started project of the using APOTS in different toxic and traumatic optic neuropathies, I considered that 3 weeks because of my past experience about that. And I may say you that surprisingly, especially for toxic like metanol toxicity, when you give the APOTS, even after 3 weeks, you are seeing some visual recovery. It's very interesting. Even when the patient develops obvious signs for optic atrophy, still we are seeing some effects of APOTS. I agree with Prem that APOTS is supposed to hold the BCL2 and caspase-3, the signaling for the apoptosis. That's the critical time for our disease, that we prevent them from the apoptosis. But it's very interesting that APOTS has shown some effect even after that. We have shown that both in animal model and in human, and it's very interesting. So I may say, even after 3 weeks, I provided the 3 week window period for giving APOTS. But even after that, you may try it because it's quite safe, and you may try it. It deserves to be tried. And yeah, it's about APOTS.
Thank you.
Yeah. Akshay, are you done with your questions? Because we just try to get back to maybe anterior segment a little bit from Kendrick.
Sure.
Yeah. So, because I know this is also quite important, and then we are just trying to cover all the sections in this thing.
Yeah.
Kendrick,
I think it's enough evidence that neuro-ophthalmic meetings can probably go on and on and on and discuss the same thing.
No. There are so much of work to be done, and I agree with Prem what he has shown the animal experiment, because if I get into that discussion, it will never end. It's so exciting what Prem is doing there. But amazing, I think, everyone. And from anterior segment, I think they have covered almost everything. I think there is a question there from the floor, which we'll try to answer. And someone has recommended, again, it is going to the oculoplasty, but maybe one of you can answer that. Is the IGS would interfere the nasal endoscope if we need to perform any surgery involving posterior orbit, perhaps? This is for Dr. N.
So I think, is she around?
Yes, I'm around. Hi. Sorry, what's the question again?
Akshay?
Yeah, she said, would the IGS interfere with the nasal endoscope if you were to use probably the navigation through the orbit and the endoscope from the nose? Would it interfere with each other if you're operating in the posterior orbit through an endoscopic approach, perhaps?
No, I don't think so. So because it's quite flexible. So the IGS that we had was just a single cylindrical probe. That's all. So so while you're doing it, I think you can actually do it simultaneously. So you shouldn't. It's just a 20 gauge. It's almost like our 20 gauge vitrectomy, except it's just a single probe. So
right.
I don't think you would.
And Dr. Preeti, I know you have a lot of experience with navigation. How about it using endoscopically or through a simultaneous approach?
In fact, navigation was first used by ENT surgeons before we started using. So it is very easy to use IGS while doing endoscopy. You can use the navigation screen itself as your endoscopy screen. And most of the instruments that are used, you can make it navigable by attaching the eye tracker to that. Only thing, ergonomically, it becomes a little heavy, but it is fantastic to do endoscopic surgery with navigation.
So can I make a comment here for IGS?
Please.
So IGS is great for, hard tissues like bone, but when you're doing with moving soft tissues, it's not that much actually accurate. Especially when you're doing in the brain, when we are doing something inside the brain, like the transcranial, transnasal approaches, the skull-based tumors or something, it's okay because it's stuck over there. But when you're doing something like lobe that's moving, it's very, very hard to understand is it the same place you want to do or not. And even though I used IGS for orbital tumors and like apex or something, I understood that sometimes you cannot get the thing that you're looking for at the same point that the navigation is showing you. So for soft tissue, take great care. And MR, I'm not sure if you are using CT or MR or both, the blend one. But I usually advise for soft tissue to use MR. You need to register MRI for the IGS, right, and CT scan. So,
yes,
but it was great. Thank you for presentation.
Right. And we have one last question for Dr. Syed Mehboob Qadir. Would you recommend, other than going for an open approach in external foreign bodies that have penetrated into the in facial injuries, if there's a foreign body in the sinuses, would you think of using an endoscope, or what are the other factors that you consider when you decide whether to go in to remove or to leave behind a metallic foreign body? Is Dr. Mehboob here?
I think he's left because he has to go on a long drive for another project.
Then I'm going to leave that question to you. Or
yeah,
sure.
Sorry. Can I ask a question from Dr. Parolan?
Please.
Yeah, it was a very interesting case actually. That subgaleal hematoma extending the orbit was great actually. Thank you very much. So I wanted to emphasize and make a comment on that before explaining that travel of the hematoma inside the orbit. We need to take care that we have no subtle roof fracture. You need to do HRCT before doing that. So I'm not sure if you are doing HRCT for any pediatric trauma or not.
I think in our institution, we don't routinely do that. So that's a good point, Dr. Farzad. But when we double checked the scans, there was no high suspicion for any of the root fractures. That's why we were quite confident to do the needle aspiration approach when we did the evacuation. But that's very good. Thank you very much.
So do you have any comments about the type of the blood that you aspirated through the orbit? Was it like clotted one, or it was, liquefied and degenerated RBCs?
Yeah, so actually it was dark blood, but it was quite liquefied. So we were ready to do a anterior orbitotomy in case there was nothing that we aspirated. But fortunately, when we found the lobule, there was a gush of blood, and it was just easy to aspirate without any resistance. So we just proceeded with that technique.
Exactly. It happens exactly after that the clot is resolving. That's very good point. Thank you.
Yeah, we are coming to the close of the time, please.
Right. Just one more question to the neuro-ophthalmologist. With so many, multiple confounding factors, do you ever do you think there is any role? I mean, at the risk of sounding ignorant, at the risk of, do you want to go with an all guns blazing approach, erythropoietin with steroids and a decompression in a optic neuropathy? I know there is no class 1 evidence in a in a placebo compared randomized control trial for each one, but is there any benefit or is there any merit in trying to salvage any vision with everything possible in the same patient?
I don't think it's a good idea to shotgun the patient with different kinds of drugs and the surgical things without any scientific basis. But I agree. Actually, it's my protocol. I give erythropoietin, and even if I go for OCD, if it's not in a research project, I usually use erythropoietin at the same time. So, but about corticosteroids, we have enough evidence, as Prem mentioned. We have CRASH study, we have Stein-Sapir's and Dr. Bob Goldberg's study that's showing corticosteroids, even they are not beneficial. One RCT showed that it's not better than observation. Even it can actually increase the mortality of the patients. So I don't think it's a good idea to give high dose steroids in the patients. I'm aware that many of the colleagues in different parts are giving everything, like high dose steroids, erythropoietin, OCD, everything, but brimonidine drops, everything. But it's not a good idea to give a cocktail or something like that to every patient.
Yeah, hence the question, because many times we come across.
Akshay, time is up, please.
All right.
No, Rashmi, please go ahead.
No, so I just wanted to echo what Dr. Patel said, that steroids, in fact, there is a clear now thinking that not only that it does not help, but in a higher dose, it might reduce the neuronal survival of the optic nerve. So you might be harming the patient by giving a mega dose from the optical point of view as well.
Yes, thanks.
Okay, so I think that brings us to the end of day 1.
And Akshay, thank you very much, and really amazing. And I'm sure this will continue for the whole night if we continue to discuss. So I hand it over to Dr. Ganga for concluding remarks. But before that, we'll just get a very brief clipping from Microvision. Navneet, you can just quickly show a very quick clip, and then we give it to Dr. Ganga to conclude the day and give a summary. Thank you very much, and really amazing. I'm sure this will continue for the whole night if we continue to discuss. Hand it over to Dr. Ganga for concluding remarks. But before that, we'll just get a very brief clipping from Microvision. Really amazing. I'm sure. Hand it over to Ganga for concluding remarks. But before that, we'll just get a very brief clipping from Microvision. So again, the clips, and with that, we'll hand over to Dr. Ganga for wrapping up the session, and he will maybe Navneet, you can stop here, and
Dr. Rupesh, you have to tell about the quiz also.
Dr. Ganga will say about this. Maybe you can just leave it at that slide, and then Dr. Ganga can take over from there. You can leave it at that slide.
Are we on?
Okay. Yeah, Dr. Ganga, over to you.
No, I just wanted to thank everybody for putting the first day program together, keeping ourselves on time, which, as far as I know, has never happened in any webinar before. So hats off to the moderator, hats off to the section in charges, hats off to the chairpersons, and bigger hats off to all the speakers. A special thanks for all the keynote lecturers. Despite the time, for Prem Subramaniam, it was probably like 5 in the morning. Probably he woke up, brewed some coffee, and dressed up in his bow tie, and ended off for the beautiful session. Thanks to Prem, Dr. Suzanne Freitag, for really giving us not the textbook lecture, but really sharing with us the nuts and bolts of good clinical medicine, which is the reason why we all went to medical school. So thank you, Suzanne. Mohan, as always, was dynamic with his wonderful surgical skills and escapades and teaching us good principles. And Professor Christopher Liu for actually teaching us that he'd never ever give up an anterior-segment bad trauma. If there is potential in somebody who's lost both eyes, there is still hope, although the technology is still evolving. And this is just to showcase a number of countries which really were represented on day one today. And although COVID actually brought to a standstill all physical meetings, we're talking about social distancing, actually the webinars actually have brought us even closer together. This probably would have never happened otherwise. And I think really bringing people and experts to share experiences from countries across the globe, not just Asia Pacific, this is just a spread of the countries that have been represented today. Dr. Rupesh would like to instruct everybody that we will be giving you a link for a feedback form for days 1 and days 2, for those of you attending days 1 and days 2 separately. And based on the feedback form, which I think Dr. Akshay and Rupesh are working on, you will be able to generate a certificate for participation. And you've seen the value of the APOTS clips that were shared and contributed by Vivek and Tarjani and quite a few other people as well. We are looking forward to sharing a basic template with every one of the speakers and chairpersons, where in a very simple bite-sized piece, you should be able to teach us some great take-home messages. Tomorrow, we are going to look forward to the ophthalmic trauma quiz, and I'm going to let Dr. Rekha say a few words on the slides. Turn your microphone on, please.
Dr. Rekha?
Yes.
Yeah, you can speak about your quiz.
Am I audible now?
Yeah.
Yes. Thank you, Dr. Ganga. Tomorrow we have an exciting ophthalmic trauma quiz, and I just want to tell it's an half-an-hour quiz, and which is on myquiz.org platform, and you will have 40 questions, including 10 rapid-fire questions. There are 8 rounds, and after every round, there are break questions. So which are non-trauma questions, non-academic questions, which carry no points. And we have created 2 rooms, one for trainee who are undertaking some training in the form of diploma or degree or maybe medical students. And the other room is a room which is already those who have completed their degree or diploma. So we have 2 rooms with the names Messi and Ronaldo, and different codes are there. So please enter your room as per your academic qualification. And the codes will be shared tomorrow morning on the APOTS quiz.
Please tell them how do they register for the quiz again, please.
Yeah, they have to register on the phone number, which is shared on the flyer ophthalmic trauma quiz. The phone number is 99866 92097. So register here, pre-register for the trauma quiz, and then you will be given codes. And as per your current qualification, enter either Ronaldo team or a Messi's team. And
can they register in the last minute, or do you want them to register today?
That would be great if they register today, 11:30 Singapore time, and that would be great. And by now we have over 100 delegates who have registered. So that is a good number, and we look forward to more delegates participating in this quiz. By tomorrow, I hope we'll have an exciting...
So can we say that by the end of second session tomorrow, they should have registered if they want to participate, correct?
Correct. Okay. And the exciting prizes too.
But those prizes are suspense, right, Dr. Ganga?
Yes.
Well, I don't know what the prizes are.
Anyway. Suspense for me too.
Prizes, that is a good news.
Right. So anyway, so that is of course the tip of the iceberg and the grand finale. But we have an exciting program tomorrow. We, for the first time ever, although we did have that in 2016 and 2018 meetings, a section exclusively on allied health, the role of optometry, orthoptists, ocularisti, and in their role in ophthalmic trauma, followed by a great session on retina, chaired by Dr. Azad, and in charge is Dr. Amira Wan. Wonderful speakers, including a dynamic talk on sympathetic ophthalmia. And we are going to have a nice global perspectives chaired by Professor Natarajan and Dr. Huayan, Dr. Paisan, our presidents and vice presidents, with star speakers, starting off with Dr. Rupesh Agarwal, telling us where we are in terms of data collection for Asia Pacific through iGates and where we are now, what has been accomplished, what we need to do. Dr. Professor Graham Holder, who's going to talk to us about the role of electrophysiology which was a very sought after topic in the previous trauma meetings. Dr. Bob Masoli is going to talk to us about damage control ophthalmology. There is a new term that I learned in the past few months after interacting with him. He's going to teach us something about damage control ophthalmology. And Dr. Talma, who gave a beautiful talk on WOC, is going to share with us our African perspective. And we're looking forward to a nice, healthy collaboration with APOTS and the African subcontinent. And of course, the father of modern ophthalmic trauma, I dare say, Professor Ferenc Kuhn, who's going to talk to us about his journey. And to welcome you all tomorrow, we're going to have Professor Caroline Chi, and then hand you over to the two tough moderators. Just be careful of Dr. Akshay Nair. Huh? He's not just scientifically strong, he's physically strong as well. And don't get misled by Dr. Kendrick, she's gentle demeanor. Thank you all very much. Dr. Natarajan, would you like to say a few words?
Yeah, so thanks a lot, Ganga. I think I can just see the real excellent teamwork and really headed by you and Rupesh and Kendrick and everybody. I think the list is big. You can see it in our virtual conference group. And special thanks to Ashok. And today happens to be Navneet's birthday. So on behalf of APOTS and the entire faculty, I wish Navneet, can you come on the screen? Now, Ashok, can you allow Navneet to come on the screen?
Yes, sir, I'll allow him. Yeah.
Yes, sir. Ashok and Navneet, and I think yesterday in a private meeting, Ashok did a birthday song, but I couldn't create myself the birthday song. But we wish
Yes,
my
sir.
person and Navneet a very happy birthday.
Thank you very much, sir. Thanks a lot, sir. Thank
We
you.
will make you all an honorary APOTS member.
Oh, that's fine, sir. That's nice.
I think they can become a corporate member, which we are looking at. The micro-session, the people will pay and they will enjoy it, right?
Thanks a lot, sir.
Thank you. Thanks a lot. And I think I thank everybody and I did that. And I think I'm very happy that I have an excellent team of Ganga, Kendrick, and Rupesh who are allowing me to lead. And I didn't do anything except sitting here and watching and learned a lot from a lot of basic ophthalmology, which I think otherwise I remember Dr. Badrinath scolding me that, hey, come on, you are a veterinary surgeon, but please look at optic disc and other things. But now I learned from Ganga and Akshay, right from the lid to the back, I think we see an excellent talk by Prem. And I think really it was great. I think this particular Asia-Pacific ophthalmic is teaching me how to be a like globe means of the globe of the eye and as well as the orbital and the entire orbit. I think as a surgeon, and
Brain as well. brain also. Prem has covered the brain also.
Yes. Yesterday, Ganga was operating on his birthday, the surgery up to the brain, and even Akshay was doing that. He told me tumor. So I think it's great. I think it's a great learning, and I'm really happy. I don't have words to express the learning. So it's really wonderful. And today is India for I think the rest of the 20 countries. I think I want to say on Asia Pacific, we had a great teacher, Dr. Sarvapalli Radhakrishnan, past president of America of the India, and his birthday is celebrated as the Teachers' Day, and Navneet Kumar has joined that, and it's great on a Teachers' Day. I learned a lot, and in spite of being a teacher and how to teach was a great session by every speaker today, and I wish we are increased. I think the statistics says few thousands have logged in the webinar, few thousands in Facebook, and few thousands in YouTube, and we're also going to do post meeting, sending them mails. It's not, I don't use the word marketing, but teaching mails will go. I think I suggest we should have each session separate mails go to the separately so that whoever is interested will go through Orbit or neuropathy or oculoplasty or retina like that. Great, Ganga. I think it was a great beginning. I think the fifth veterinary, it looks like in spite of we have done a few hours sitting here, but I think I should say I didn't get bored. And you can imagine I asked for some slides and I got some slides from already.
Actually, I wanted to say, if you keep mentioning my name, this is the team which was working behind it. I was keeping it for tomorrow, but I couldn't resist the temptation of interrupting you. Just to show that the kind of people who have been together.
Led by you, and and that's what I wanted to say, because I'm telling your name because you are the taskmaster, and I think the hard work which Dr. Mukherjee has mentioned, many speakers have mentioned, that you have kept up the time only because of you and the entire team behind what you have put in the screen, and the heroes behind the screen are Navneet, Ashok, and who's the other third guy? Ashok.
Amit and Anupam, sir.
Yeah, so they are all the people behind. I think sometimes I was wondering how come we are teaching people to keep up time. But I know that everybody, in spite of that, telling 1 minute, the people were extending few seconds. But we are absolutely.
Sir, your time is up now, sir.
You're a true professional. Thank you very much for everybody. See you all tomorrow.
See you all tomorrow.
Bye, everyone.
Yes.
Anupam, close the webinar. Close the webinar.
To keep up time. But I know that everybody, in spite of that, telling 1 minute, the people were extending few seconds. But we are absolutely.
Sir, your time is up now, sir.